corner will start with
Very, very good morning to all and welcome to CardioCon 2023. Slide please. No. Okay, sir. Yeah. So the first topic which is related to the in-stent restenosis and the debate is on the drug-eluting balloon versus the stent. Now the case is already on the podium, on the floor, and this is the 55-year-old male with past history of PTCA and presented with ISR, and what will be the best strategy for the revascularization. And I have to talk about the paclitaxel drug-coated balloon-assisted imaging, which is the preferred revascularization. Now we all know that the restenosis when the after the stent proximal and distal 5 mm more than 50% stenosis is called ISR, and several etiological factors play a role in the ISR that is related to the patient, procedure related, and the lesion itself. If you see the patient related, that diabetes or any chronic comorbid conditions play a role. The procedure related is really useful things, because the procedure like if stent is under expansion, long stent, or any geographical mismatch, residual plaque at the stent edge, these are the things which we can really find it out, and we can plan the treatment, and that I am going to show in the imaging. And the lesion related factors like long lesions, stent bifurcation, especially osteal lesion like this, and the long lesion like which is in our patient. So these are the culprit or the etiological factor for the ISR. Now in the PCI we have evolved from the plain balloon to the DAS, and now the fourth revolution, that is the DAB. Basically DAB is the semi-compliant balloon, and where anti-proliferative drug is coated and which is released slowly through the vessel during the balloon inflation with a specific inflation time. And these are the drug usually lipophilic, which usually absorb fast and retain for a longer time. And the excipient or the polymer which hold the drug, as well as it releases drug to the vessel wall. So there are mainly the DAB works in stent restenosis, which we usually encounter almost 3% in a angioplasty in a year time, and the small vessel disease and the bifurcation lesion, mainly in the bifurcation, the osteal lesions where stenting the the side branch where the osteal lesions are involved, and that time DAB is really wonderful. Now coming to the why paclitaxel is used, because paclitaxel is having high lipophilic property. It rapidly intracellular uptake and retention in the vessel wall for nearly a week time, and it acts by irreversibly binding to the microtubules, inhibiting the cell division and migration, and it leads to the structural intracellular changes which causes long lasting effect. And it acts very fast. The incubation period is almost 3 minutes, and it lasts for 12 to 14 days. So long lasting effect, rapid effect, and last longer time, these are the special property. The concentration of the paclitaxel is almost 3 times, because it takes time, the most of the drug which is dispersed in the blood while delivering to the target lesion, and once the paclitaxel balloon deliver a dose to target in a very short time, that is the higher than the total dose released by the DAS. So the drug which is delivered through the drug coated balloon, which is quite higher than the DAS, and with this immediate drug release there is no need of polymer, and so there is no further late thrombosis or this ISR. Now the safety profile with the paclitaxel in the Texas 4 trial, that has been shown that 5 years we have the safety data. So paclitaxel is really safe in that has been shown long back. Now coming to the comparison between the DAS and the DAB. DAS for the drug delivery require scaffold, where the DAB require balloon, and the drug is coated over that balloon. For the DAS it requires polymer, and the dose of drug is quite high in the DAB, and it releases fast. But the major advantage with the DAB is that it, there is no need of implant, there is no foreign body after that, and it may last long time, and you may cut down your DAPT, which is really helpful in the long term. This is again same thing, the drug eluting stent, slow release and the fast action, the slow release with and persistent effect compared to the drug coated balloon, immediate release and short lasting effect. Now coming to the imaging, imaging really help in the identifying the cause of the ISR. If you see in the A, where the under expansion of the stent itself a major cause, and this is almost 50% of the cases, the culprit, the main reason is the under expansion of the stent. Now in the coming to the B picture, where the plaque after the stent strut, it may play role in the future ISR, and in the C picture there is thrombus in the lumen, and D in the there is a stent strut is not covered in the both stents are not covered, so there is gap between the stent strut, and E there is a dissection and the stent fracture. So these are the different reasons where ISR can form, but among them the under expansion I would say is the major reason, and according to that we can formulate the treatment plan. In the under expansion, where the DAB is really work very well, and most of the time this is the etiology and it works really well. Coming to the multiple stent, when patient is already stented, that time again the DAB is really work really well. Now coming to the evidence. Now the long-term outcomes following DAB versus the thin stud. My friend Kalpesh, he may argue that he can put a thin stud stent in the ISR, but the data almost in favor of almost same, like composite endpoint, target vessel related, myocardial infarction, cardiac death and TVR. All four are similar in both the groups in the DAB versus the DES. So the real life registry revealed similar long-term outcome of the thin DS versus DAB, and there was no significant difference in the secondary endpoint like TVR, MI, cardiac death and dose. Now, again compare with the different paclitaxel versus sirolimus, almost similar kind of drug coated balloon with different drugs, but both are comparable. Now coming to the DAB versus DES, if you see the MACE in almost all the clinical trial like DESIRE 3, DARE and PEPCAD, almost it is similar or comparable. So DAB is non-inferior in most of the clinical trial. If you compare in the PECOT trial, the DAB versus POBA, and in that clearly the drug eluting balloon is far ahead of the plain balloon angioplasty. The treatment of coronary ISR with paclitaxel coated balloon catheter is safe and persistently reduces the repeat revascularization during long-term follow-up. Now, and in the ISR DESIRE trial, that has shown that at 36 months the TLR rate was significantly lower in the PCB group compared with the POBA control group. And in the basket small true trial, this is basically trial with the small artery, but the artery size was around 3 and less. So it's not as small as we are thinking. And the outcome is that efficacy and the safety of DCB are similar irrespective of the vessel size. So however, there is a beneficial effect of DCB over the paclitaxel eluting stent regarding the TVR, non-fatal myocardial infarction and the MACE. And in the small vessels, again, the BELLO trial has shown that among patients with small vessel coronary artery disease, a drug-coated balloon met criteria for non-inferiority and sometimes superiority for late lumen loss compared with drug-eluting stent alone. And the treatment of small vessel disease with the paclitaxel DAB was associated with less angiographic late loss and similar rate of restenosis and revascularization as paclitaxel. Now coming to the debut trial, in that where the bleeding risk is high and you want to avoid to give long-term DAPT, and the PCI in drug-coated balloon was superior to bare metal stent in patient with high bleeding risk, and the percutaneous treatment of bifurcation lesion with DAB resulted in procedural success rate of 100%. So incorporating all the clinical data, this is the meta-analysis which included almost 10 randomized clinical trial, all the trial which I discussed, and that has shown that in coronary ISR treatment, DCB provides similar safety profile as DES out of 3 years. And this is the meta-analysis of all the small vessel trial like basket, BELLO, that has shown that the MACE risk is almost comparable with the DES. And this is the SCAR registry where DCB used in the de novo lesions, and that has shown that treatment with DCB has similar risk of TLR and significantly lower risk of TLT compared with new generation DAS up to 5 years. So the DCB work really well in the ISR, small vessel, as well as a de novo treatment when the patient is having high bleeding risk and where you don't want to give DAPT for the long time. Now coming to the third, this is the for third debate, and this is paclitaxel versus sirolimus. Sirolimus, it is having a nanotechnology, but when coming to the clinical role, and that time the clinical data says that sirolimus and the paclitaxel coated balloon, there is no significant difference in the clinical endpoint after 12 months. So even though the technology is the advanced, but the clinical scenario almost similar. Now coming to the guideline. What guideline says, the drug coated balloon and DES both has been given class 1A indication for the ISR, and the IVAS and the OCT should be incorporated in all kind of ISR treatment. Now the practical point before putting the DCB, because it requires a better pad preparation. When you are doing a drug coated balloon, you need to dilate the lesion very well. Almost 1-to-1 kind of preparation is required, because once you start tracking your balloon, it should not waste your time inside the manipulation, because once it enter into your tweak and reach to the target lesion, it should be delivered immediately. Otherwise you are going to waste that drug, and it should not remain more than 3 minutes in the blood stream. So basically, once you prepare the bed well, and for that you may require rotablation, lithotripsy, and use your IVAS and OCT to see the better preparation. And if result is acceptable, like no limiting flow, no dissection, residual stenosis less than 30%, and FFR more than 0.8, then the DAB work is done, and you can justify your result. If there is dissection or FFR is less than 0.8, then DAS is preferred choice. So the DAS, there are long list of role of DAB in these small vessel to ISR, branch vessels, bifurcation lesions, long lesions where you don't want to put stent long. So distally you can do drug coated balloon, and proximally you can put stent, so you can prevent the future event. Now coming to the last slide, and that is the top 10 points. With the DAB, you can homogeneously deliver the drug to the vessel wall, because the drug is embedded over the balloon, so you can deliver the drug in a better way to the overall wall. Second, it releases drug immediately and in the higher doses, which is required because of it is ISR. And the option of using drug coated balloon catheter alone or in a combination may sometime work, because proximally you can stent and the distally you can do DAB, and that in that way you can minimize the long stent. And imaging, yeah, definitely, because imaging helps you to identify the cause, it identifies the morphology of the lesion, and according to that you can choose your DAB versus DAS. And if you are using DAB and your case is appropriate for the DAB, so there is no extra metal left behind the body, you can prevent the further ISR or further event. And the potential for reducing the antiplatelet therapy, that is also important, because sometimes this patient is having on high bleeding risk, like especially in the high bleeding risk patients, you have to cut down your DAPT or antiplatelet therapy, and that time DAB really works well. Lower event rate and better long-term safety, that has been shown in almost all the clinical trial. Almost similar kind of efficacy or non-inferior trial in almost all the cases. In patient with recurrent ISR, when patient already stented, ISR develop and again repeat ISR, and that time DAB is the only choice, or CABG. And the last, IVAS OCT with DAB angioplasty is non-inferior to DAS. Thank you so much. Next.
Thank you, Mukesh, for a very nice talk. And I will invite Dr. Kalpesh Answara for his take on tackling this type of lesion.
So good morning everyone, and welcome to CardioCon 2023. So as Dr. Mukesh sir has spoke about the role of the DCB in management of ISR. So I just have a few points to argue with Dr. Mukesh Ladda sir. So as we have discussed, this is a 55 years male. He underwent the PCI to RCA, which was performed in 2 years back. So presume that he had a drug-eluting stent, which was 4 by 38. So it is vessel is not a small size. First of all, it is very big vessels, and there is patient is now presented with N-STEMI. So he's already having acute coronary syndrome, and there is a 99% osteal involvement. So as we all know, the osteal involvement of RCA, so it's difficult to treat even native osteal lesions. Here patients having a native osteal ISR. So let us presume that patients had a neoatherosclerosis. That is one of the mechanism of the instant restenosis. So my best strategy to these patients I will do the osteal stenting, as I will consider as a de novo lesion, and it can be instant restenosis. Slide. Okay. So I can presume from this case there is a osteal involvement of with the patient with SES, and the DES was used, and there is no other comorbidity like hypertension and diabetic in this patient. So patient related risk factor for ISR is very less in these patients. And as Dr. Mukesh told, that there is a patient who is having a high bleeding list and there is a DAPT is intolerant or contraindicated, you cannot use the DES. But here patient is not having any bleeding list, or neither he is intolerant or not a contraindication for using the DAPT. As we know that instant restenosis mechanism, there is two main mechanisms. It's discussed, that neointimal proliferation or hyperplasia, in which there is a vascular smooth muscle cells proliferation and migration and activation caused by the vessel injury following the mechanical stretch or internal elastic laminar rupture and medial dissections. And there is another mechanism which was discussed, that was the neoatherosclerosis. It may affect the nascent neointima, that in meaning of new disease. So patients had a DES 2 years back. So we presume that patients already have a endothelized stent structure. So it probably he must be having a neoatherosclerosis rather than the neointimal proliferations. As Dr. Mukesh has discussed, that the patient's related factors, lesion related factors, and procedure related factors, this should be considered when you are treating the patients with the instant restenosis. So for us as an intervention cardiologist, the lesion length, lesion related factor and procedure related factor is most important to treat this kind of patients. This is the ISL classification. Just briefly tell about the type 1. This is focal, type B it's diffuse, type 3 it's proliferative, and type 4 is total occlusion. So depending on the involvement of the lesion length, we can classify into 1, 2, 3, 4. And again, the type 1 can be classified into 4 types depending on the ISR as formed. It's type A, means it's gap type B, which involves the margin, and type C, which is involvement of the only focal body, and type 1D, it is a multifocal. Now, I'll discuss about why I should prefer the drug-eluting stent in these patients. First, I have a imaging. So once a patient being having a instant renal stenosis or neoatherosclerosis, IOS imaging allows me to real-time assessment of lumen area, plaque compositions, size and distributions, and finding from a meta-analysis suggests that is better clinical and angiographic result may be obtained under IOS guidance when treating patients with ISR. And not only that, the another imaging OCT, which guided standing, it also improve the clinical outcome as well. So OCT is used to reveal underlying mechanism in patients with stent failure, including ISR and stent thrombosis. So this imaging is absolutely available each and every cath lab. So we don't think about the second layer, which will be gives the recurrence of instant stenosis, because now we have IOS and OCT guided angioplasty with using the DES, which will allow to identify stent under expansion, stent fracture, thrombus, dissection, which can be only treated by putting another drug-eluting stent. So these are the image of the IOS and OCT. It's nicely comparable with the histopathologic slides with the, in patients with the instant restenosis. So experts and guidelines recommended this is class 2A recommendation of using the intravascular imaging. Now point 2, mechanism of DES. As we all know that not only it contains the drug, it also contains the polymer and metallic structure. So nowadays, as Mukesh sir said, that THEMS drug DES is now available to treat the native as well as the patients who's having a drug instant restenosis. So DES recognized for their strong anti-proliferative and therefore is very attractive management for the ISR. Network meta-analysis has ranked that DES implantation is most effective treatment for the ISR. And head-to-head trials demonstrated there is a superiority of DES implantation with other therapeutic options like balloon angioplasty, intravascular brachytherapy, and paclitaxel DCBs. In de novo lesions, DEB produces profound inhibition of neointimal proliferation and provides scaffold to the prevent recoiling of vessels. So recoiling is another phenomena which involved in mechanism of ISR that cannot be treated with the DCB. And ACS patients with ISR, neoatherosclerosis associated with plaque rupture and thrombus formation, which can be fixed with the DES. Clinical study, this was the restenosis REBIS 3 study, and restenosis intrastent balloon angioplasty, which compared with the drug-eluting stent. And they found that use of second generation DES was superior to first generation DES, what we are using nowadays, second generation, and there is a third generation even stent are available to treat this kind of patients. And intravascular imaging for treatment guidance had improved the angiographical as well as the clinical outcome in patients with the ISR. So despite of this benefit, we should accept that when patients have a DES ISR, the recurrence rate still, if you treat with either DCB or DES, the 10 to 20% of patients having a ISR recurrence. So it is very difficult to treat the DES ISR. Now, this is a comparison with the endolimus eluting stent versus balloon angioplasty, and they have shown that everolimus eluting stents, it gives the best angiographic result as well as the clinical outcome. This was studied in SR Desire 2 and stent ISR. Then PCI with DES. So there is another hypothesis that if you treat the heterogeneous DES strategy, means patients who is having a one kind of the drug-eluting stent, and if you use a second type of drug-eluting stent, there may be a beneficial and it will prevent the recurrence. But the result was not that much acceptable, and SR Desire did not show any benefit of the heterogeneous DES strategy for treatment of sirolimus eluting stent in ISR. But in RIBS 3 study, there was found that heterogeneous DES strategy may provide superior outcome in patients with the ISR. Then it came to the LIBS 4 study, in which they only studied the everolimus drug-eluting stent. Now specifically, they studied Science Prime versus DCB, and what they found, the EES provide better primary endpoint consisting in segment MLD at the 6th and 9th month angiographic follow-up. In fact, the patients in EES arm had a significantly larger MLD, and p-value was very much significant, and net lumen gain was much more, and lower percentage of diameter stenosis and binary stenosis rate as compared to the DEB arm. And 1 year clinical follow-up, the main clinical outcome in measure of composite of cardiac death, myocardial infarction, and target vessel revascularization was significantly reduced if patients received the everolimus eluting stent as compared to the DCB. Mainly it will be driven by the less need for the target vessel revascularization, and p-value was very significant in this study. These clinical trials for drug-eluting stent versus drug-coated balloon, as already shown by Dr. Mukesh, they are all having a less incidence of the clinical outcome as well as the angiographical outcome as compared to the DCB. In AZAR, DESIRE 3, RIPS 4, DARE trial, this PEPCAR China ISR trial, and Biolox randomized control trial. So these have shown that the DCB, DES, either with the paclitaxel or with sirolimus drugs trial or sirolimus DES or everolimus DES, there will be a less incidence of the MAST at the end point. This study already has shown by Dr. Mukesh that Dadlow study, in which they pulled analysis from the 10 existing randomized clinical trial comparing the DCB angioplasty with repeat DES implantation for the treatment of coronary ISR. And look at the primary efficacy endpoint in terms of target lesion revascularization at the 3 years. There was a longer period, 3 years. And also they have compared the primary safety endpoint composite of all cause of death, myocardial infarction, and target lesion thrombosis at 3 years. So this was the structure for the comparison with DCB versus DES. And what they have shown that in patients who is having a DES ISR, risk of the primary efficacy endpoint was higher in DCB angioplasty than with the repeat DES implantations. Whereas the risk of the primary safety point was numerically lower in patients who was treated with the DCB. But repeat revascularization with EES compared with DCB can reduce the risk of the MASH. So this was the conclusion study from the Dadlow pooled analysis. Now comes to the guideline. As Dr. Mukesh Ladha has shown that European Society of Cardiologists, they are recommending class 1 indications for the use. Once the patient having ISR, you perform the intravascular imaging, mechanical tissue on IVL. If it is yes, you address the mechanical issue. If it is no mechanical issue, you can do the bed preparations of the ISR lesions. And look at the last, if you treat with the drug-eluting stent, so DES is moderately effective as compared to the DCB in this algorithm and an guideline. Now, we should not forget about the osteal lesions is difficult to treat because most of osteal lesions require stenting. So, if you do debulking therapy with rotablation, IVL, cutting balloon, scoring balloon, high pressure balloon, this can lead to the catastrophic during the procedure. So at that time your DCB will be not useful to treat this catastrophics. Only drug-eluting stent will be useful in case of patients had a bad dissection, no reflow, acute occlusion of artery, hemodynamically instability. In this kind of patient, only drug-eluting stent can be useful. So using DCB only in osteal lesion cannot be accepted like these patients. And patients is having osteal lesions, so DCB is, as Mukesh says, particularly useful when there is a addition of another stent is undesirable. Suppose patients already having a multiple previous stent layer and presence of any major sidebands, which is not there in our case. It is a typical osteal lesion without involvement of bifurcations. And the vessel size is very big, so you cannot do only DCB in these patients. This is a stent failure, stent under expansion, stent fracture, underside stent, edge dissection, miss overlap section.
Risk for the recurrence of ISR. But if you look at the newer generation of stent which reduce and overall improve the performance, because of improvements in platform like thin strut cobalt chromium and polymer free stent now is available. So this care must be taken to ensure adequate lesion preparation to achieve prior to the implantation of new DES for treatment of ISR, and particular care taken to tackle any under expansion of original cells. So for that we have a IOS and OCT. So my take home message on that, we specifically EES is superior to DCB in angiographic endpoints with larger MLD, lower diameter stenosis and less binary restenosis. Revascularization with the DES significantly reduced the TLR and TVR as compared to DCB, and EES also associated with the lower mesh than the DCB. Use of IOS and OCT overcome the disadvantage of second stent layer in ISR and guide the stent expansion and position. Thank you.
Dr. Kalpis, thank you, Dr. Kalpis. You have put forth your argument in favor of drug-eluting stent used in such cases. Thank you. Let's invite Dr. Ritik. Let's hear from him what's his argument in this case. Now we'll put his argument in favor of using sirolimus drug-eluting stents with nanotechnology.
So good morning everyone, and thank you Kamal bhai. My talk is on sirolimus eluting balloon in a given scenario. So what we don't like in the cath lab. So as an interventionist, your patient is unstable and you don't like, one is calcium, second is a heavy thrombus burden, and third is this in-stent restenosis that has occurred to your stent you have implanted. So these three things you don't like. So ISR is definitely an Achilles heel for most of the intervention cardiologists. This is the data which was published in 2015, and clearly the first generation stents have clearly shown that the higher in-stent restenosis rate. With that we have a second generation stent. We have changed the polymer. The polymer is biodegradable, but the problem is not solved. At 1 year we will again see an in-stent restenosis rate of around 12%, and that increases by 2% every year. So where is the problem? So if you look at the data and analyze it, what you found is the event is actually with the metal. So drug has already gone, you have metal inside, and the metal is creating problem. You have data up to 5 years. So what we can discuss on that part is
Unfortunately, we don't have this. So this is an indigenous device. You fire and forget. But for in-stent restenosis, unfortunately, we don't have. You have to keep a close follow-up of your patient, because the patient can become symptomatic. You have a very resistant in-stent restenosis patients coming back to you. But the trials and scientific literature, what we have learned up till now is that what is our aim? So our aim is very simple. You have a maximum acute gain and you have a minimal late loss. So if you can achieve that in your in-stent restenosis patient, your job is done. So by treating this kind of lesion, you can't be conventional. That is one important thing. You can't be casual and you can't be complacent. So what you need is basically this. You need an exotic approach which is extraordinarily elegant. And the soldier is not the soldier, in fact it is a cardiologist in the cath lab using an imaging device for a precision directed intervention. So this classification, we all know this classification, it is almost a 2 decades old classification for a bare metal in-stent restenosis by Roxana Mehran. Although it is relevant in our case because it is an osteal lesion, but with the imaging and various images all the speaker have shown, we have various mechanisms. So beyond a angiographic stenosis, you have various pathophysiology.
you can have a neointimal hyperplasia, you can have a neointimal proliferation, you have a stand fracture, you have a geographical miss with the thrombus and calcification. So lot of things happen. But what we have learned from this study of 5 years is that the in-stent restenosis in a drug-eluting stent is most of the time focal. So that is one important message. And secondly, for a drug-eluting stent in restenosis, the ongoing late loss we have observed is up to 5 years. So after the first year, which is a 10 to 12% in-stent restenosis, there is an incremental 2% in-stent restenosis rate up to 5 years. We may have a long-term data, but that studies are going on. So these are two important messages for when you are treating your in-stent restenosis. So our patient had two risk factors. There are many risk factors. Non-diabetic, non-hypertensive is good for the patient, but two important, a different beast. One is a osteal lesion, and second is a in-stent restenosis per se. These are the mechanisms that we have already discussed. And this is the Waxman's classification based on the imaging. And if you see the role of drug-eluting stent, which has been unanimously accepted, is only in a stent fracture case. In rest of the other cases, you have to use your experience, imaging, and then take a decision. So our patient is a young male. So young is very important because he is 55, he has a long fruitful life. You don't land up this kind of patient in trouble by doing a zealous work. So it has an RCA in-stent restenosis, the stent is large. So we are not talking about a small vessel disease. And it is a focal in-stent restenosis. Now coming to the RCA osteal beast. So in-stent restenosis of a RCA osteal lesion is an altogether different beast. So and there are data which are available. So this was a paper in 2021. And what it has shown, that a first generation stent, of course, had a higher in-stent osteal restenosis. Second, if you over-expand, then the chances of stent fracture is high. And as the point's been clear, that osteal stentings are difficult. If you protrude more, again a chance of in-stent restenosis because of stent fracture is high. But every time what they have seen is, I think it is not moving. Excuse me, it's not moving. It's not moving. Move slide. Next slide. So it's always a focal. So the focal part is very important. So this is a dedicated data for RC osteal lesion. And it is again imaging supported. And what in the imaging they have found, a stent fracture where you will definitely use stent is only 23%, and calcific nodules which are seen in 11%. So in 32% cases you will have this problem, but rest of the 70% of cases you will have a patient where you can use either stent or a balloon. And this is a recent publication which is published in Eurointervention. So this is a predictors of repeat PCI of recurrent DES ISR. So you have implanted a stent that the DES occurred, and you have implanted a second stent. So these are the predictors. So LCX has a higher risk. Calcification has higher risk. If the patient is coming earlier at 6 months, it is a higher risk. And it is a diffuse lesion that is a higher risk. And even with a score of 0, what you have a 12%. So your score is 0. Our patient has a score of 0, that there is a 12% risk. So if you use a second stent, you will have the same 12 to 15% risk. And whatever data up till now we have, and we will dissect the data, the risk of drug-coated balloon risk is around 15 to 18%. But what if you have a restenosis again, whether you have used stent or a balloon, the restenosis is always going to be focal. And it has been proven that almost 70% of the cases, you do intervention, the patient will come back, you will have a focal in-stent restenosis. That data we have, that almost 70% will have focal. Now if you have implanted a second stent, that the third stent is not recommended. So it is a clear that if you have implanted a second stent, the third stent is not recommended. If you have implanted a second stent, the in-stent restenosis rate, which is very high, then your options will be balloon or a CABG. So why not balloon first rather than waiting for the in-stent restenosis to occur in the second stent? Now coming to a stent related issue, and we have all experienced this, that recoil part you have clearly mentioned. Once the balloon is there, the stent expands, you deflate the balloon. That occurs specifically with the RCA osteal lesion, circ osteal lesion, and LAD osteal lesions. And current generation stents, we are talking the newer, they are thin studs. So basically to address this, We don't need a current generation thin shunt stents. We need a synergy megatron. So synergy megatron is a different beast. We all know that is a higher connector. The length of these peaks are less, and the number of peaks are high, particularly in the first two parts. And later part of the stent had a 3 connectors. The EES comparison with the paclitaxial balloon, the EES was the conventional EES. We are talking about the ostial lesion, that too in the ISR of RCA. So that data does not stand with our case. So this stent is not available. So ideal stent would be this, but this is not available. Advantages, I think Mukesh Bhai has clearly mentioned. I'll just keep, so what the number of advantages. So this is the data. Now the red ones are for the drug-eluting in-stent restenosis. The initial study of 1 year, that was by a Park and group, and they have shown clearly that the target lesion failure rates, all cause of mortality, MIN is almost equivalent. The result change with the Dedalus study where they have shown that at 3 years, the paclitaxial balloon had some issues. So it is safe and it is a slightly less effective compared to a stent therapy. But there is a lot of heterogeneity in the data, and what heterogeneity is that they have compared, first of all, the 10 or 11 trials, they have compared paclitaxial balloon to paclitaxial stent. We are not more using paclitaxial stents. When compared, the paclitaxial balloon was compared with the ES, the result favored a stent. There are no data for the focal lesion in stent restenosis. If you look at the trial again, the most of the balloons, paclitaxial balloon which were used, they were releasing 3 microgram per meter square drug. Now which balloon we have right now? That has a 3 mm balloon, 3 microgram release. We don't have that balloon. If you take a Medtronic balloon which is going to be there, it is releasing 4 microgram. So that data is also not, we are not having. If you talk about the Boston balloon, it is releasing 2 microgram. So even though that data is not with us. So if we talk in terms of data also, we cannot generalize paclitaxial balloon eluting device because all are having a different characteristics. So these are the data. And since subgroup analysis, coming to particularly the ACS part, the balloon was found to be effective. Now, why they have to stress on the safety part, it is a different part. So, but because of this reason, we need to have a balloon. Now, coating is a problem with the paclitaxial balloon, we all know. Retention of the particle leading to late mesh is a problem with the paclitaxial balloon. How you prepare your balloon, that is also important. And this is a ghost of Castanov, which the data is clearly shown that in the intervention, that too in a femoropopliteal at the end of 5 years, there was more death and infarction. A lot of people can raise a question, and that is why paclitaxial people have to come up with the data now. It is safe, because in the peripheral intervention, they have a lot of data. So why do we need a sirolimus balloon is because of all these factors. So sirolimus, we are quite familiar. It is quite safe. It is anti-inflammatory. The only 2 problems and which was solved. One is a tissue absorption, one is a tissue retention. Now coming to balloons of paclitaxial which are available, agent, as I mentioned, it is a balloon with the Boston. It releases 2 microgram. We don't have a data. A sequence, please, where most of the trials were done. That is not available to us. Now the same 3 microgram release Dior balloon is failed miserably with the stent. So you have a 3 microgram releasing balloon. One is almost found to be quite equal to with the stent. One is miserably failed. So that is a heterogeneity in the data. And we have a 4th Indian balloon, which is sirolimus elusing. Now is a recent recall by a Medtronic. And the date I can read is around in the September 2022. They have recalled their balloon, paclitaxial eluting balloon, because it has a gross compliance issue. Because the drug coating, which was higher, that is 4 microgram per mm square, that had led to a compliance related issue. Dissection increase and the instant stenting, number of stents in a provisional drug eluting strategy, balloon induced strategy, they have to use more stents. That is why the recall was done. And that is why we need a sirolimus balloon. And this balloon has a unique way of preparation. I think a sirolimus is encapsulated in the phospholipid layer, and that is why you deliver a drug. And it has an obvious advantage. So facilitates better adhesion, circumferential coating, effective drug transfer, and the better tissue availability. The preparation is different compared to the conventional balloon. They implant it at a lower pressure, they spray it, there are 3 folds, and because of that, there is an effective drug delivery. There are data also. So before they initiated a trial, the data was done, and the drug stays in the adventitia for 7 days, and that is, the trial was done by none other than Dr. Renu Virmani. And this is the first study. Now this study, if you compare, it was also with the sequent please balloon. It is not with the magic touch balloon, and that found that it is effective. Both the balloons were of the same company, and they found it is equally effective. This was a single arm study, different balloon with the sirolimus, and they also found that it is quite safe. And if you compare the conventional data of late lumen loss, which is again an important strategy in management of in-stent restenosis, it is almost equivalent. So these are the data up till now we have. So late lumen loss was almost 0.31 compared to all the data with the paclitaxel, which is 0.39. So in that terms, we see the sirolimus balloon has scored. We have also data with exclusively magic touch balloon, and this was a registry, and we all know the real world data are quite more important. Their ACS patients were also selected. Focal restenosis 89%, RC intervention almost around 29%, large vessels were selected, and at 3 years they were reasonable target vessel revascularization or of around 4.7%. So it should be considered a fantastic result. And before venturing into doing a drug balloon, I think preparation part we all discussed, but this is a data with the usage of cutting. So ISA Desire 4, they've clearly shown that if you prepare your bed with a cutting balloon or scoring balloon, the effective delivery of the drug occurs, even watermelon sitting. So your lesion is not prepared, and as both the speakers have clearly shown that if you insert a balloon, somehow you have to remove it out, the drug will go. So that is not a strategy. You have to prepare your balloon bed very well. So cutting balloon or scoring balloons plays an important role. So this is a strategy. Europeans follow this strategy. With the focal in-stent restenosis, you do ballooning, you have a good result. I think with the image guided strategy, you just come out. You use stent when you have a dissection and other complication which has happened. And use imaging, either IVAS or OCT in your cases. So in summary, we are quite familiar with the sirolimus group of stents. In that way, it gives a lot of confidence. Paclitaxel, there are a lot of confusion, and in 2000 data, which is a 2020 data, which is very recent data, that paclitaxel has created problem in the peripheral vascular disease. So that has not gone. So our confidence is shaky. Our patient has come for the in-stent restenosis in 2 years. Younger patient, you will not do things which can create another confusion. And various data is supported. However, the long-term registry and comparative registry are not available. But in this case, I think I will go with the sirolimus stents, because number of things I have mentioned regarding the paclitaxel balloon as well as the use of stent. Thank you.
Thank you, Dr. Gruentzig, for such an elaborative talk on sirolimus relating balloons for a case of ISR. Now we have heard all 3 speakers of ours, and we'll leave an open discussion with moderators being involved for a discussion with all the talks we heard.
I think we have Gambhir sir here, and what sir you would say about the ORC, osteal in-stent restenosis management? Your experience, you have vast experience of managing such complicated cases.
Thank you for asking me to give my experience on the management of ISR, particularly ISR following a drug retention. Let me admit a few things. Firstly, I think one of the most challenging problems to treat today is the ISR. It is much more difficult to treat the ISR than a gene over lesion. That's one. Number 2, the longer is the duration of the implantation stent and the occurrence of the ISR, the more are the difficulties in treating. Coming to the treatment part, well, what I normally do is that I image all these patients with IVUS. If the vessel is calcified, and if it is 3 to maybe maximum 3.25 or even sometimes 3.5, we go and do a the vessel is calcified and go to a reasonable size and even up to a 2 mm bar depending upon the size of the vessel. We do a good amount of debulking, and after debulking, I don't have personally much experience with a drug-eluting balloon. Of late, I have started using drug-eluting balloon, and if I get a residual stenosis, mark it, I say it again and again. If I get a residual stenosis after doing a debulking with rotablation, followed by massive balloon dilatation or a high-pressure balloon dilatation, if I get a residual stenosis of 20% or less, then I use a drug-eluting balloon. But if I don't get a residual stenosis despite using all this modification of ISR by cutting balloon or rotablation, then I do not put a drug-eluting balloon because I am totally convinced with the basic principle of introduced physiology that if you leave a residual stenosis of more than 30%, whatever you might do, patient will come back with a restenosis. So try to achieve a residual stenosis by any of these devices to less than 20% and then do a drug-eluting balloon. But if you can't get that, then I think better to do a stent and then expand treatment. But that is the limitation of stent also. If you are not able to get a residual stenosis with even DOPA or even cutting balloon to a level of less than 20 degrees, then even your stent may not work. So these are the problems which I think someone wants to work. And I was suggesting Manish from Concept that you develop a drug-eluting balloon, magic touch. Why don't you work on a balloon which has got blades on it? Gruentzig works dual purpose, cutting balloon plus a drug coated. So we are working on it. He has not started. He has started thinking on those lines. And then we tie up with some people who are making the cutting balloons like Boston and any one more company. And then coat it with a serial limit. So coating serial limit is fantastic. That is where you have to with phospholipid encapsulation. So if that comes up, I think that will solve the problem to some extent or to a great extent. But without this, it is a difficult task. If it is calcified, well, then rotor does the job. You get a 0% residual stenosis, and then you can put a drug-eluting balloon or a stent, depending upon if there is a dissection, stent, if there is no drug-eluting. Just one point. The calcification is inside the stent. So rota or even your diamond bug can help. If the calcification is behind the struts, then yes, at that time excimer laser or IVL balloon can also help. Right?
But I think with the diamond bag, there are no data to support. In the stents, I think, sir, orbital is not been tried or we have a proven data.
So with eczema, I guess we do have some data, but otherwise we don't have substantial data to support either ways. There are centers that have published a small number of patients for the same. It still remains a matter of debate. We'll open the discussion with Dr. Hitesh.
Eluting balloon, that is like almost in out of phase, so there is no more discussion required for faculty. Now the things like strategy for going for stent or a drug eluting balloon, in fact most of the data and the way the discussion progress, it favors more towards putting a stent inside the stent rather than just living with the drug eluting balloon, because most of the times it doesn't give the residual stenosis less than 30% or so. So that will be the take-home message that try to implement. And now the availability of the thinner strut design and the recent stents, chances are of recurrent event will be less. But again, like there is a pattern of, we have one patient who, a young patient with a circumflex stenosis stented by me way back, almost 6 years back. and LED and RC were normal, young patient, 32 years old. He had another event 1 year back, and he was at some different place, so another stent was implanted. Then again he had a third event when we treated with a drug-eluting balloon, and we accepted the result with some residual restenosis. Again he had a fourth event. Again he was out of station, and another third stent was implanted in the same scenario with a good result at the end of the procedure. And we just, for our academic purpose, we did the check angio, and it was having instant restenosis. Patient was not having symptoms, so we left it on because all the strategies were tried, and the other arteries were normal, circumflex were involved. I think in certain scenario where there is a recurrent stenosis and the patient is having, say, either collaterals or if relatively symptom-free, then aggressive medical management would also be the optimal strategy to manage such patient.
Sir, my question would be as complete, sir. Hello, sir. Sir, we do aggressive pre-dilatation and post-dilatation nowadays. So what is your experience about post-stenting aneurysm in the stented part? With aggressive post-dilatation, is that post-dilatation is responsible for many times aneurysm in the stented part, or some other pathologies working there?
Well, I think what I understand from your question is one is the aneurysm in the central part developing immediately on the table, and secondly on follow-up.
No, sir, on follow-up.
On follow-up.
Not on table, but on follow-up.
On follow-up. Well, first of all, the number of patients who come with aneurysm formation after a drug-eluting stent today is very, very low, very low. You know, I mean, all of us have seen anecdotal cases, and the case which I have seen and reported, nobody has seen. I have seen an aneurysm as big as a football size, which was pressing on all three arteries, LED, circumflex, and the ramus, and it was a pseudoaneurysm. So it is not the high pressure dilatation which will lead to aneurysm. It is then we reviewed the literature, and possibly it is some kind of a inflammatory response to a metal that sets in. But more importantly, I said there are few case reports, and our case was also fell into the same category. The patient developed a small leak after treatment, and then it got localized.
Thank you, sir. Thank you for your valid and valuable, knowledgeable points. I guess we'll conclude this session now. With the
We'll conclude this session because short of time.
Yes.
I think the next session's presentation are ready. So thank you everyone. Thank you chairperson, and thank you moderators for giving me valuable time for these sessions. So we'll move on to the next session, the about 25. Yeah, please.
Also, there are photographs to be taken between speakers with the bout or hand gloves or boxing gloves, and so can the chairpersons and the moderators. That's downstairs in front of the Cardiocon logo. Thank you very much.
So, very cognitive session delivered by Dr. Mukesh Ladda, Dr. Kalpesh Hansora, and Dr. Gruentzig Trivedi. And also, thank you so much, Dr. Hitesh Shah and Dr. D.S. Gambhir for making this session very interactive. Give a big round of applause for all them valuable contribution during the session. Thank you so much. And now it's time to move ahead for the next session. And for this, I would like to invite a chairperson for this session, Dr. Uttam Chandarana, Dr. Priyank Modi, Dr. Kiran Prajapati, and Dr. Ravi Sanghvi. I would like to request all the chairpersons to come on a stage. And also I would like to invite a moderator for this next session, Dr. Rohan Parikh, Dr. Radhakishan Dake, Dr. Aman T. Patel, and Dr. Ajay Kare. So please welcome all the moderators also to come on a stage. I would like to request chairpersons to introduce us 5 speakers. There are 5 speakers for this session. So I would like to request chairpersons to introduce them and welcome them on a stage. Thank you. Over to chairpersons.
Next slide. Chairpersons, please introduce the case.
Hello. Yeah. This is a 50-year-old doctor with diabetes presented with STEMI with ongoing breast pain and a plan to undergo PTCA to the tortuous Stafford Crook angulated long ulcerated 95% mid RC lesion with large RV branch arising across it. He has recently been diagnosed with carcinoma of colon, for which he has already completed his chemo and is now scheduled for GI surgery. He also has a history of melanoma, twice as presenting complaint at the time of diagnosis of CA colon, and the stent parameters that help in choosing the stenting would be the first talk, Dr. Devendra Shrimal. Thin strut Zotarolimus eluting stent is most trackable and best stent for this strategy in this setting. Yeah.
Thanks for the organizing committee to invite me in this discussion. As we discussed, this patient is having carcinoma colon. He is having a history of melanoma also, and he is having a tortuous vessel which requires a skillful placement of the stent. And remember that if you put the wire, if you pre-dilate the region, and if you lose the wire and guiding access to the artery, it can be a havoc. So I will discuss about the thin strut jazz, which is most trackable and best stent for this setting. Why it is so? We all know that the ARC consensus on high breeding risk features, which includes age factor, renal dysfunction, particularly the estimated GFR is less than 30, liver disease with portal hypertension, active cancer, anemia, if hemoglobin is less than 11. We often forget this thing that even hemoglobin is less than 11, it is major risk bleeding. Low platelet count, which is less than 1 lakh, particularly if it is less than 5, it is severe thrombocytopenia. From 50,000 to 1 lakh, it is moderate, and from 1 to 1.5, it is mild thrombocytopenia. So if it is moderate to severe, thrombocytopenia is there, it is a bleeding risk for the patient. Stroke, ICH, brain heavy malformation, bleeding diathesis, prior history of bleeding or blood transfusion is there. These all are the features which categorize the patient for the HBR. OSC is particularly important, and particularly in this setting, atrial fibrillation is very common because this group of the subset of the patients which require oral anticoagulation therapy in the form of means knocks can be there or even simple like strom or warfarin can be there. NSAIDs and steroids, they are taken as a minor criteria, but OSC is taken as a major criteria, right? And planned surgery on dual antiplatelet therapy, recent trauma or surgery, these all are the high bleeding risk criteria. We know that what is the actually we can see here. The blue part here is showing that these are the major criteria: OSC, low platelet count, bleeding diathesis, liver disease, and active cancer and planned surgery and so on. And lower part, lighter part, which is suggesting that minor criteria and dual features, which suggest that the binary features are there. So HBR patients are a large, growing, and complex population. We really don't know. If we analyze them, then we can really come across that up to 40% in different not studies means taken from the population of PCI group patients. Up to 40% of the PCI patients are at high bleeding risk. There is limited evidence in these patients. Complex anatomy is there, particularly like diabetic patients are there, CKD patients which have diffuse disease. They have 3 times greater risk of bleeding event for HPR patients on extended DAPT regime, and they have 4 times higher risk of mortality if they bleed post-discharge. So actually the condition is critical, and in such patients, HBR patients, we should have a different strategy to protect them from the bleeding. At the same time, we should think about the ischemic part also, that they should not have the stent thrombosis. So optimal strategy to balance between the bleeding and the ischemic risk for HPR patient, we should try to find out. So this is my personal data on HPR patient in NH patient which underwent angioplasty. So we retrospectively analyzed 200 patients taken. Approximately we found that 32% of the patients were having the high bleeding risk. So that is a good number. As I told you, there should be a balance between the ischemic and the bleeding part, and optimal patient care and decision should be there. Few words on Resolute Onyx polymer. We can see here that because this is having BioLinks polymer specifically designed for the dress, it is having rapid endothelialization, minimal inflammation is there, it is having low risk of stent thrombosis, and it is having controlled revolution. So that's why it is a good stent choice for such patients who are having high bleeding risk. One independent study was performed which is showing that the proven healing at 1 month, where 15 patients were taken and OCT studies were done, 3,600 stent struts were taken, and it was found that almost 90% of the stents were covered with the endothelium at the end of 1 month. So we know that if there is complete coverage of the stent, the chances of stent thrombosis in the later stage is less, and we can certainly reduce the dual antiplatelet to single antiplatelet therapy. It is having different design, which is having a single wire design. So because of that, the trackability of this stent is better. It can be tracked even in the tortuous vessels. Then second thing is BioLinks biocompatible polymer is there, and both of these ultimately culminates into fast healing, which is, as I told you, in the OCT studies we have found. So here again, increased thromboresistance can reduce stent thrombosis risk, and it provides the option to discontinue the dual antiplatelet therapy. We can share this. The Resolute Onyx, which was compared with the BioFreedom in Onyx 1 trial, and it was found that this more fluorescent is better. So as compared, because BioFreedom is the only approved CE marked approved in the high bleeding risk patients. That's why it was compared. The Resolute Onyx was head-to-head compared with the BioFreedom. It is not available in India, and it was found it was a non-inferiority trial, and it showed that the results were almost equal with the Resolute Onyx and the BioFreedom. And here we can say that the Resolute Onyx has showed superiority in thromboresistance also because of lower platelet aggregation can contribute to reduce stent thrombosis risk. While in polymer trial with so-called novel technology, we can see that the synergy stent and the O0 stent, you can see that with O0, 86% lower ST rate was seen. With the synergy, there was like almost same, no significant difference was seen. Significantly lower spontaneous MI was seen with the Resolute Onyx stent here, you can see. And lost stent thrombosis confirmed at 2 years follow-up. And if we analyze this thing, we can see here in the initial part, means acute, in the early stent thrombosis means within 1 month, we can see that the Resolute Onyx was even better numerically as compared to the Biofreedom.
Hello, hello, mic check, hello, hello,
Here, that
hello,
one
mic
trial,
check.
Onyx 1 trial, which was first head-to-head comparison and with the Biofreedom stent, and almost 2,000 patients were taken in this study. It was a multinational, international study which included 84 global sites. It was single arm study actually. So it showed almost 1,000 patients were taken into both arms, and in the 2-year follow-up, almost 97-98% of the patients completed the study. In the study, was good part that average criteria for this HBR patients were taken as it was 1.6 average criteria per patients. 46% of the patient met 2 or more criteria for HBR. So different criteria like elderly patients, OSA, anemia, and all these things were taken into study. This part is important. This slide is important. Patient characteristics. Almost 40% of the patients were taken as diabetic patients. Atrial fibrillation patients were almost 1/3 of the patients, because we know in such patient or in this group of the patients, anticoagulation therapy OSA is required, and this was a good number because OSC along with dual or single antiplatelet later on becomes important. Again, acute coronary syndrome was almost 50% in this study. So that is again important because we all know that the acute coronary syndrome patients are at high risk of stent thrombosis in the later stage. So we fear to stop, particularly as compared to the stable patients, where the stable angina patients undergo angioplasty, we don't fear so much. But if a patient who is having acute coronary syndrome, thrombus burden is there in such patients when we put stent, right? So we try to extend the dual antiplatelet therapy for a longer time. So in this study, almost 50% of the patients were acute coronary syndrome patients. If we go to the lesion and procedure characteristics, again, this study included almost 46 to 48% of the patients who are having moderate or severe calcification. And if we know that the calcification is an important part where the stent trackability becomes important, then even after putting the stent expansion becomes an important part. Then we can see here in this again, that the crossover to other study stent was with Resolute Onyx, it was only 0.2%, but with the Biofreedom stent, it was approximately 4%, which was statistically significant. And because of that reason, the device success was also higher in the Resolute Onyx. So in this study, 92% of the patients were on dual antiplatelet therapy for 1 month, and later on they switched over to single antiplatelet therapy or OSC depending on. So here again, we can see that the spontaneous lower MI was seen lesser with the Resolute Onyx as compared to the Biofreedom stent. Significantly lower CDTVR with Resolute Onyx was seen at 2 years. So this study, which was largest study and first study to compare DAS versus DAS. So it in further sub-analysis was done, and which included AF subgroup patients, complex PCI patients according to sex, diabetes, bifurcation, small vessel, ACS subgroup and imaging subgroups, and it was found that it was non-inferior as compared to the Biofreedom. So Resolute Onyx was safe and effective in high bleeding risk patients on 1 month dual antiplatelet therapy, and if we see the MI part, spontaneous MI was even lesser as compared to the Biofreedom stent. Short DAPT trial comparison, if we see here that the Onyx 1 trial were global trial and clear analysis trial in which patients were taken from the global analysis, US and Japanese patients were taken. So here again, it was like Onyx 1 was a randomized trial, And here we can say the different characteristics of the patients, that how complex lesion and the patient complexity was there. And in this trial, the important part was that patients were in the ACS group as well as highly calcified subgroup was also taken here in this patient group. We compare here like complex lesion were B2 and C, so 80% and 79% as compared to the other studies where it was less. Prior MI was higher and the ACS patients were higher in this study group. Broadest inclusion criteria was seen in this study group with the HBR patients. We can see here what is the ACR definition, and according to this, if we see the Onyx 1 global or clear analysis, which included almost all the criteria, and if we see the other leaders free and juice, it was taken with the bare metal stent actually. So comparison of bare metal stent with the drug-eluting stent. Master DPT, which was recently published, it included Ultimaster stent with 1 month and extended, means 3 months dual antiplatelet therapy. So it was like same stent with shorter duration or longer duration. So if we see this Onyx 1 global and clear, it included higher number of the patients which were having the these criteria. So largest data in highly complex HBR patient with Resolute Onyx is seen only DAS with head-to-head comparison versus DAS. 2 clinical trials with 2,500 highly complex HBR patients were included. Only DAS to show significant better results in safety outcomes. Only DAS to have 2 trials versus biodegradable polymer and 1 trial versus polymer. I'm not going into these parts. So if we say that it is the first and only DAS FDA, CE and DCJ approved for 1 month DAPT, and it is clearly written on statement updated in information for use, IFU. They have clearly written in their IFU that this stent is approved for 1 month. So in this case, I'm coming back to the first slide, means the case factors to be considered in this HBR patient who is a doctor who had carcinoma colon. He is having history of melena. So tortuous vessel, Shepherd Crook RCA is there. Then side branch SS is important because large RV branch was arising from the mid RCA, 95% lesion was there. And this was really HBR patients. We need a stent which can negotiate the tortuous vessel. We need a stent which is having the side means pore, or what we can say that opening, strut opening, which can provide a good access to the side branch easily. If we compare with the other stent, it is having a circular strut opening in Resolute Onyx as compared to quadrangular and different shapes in other stents. So this provide rapid access and easy access to the side branch also. And third thing is HBR patient. So data are with you that this patient, this stent can be used in such patients and can stop dual antiplatelet therapy. So choice is yours, but these are some of the data that we can use this patient in, particularly in this subset of the patients. Thank you, sir.
Yeah, thank you, Dr. Devendra, for nice presentation. Now, from the blue corner, Dr. P.K. Hazra, he will be presenting on drug platform, the dose, elution profile, and polymer, that is biodegradable, for polymer free are more important determinant with the availability of the new delivery system and catheter.
Right, thank you. When you have a high bleeding disk patient, there's no doubt that the newer stents like Onyx, Giants, Energy are better. Well, I try to put my stent in the perspective. When you started doing angioplasty, it was believed that the mechanism of balloon angioplasty was compression of the biological tissue with extrusion of water out of the biological tissue, and it was followed by a drug-eluting balloon or drug-eluting stents. And with that, we have moved so much in the knowledge and the development of stent technology. So this was the horrible journey how we had with the Cypher stent because of thickness and the durable polymer. But every history can go back to the origin of the history, and we can always criticize on the hindsight. And these stains, horrible stains like Cypher or Taxus, had very horrible polymer that was very thick and non-uniform. Now we have moved to a better polymer like your Onyx and Giants. We have also improved on the stain technology by putting a longitudinal stain where there is no hinge. When Pamaj and Richard was traveling in an aircraft, Richard asked the air hostess that how come these food trolleys are coming into line and without any like a rail, and there is zigzagging. The air hostess gave a simple answer that there is a hinge in between two food trolleys. That's how the Pamaj and Richard, they introduced the hinge. And with that hinge, you can track these stains. Now, after that, there are a lot of trackability problem has been solved with the Onyx design, start thickness. Now, we are actually moving towards no hinge stain technology. I'll be highlighting those technologies where the polymer, the stain technology has improved so much that it can be placed even the distal, tortuous, Seyfert-Krug, RCA, left cornea artery within the brain. So we have started our journey with 140 horrible stain, 132 is a horrible Taxus, disastrous stains we had, and then we have come down to 50. We had another disaster with 150 bioabsorbable absorb stain. Now we have 60 to 64, 65 is your biobind, 68 is a vivo stain, polymer free stain, dual drug stain. We have 70 micron, 71 micron is dynamics, bioadapter, and my next speaker, Dr. Professor Gambhir, will be speaking on 73 abluminous stain. The start thickness is important, but it's not that important because the synergy or your Onyx or your Giants varieties, they have kept the 81 micron as the start thickness. Now, what do you top it up? You top it up with the polymer on the both sides, on the aluminum sides. The thickness of the polymer is also important. Now, you have a DPDS, durable polymer DS, on ultra thin start would have been the best. Unfortunately, none of them are having a less than 70 micron start thickness. Perhaps the polymer which are durable takes care of the start thickness which is more than 70 micron. Disadvantage of bioabsorbable polymer taken care of by thickness of the BPDS. So this is the transitions of first generation to second generation, third generation. So third generation starts with Synergy. This is the only bioabsorbable DS, and which has got very high radial strength. It can expand to a larger extent. It can be put into HBR risk. And then we had these bioabsorbable polymers in the host exam study. It has shown there is no difference between biodegradable and bioabsorbable polymer. So all about giant stains, as I said, 81 micron, all about our DPDS, all Medtronic are DPDS, all Boston Promo series are DPDS, the durable polymer. The rest of the second generation stains are BPDS, including Boston Synergy. So these are the Indian stains doing very well, and these are the twilight stains. Many of these stains are not used in India. There are almost 30 stains. These are HBR patients. All are doing well. So stain is important. Start thickness is important, but not that important in today's perspective. I tell you why. So acute thrombogenicity, the gold standard was Giants. You see less stigmas, less stain on a Giants, whatever method you adopt. And it can be compared with Orsido, Ultimaster, Onyx. So there is drug dilutions, drug elutions, drug release, or aluminum surface, whatever method we have done. Giants remain the gold standard. You have the least thrombogenicity with the giant stain. Start thickness, as I mentioned, the fluoropassivation will remain there. Will be the next. We can improve upon fluoropassivation. For the time being, fluoropassivation is the gold standard. So drug elutions, what we have improved, you have improved the drug elution pattern, the drug dosage pattern. Like for example, Giant Sierra releases 1 microgram per millimeter square. The Chinese stent, Firehawk stent, is a very good stent for HBR patient. Martin Leon working on that. It is only 0.3, that too in the well. And 90% of the drug is released within 3 months. So after 3 months, you can safely, the Vivo ISR or the Firehawk, you can stop DAPT if the need arises. So abdominal concept was there to drug dosage reductions, but that is not enough. we found there's not much of big difference between the clinical outcome, POCO and DOCO, between BPDS and DPDS, as I mentioned. So what is important for the youngsters and the young fellows who are doing routine angioplasty, complex angioplasties, and this patient who is a doctor, 50 years, HBR patient, if you are putting a stent or drug-eluting balloon, you have to give a minimum 1 month of DAPT. Drug-eluting balloon is safer options in these patients, but if you're contemplating to put a stent, please do use imaging, and imaging is the only answer to reduce the doubt. It may not be the polymer itself, or drug or polymer free or luminous or luminous, stud thickness is important or not that important. So it can be, all the stents can be seen nicely with the OCT, and now we are moving towards the link-free DS, ultra-footprint DS, vasomotion DS without having a bioabsorbable scaffold, and biorotary stent. So this is the INR stent which is published in TCT 2022. There is no longitudinal link. It is glued or hold together by the polymer, so it can crack anywhere. And these polymers, can heal very fast with least inflammations on the vessels. And these are the stents where you have a very good optimal support, supreme flexibility, and allows vasomotions like your absorb or emirase, ultra low footprint with two markers, and it is porous. How low is a low enough dose to prevent ISR and promote faster healings? Now, if you look at the drug doses of Elunir, which was the first generation of this Iron Man, the Ionir is only 31 in comparison to Onyx and Giant. So drug delivery is throughout the envelope of these stents, not a patchy drug delivery. And it can be seen that in OCT they heal very fast. So this is again, this is a breakthrough technology. If you see on this side, there is vasomotions, and these are the link, and these glue are together for 6 months. And once the glue is absorbed, the polymer is absorbed, the hinges are free, they can move freely, and you get the vasomotions back. So dynamic stent has been promoted by Antonio Colombo in the EuroPCL last time, and these are another breakthrough where there will be no polymer after 6 months. The longer polymer you have to keep, because you have to keep these stents glued together for 6 months. So Vivo ISR is another breakthrough technology. You have a double drug, it's a polymer free, and we have the longest data so far as far as safety, stent thrombosity, and your mesh with Vivo ISR stent. So long journey. Now coming back to your HBR, you have this patient definitely in HBR. If he has got colon cancer, your Firehawk, the POEM trial has included cancer patients like AIDS, OAC, CKD, liver disease, etc. There's so many factors has been included in many trials. So it's not possible to understand each and everything. So whatever you have seen in this patient, definitely this patient is a high-risk patient. I do not mind if somebody puts Onyx or Synergy, but Vivo ISR also can be put there. So polymer-free drug-eluting stent yesterday in TCT-MD, the ISR test 5 trial has shown that is non-inferior. There's not much of extra advantage of having. So what is important? The stent commandments, like if you have amazing, if you prepare the artery very nicely, taken the calcium by Rota, master of Rota is sitting, legendary Professor Gambhir is sitting. If you prepare the balloon, prepare the lesions nicely, most of the newer generation stent can go into HBR patient. Now, imaging, bed preparation, choosing your right stent is important. Now, the packaging is also important. So this is a man who is a doctor himself, and he was in the team of Bush. George Bush had the 90% LED stenosis. He was asymptomatic. He was doing daily jogging, etc. And he did his treadmill test, and then he said, you have to go for angioplasty. So he did go for angioplasty, and look at this gentleman who was actually giving a brief on George Bush, the president of the United States, on how the stents are put in human being. He doesn't know even how to open a stent. So knowing the package is very important. I mean, what size you are putting, what is the expansion, I mean, how much a 3.5 can be expanded up to 6 millimeter in a left vein. So distal diameter is important rather than polymer itself. That is my take-home message here. So when I asked my chat GPT to write a poem on this man, the DS polymer, durable, bioabsorbable polymer, duration of DAPT, the bleeding ACS, a doctor, and RCA tortuosity. So my chat GPT wrote a poem for me. I got the latest tech that does the DS polymer, durable and bioabsorbable polymer, duration of DAPT bleeding. I can control ACS, RCA tortuosity on a whole. The chorus says, I am a mission to make healthcare great. With my technological advances, I cannot wait. Using my knowledge and honing my skill to make sure healthcare here to stay and will. So that means artificial intelligence will be applicable for difficult cases, for simple cases, use your simple brain. And there is a lot of simplicity in current generation. Thank you very much for your kind attention.
So, thank you, Dr. P.K. Hajra. So, next, Dr. D.S. Gambhir, I welcome for his talk on new generation abdominal drug elution with semi-absorbable platform in the DAS for such Indian patient.
Can you go into my talk? Well, friends, and good afternoon to all of you. You have heard the previous two speakers. Well, unfortunately, the first speaker was hinging his point of view primarily on the second part of this case, that is high bleeding risk. And Dr. Hazra was possibly more philosophical than coming on to the point. But I like his philosophies. He was not on the earth, but he was flying somewhere on the moon with some newer generation of saints, which I don't know whether they will come or not. But let me go on to straight away the subject. Well, we have a patient, the clinical profile is already with you. Let me just summarize for you the clinical features of the case. Because the primary objective of an interventional cardiologist in this case are three. A, how to approach this patient and get an acute result. He should be out of the lab with an excellent angiographic and clinical result. That's the first primary objective of the angioplasty. Second objective is that his long-term results should be good. He is less likely, or he should not be a candidate to start with. He should not be a candidate who should come back to you with a restenosis because it's a challenging case. And the third point is, of course, the high bleeding risk. He's a case for high, he's got certain factors which make him a high bleeding risk case. So you have to take all those precautions which prevent bleeding during the case and also subsequently manages the antiplatelet regime in such a way that he does not land into massive bleeding because he is a malignancy patient. So for you to summarize the case, let's say that clinically he is a diabetic, which should be taken into point. He is having non-STEMI. His anatomy shows that he has got a culprit vessel, which is RCA, which has got Shepherd crook. Now mind you, this is the important point. Every Tom, Dick and Harry interventional cardiologist cannot go and do a Shepherd crook, which is very tortuous. And lastly, the morphology of the lesion was that it is RCA 95% stenosis, which is long and ulcerated with a large RV branch. Well, with all these features, of course, it will be difficult or it was impossible for any one of us to get a case, but I'll show you a case almost akin to this. Besides this, he has certain high risk features for high risk for bleeding, comorbid conditions which you know, he had CA colon, history of chemotherapy and melena, and he was scheduled for GI surgery. Now, when I approach this kind of a case, the first thing is, as I told you, the success and safe procedure. And for success and safe procedure, you have to have an appropriate selection of the hardwares, including DES, and pre and peri procedural antiplatelet agents, because he is a case for high bleeding risk. And then how do you manage this now, or how do you de-escalate his dual antiplatelet therapy so that he does not bleed subsequently. Now, this is just to show you that how I have chosen a Amplas guiding catheter for a graft. Now, coming to a case something like this, which is almost like this, but of course, I don't know whether they saw my case and put it into the clinical profile, but I don't think so. This patient, first thing is you have to select an ideal guiding catheter. It should be it should not be Judkins, it should be Amplas guiding catheter 1 or a hockey stick. And you can see here, this is a Shepherd crook, or it's a partial Shepherd crook with a very tortuous artery, very highly calcified right from its proximal to the distal part, and there is a disease at the bifurcation extending into the PD. So almost like a RV branch. And guide wire should not be the routine guide wire. You have to pick up a hydrophilic guide wire. And stent should have all those features which I have enumerated in the last part. So what I picked up was abluminous drug-eluting stent plus, which because this is a stent which is different from others. It has got a abluminal coating on a stent, and not only that, it has got a fusion coating, which is means the stent is coated, but besides the stent, the exposed parts of the balloons are also coated with sirolimus. So it is a DES, and in fact, it is a DES plus drug-coated balloon. There is also a edge coating, 0.5 millimeter edge coating, which is protruding outside the stent, and the purpose of this is to prevent edge restenosis. It has got a biodegradable film, which, as Hazra has pointed out, doesn't make a difference whether it's a bioabsorbable or biodegradable polymer, and several studies are showing different results. And then, of course, the releasing pattern is very good. 50% drug is released in the first 7 days bus, and then the remaining 70% drug is released in the 48 days. And I'll show you in the last slide the histopathology from animal model. Now, so this stent has very highly flexible, it is conformable, remarkable side branch access. It has zero foreshortening and a good radial strength, and the strut thickness, as I already told you, is 71 microns. Now we have a clinical data to support what I'm saying. This is an enable registry, which is a post-marketing registry of abluminal DES plus, which was carried out in Gujarat by Dr. Sameer Dani. And you can see here that's a very large number of patients, more than 4,000 patients, and followed more than 2,000 patients followed up for 1 year and then 2 years. And you can see that all across the board, whether it was MACE, cardiac death, TVR, and stent thrombosis, they were all very low. The cyan bars, they indicate at 1 year, and the orange color bar indicates the outcome at 2 years. So all they were very acceptable. And even in diabetic, like this patient was diabetic, so we picked up the diabetic data, and out of these 2,000 patients, 855 were diabetic, and there was a promising performance of this abluminous plus across all clinical endpoints, even in diabetics. And when they compared with non-diabetics, the data was as good in diabetics as in non-diabetics. Now, this is my own experience. Of course, this is not been computed as yet. We are working on this. But this I want to show you the last, concentrate on the last column. Overall, this is a combination of abluminous plus nostrum stent, which is almost similar. All the other elution profile and stent platforms are same. So what I want to show is the success of implantation. Out of 113 abluminous, 112 we could negotiate the stent at the target site. So the success rate of implantation of stent was 99.3% with abluminous and 98.3% with nostrum. So with this background, let me take you to the case. So this is the case that we are talking about, almost similar case. Now we have to wire it with a hydrophilic wire, and after doing the wiring, the first thing was to prepare a bed for the stents to go, because we have to put stents right from the distal to the proximal part, and unless you prepare the bed nicely, unless you decalcify the vessel, these stents would be very difficult to negotiate down into the PT and PLV. So rotablation was done using 1.25 mm bar right from its proximal to the distal part. And having done that, we picked up abluminous long stent, 3x40. On your left hand side, you can see that it could go easily right across the PD and into the PLV. So that was the first stent we deployed. Then we deployed the second stent, which was also 3.5 × 40 in the mid part of the RCA, went easily. And then the point to be highlighted here is that we deployed the third stent through the first two stents and went easily into the side branch, highlighting that a stent can easily access the side branch through the stent that has already been deployed into the main branch. So side branch access is very easy with this stent, and that too has been shown in a distal vessel. And then lastly, we deployed a long stent at the proximal part of the RCA, including the ostium, and the ostium, as we'll see here, is very widely open, indicating that this stent has got a high radial strength. So this is the kind of result which you can expect if you do scientifically step by step from aorta to deployment of stent. So therefore the immediate results are excellent. So what we have seen in this case is that even a long abdominis DS plus can be deployed successfully in a highly tortuous and calcified arteries like this, with a shepherd or a partial shepherd group. It's possible to negotiate this stent into the side branch for distal bifurcation stenosis. Just one more slide, which is not the one. I'll show you another important feature as to how this stent can take the bends easily and can be. Now this is a left main bifurcation stenosis of moderate degree. And you see here that the circumflex 90-degree takeoff from the left main. And it's a very long lesion. It's not very easy to deploy a stent which is into a circumflex which is taking off at 90-degree, and that to a long stent. And see this sirolimus eluting abdominis stent has gone easily into the side branch and then was deployed. So this stent has easily trackable and this is the final result into the left main. Now, second part of the problem in this patient is the high bleeding risk. Now, the features have once again been highlighted that this patient had CA colon, history of melena, and he was planned for GI surgery. And all this make him a case for high bleeding risk. Now, these are my thoughts on a patient who is classified as a case for high bleeding risk. How do you approach this kind of a patient to optimize the results of PCI? First thing is the appropriate selection of DS, which I have already told you that abdominis I thought was one of the best choices in this patient. Judicious use of pre-procedure antiplatelet therapy. So you have to possibly give a serious thought on the antiplatelet therapy in such a case. And then appropriate dosing of the drugs, anticoagulants during the PCI. Maybe you may have to cut down the dose of heparin, unlike the standard dose. And then de-escalate the dual antiplatelet therapy in high bleeding risk. I need not go onto my own stand and show you that like Resolute Onyx has a data of 1 year follow-up with 1 month of dual antiplatelet therapy and then followed up with a 1 month, with 11 months of single antiplatelet therapy. But now I'll show you, it is beyond doubt that almost with all stents, the dual antiplatelet therapy can be de-escalated after 1 month. So pre-procedure in this patient we give clopidogrel plus aspirin is a good combination and a loading dose of 300 milligram. One should avoid potent antiplatelet agents like ticagrelor and prasugrel because this patient had a bleeding history of bleeding per rectum. And then thirdly one has to de-escalate of the DAPT after 1 month. Now there are ways to do this. The first thing is for 1 month you have to give a short-term DAPT with potent P2Y12 inhibitors. There are several trials, several combinations which have been done, which I will not go into the detail. One is aspirin. 1 month you give a DAPT, then after 1 month you give aspirin and decrease the potency of the DAPT. But again, it does not work because it leads to a high incidence of ischemic events. Other is you give only aspirin monotherapy. Although the bleeding risk events are reduced, but there is a higher incidence of ischemic events. Then the third strategy is you give only a clopidogrel therapy after 1 month of DAPT. This is okay, but not very high, a large volume of data is available. But possibly the best data is available from ticagrelor, which decreases the ischemic events after 1 month of single antiplatelet therapy. Ischemic events, there is no significant change, there is no significant increase, whereas the bleeding events are decreased. Now, lately, only the last month, there is a very interesting paper which has appeared in JACC, which is a P2Y12 inhibitor monotherapy versus dual antiplatelet therapy after complex percutaneous coronary intervention. And this is a meta-analysis of 5 studies. Where they have compared initial dual antiplatelet therapy followed by a monotherapy for 11 months versus dual antiplatelet therapy given throughout, both in complex PCI as well as in simple, non-complex or simple PCI. And they have given certain criteria for complex PCI, which I will not go into. Complex PCI constituted 20% of the cases and non-complex. Now, this was the result. They looked at the primary efficacy endpoint of single antiplatelet therapy versus dual antiplatelet therapy. And the efficacy endpoint was in terms of all-cause mortality, MI and stroke, and they find that this was similar between monotherapy versus standard therapy. This is regardless of stent that you have used. So therefore, any stent that you use dual antiplatelet therapy for 1 month and follow it up by a single antiplatelet therapy over the remaining period is as good as dual antiplatelet therapy. In terms of safety endpoint, they looked at the BARC type 3 or 5 bleeding, and they said that there is a reduction in bleeding with monotherapy. So there is an advantage of giving monotherapy after 1 month versus standard therapy, that is dual antiplatelet therapy, in both groups being complex or non-complex. So this is just a histopathological slide with abluminous, which they have done a histopathology in a porcine model, and they said that there is a complete endothelization at 7 days, good inhibition of new intimal proliferation at 28 days with mild increase at 90 days, low injury score and absence of any thrombus or any. So a 1 month DAPT followed by 1 or 3 months of DAPT followed by 1 month of antiplatelet therapy is being planned, and I think the trial will start very shortly. So in end, I will say, friends, my strategy for management of this case would be drug luminous stent like a luminous new generation stent with a stent strut thickness of 71 microns, which has got a drug both on the stent as well as on the balloon. And managing high bleeding risk, you have to avoid potent antiplatelet agents. And if you use a ticagrelor, go on to de-escalation to ticagrelor alone after 1 month of DAPT, and stop antiplatelets before surgery as defined in the literature: clopidogrel 3 days, ticagrelor 5 days, and placebo 7 days. Thank you very much.
Thank you so much, Dr. D.S. Gambhir sir. So coming to our text presenter, Dr. Chirag Seth, who is Chief Interventional Cardiologist at Cardiac Catheterization Interventional Institute, Rhythm Heart Institute, and he will be presenting, sorry, just I'm not able to read because of light problem, ultra thin stud dash with high bleeding risk evidence is most suited for the case.
So, thank you, chairpersons, moderators, and very good afternoon to everyone. The stage has been set by previous speakers, so I think the case has been elaborated, and my talk is going to be really, really short. So, stent selection bleeding risk case. This slide is very well known to all of us that high bleeding risk is defined as a BARC 3 or 5 bleeding risk of more than equal to 4% at 1 year, or a risk of an intracranial hemorrhage of more than 1% at 1 year. So this patient is definitely high bleeding risk because he is already having been operated for CA colon, and he is being scheduled for a non-deferrable surgery. So that adds to 2 components of high bleeding risk. And he is also at a high risk of thrombosis because he needs PCI to RCA for non-STEMI, and he is diabetic. So adding complexity, a young doctor by profession, shepherd crook RCA, ulcerated lesion, RV branch bifurcating. And we are not sure for our own population whether the so-called East Asian paradox, does it apply to our group of patients also or not? Meaning they have a low thromboembolic risk, but a relatively high bleeding risk. So what does an operator want? We want an acute success. We want easily deliverable hardware or stent, safety of choosing short DAPT therapy, and the data to support the decision. So among the ultra-thin stud stents, I mean, among the stents being studied for high bleeding risk patients, Synergy is the stent which is having the lowest thickness reported. The so-called ultra-thin stud stents yet do not have data as far as their safety in choosing this modality of a short DAPT in high bleeding risk cases. And that's why I think, based on data, I think we need to discuss about Synergy. Does Synergy tick all the boxes? So as we know, it's a bioresorbable polymer everolimus eluting stent, thin stud, 74 to 81 micron, depending on the size selected, whether it is less than 2.5 millimeter stent or more than 4 millimeter stent. Platinum chromium metal alloy platform coated abluminally with an ultra-thin bioresorbable polymer. And these features were associated with a favorable vascular healing, low thrombogenicity, and it allows for a shorter DAPT action duration. As we know, I mean, a lot has been discussed about stud thickness also, but just to put up here as a comparative slide, that among the three stents, Synergy, Xience Alpine, and Resolute Onyx, the Synergy is having the smallest stud thickness compared to Xience Alpine and Resolute Onyx. As per the design, the stud thickness, peak radius, and connector angles, they were designed to improve the crimping profile and deliverability over the Promus stent. And additionally, this Synergy stent is equipped with 2 additional connectors on the proximal 2 segments, and that gives it increased axial strength. And this overall design then maintains its flexibility and conformability, which are very important as far as the anatomy that we are encountering, a Shepherd crook RCA. So this is a comparative slide showing excellent conformability of Synergy in comparison to Xience Alpine and Resolute Onyx. Coming to the data, we have a senior study earlier reported with Synergy comparing with the bare metal stents in elderly patients. All of these patients were more than 75 years of age. Mind well, but currently as far as this BRC criteria is concerned, they are forming into the minor criteria. They are not in the major criteria. And in these patients, DAPT duration was for 1 to 6 months, followed up to 1 year. And the results showed that BRC type 3 to 5 bleeding rate was 3% and probable or definite stent thrombosis rate of 1%. And Synergy was proved superior as compared to bare metal in elderly that received a short duration of antiplatelet therapy. Next came the Evolve short DAPT study. And here also there were high bleeding risk patients, but more importantly, they had excluded MI and complex lesions, and they were given 3 months DAPT. Rate of stent thrombosis and bleeding, they were also significantly low, relatively low, but probably because the overall patients were a low risk group as far as bleeding is concerned. But at least it established that they have favorable ischemic outcomes among this selected group of patients when treated with short duration of antiplatelet therapy. After these 2 studies came the POEM study, which was reported in 2021 EuroPCR. And the aim was to evaluate safety of Synergy stent with, in patients with high bleeding risk with 1 month DAPT. And the study was powered for non-inferiority with respect to an objective performance criteria with a projected event rate of 9.4% at 1 year. And almost close to 440 patients, they were followed up and they were treated with 1 month DAPT. And followed up for, after 1 month, they were put on a single drug, which could be either 1 antiplatelet or even 1 oral anticoagulant without antiplatelet. The primary endpoint was death, MI, probable or definite stent thrombosis at 12 months. Importantly, this is a study which had included patients, almost 12% and 30% that you can see here on the slide, having cancer within previous 3 years, and those who were planned for major surgery in next 1 year. So this is one important subset which was included in this study, which are relatively lacking in other studies. An average number of criteria of patients having bleeding risks, they were 1.7 plus minus 1. Diabetics were almost 38%, and ACS patients were almost close to 34 plus 7. So that includes almost about 40% of patients were having acute coronary syndrome. So these data definitely helps us in choosing, making the right choice for the patient that we are discussing about. Sizable number of patients had complex lesions. Stent diameters were about 24 millimeter. Importantly, imaging was used only in 3% of cases. So it reiterates the importance of imaging in optimizing your results before deciding the optimum duration of antiplatelet therapy. So the result was that the rates of death, MI, and stent thrombosis were significantly low. And at the end of 1 year, the primary event rate was about 4.8%, which was much lower than what had been estimated about. And you can see from this slide that after 1 month, only close to 59% of patients were on single antiplatelet, close to 30% were on oral anticoagulants. This is the slide which shows comparative data of several other studies which have been reported about the 1 month or shorter duration of antiplatelet therapy in patients with high bleeding risk. And all across, we can see the data with Synergy stent, which shows relatively significantly low stent thrombosis rate and bleeding rate as well. So I think based on these parameters, it is safe to choose Synergy as a stent because it is going to be giving that comfort of tracking the adverse anatomy that we are looking for, side branch access, and the data that we have as far as the safety of 1 month duration of antiplatelet therapy is concerned. I'll come to the last point about this, that stent failures are a reality. All of the studies are, what we are looking at is about 1 month and looking at 1 year, but what about the scenario beyond 1 year? Whatever we are trying to achieve is a safety for early survival and looking into even late survival also. And stent failures are a reality which all of us have witnessed. This is one small image that I'm showing here is 68-year-old male. Earlier, Onyx was put in UK, that was 2.75 18 millimeter in proximal LAD. And he recently got admitted with anti-war MI. And what we find in the OCT study is that the almost initial half of the stent has been endothelialized, but the later half of the stent is completely denuded. It is not yet covered with endothelium. So this also happens. I mean, despite having all the data, you will come across some of these patients where the coverage with endothelium is not complete, it remains inadequate. Though the number may be small, but as the experience grows, we are going to encounter patients who are going to have late events as well. And that is not restricted to one stent. It can be with any other stent. It's possible. So what we are looking right now is the short-term data. We don't know about intermediate and long-term ones. We have had seen with stent failures with Zions also, short duration, long duration, possible. So though it is said that more than 90% of stent is covered, but what about that 10%? And how are we weighing that safety of stopping the dual antiplatelet therapy in short term versus intermediate and long terms? So I think we are still in a zone which is gray. And yes, as a clinician, we need to navigate uncertainties. And at least based on the current data, it seems from the discussion that has been already done and what we are trying to understand here is that it's true that yes, any good, any current generation, third generation DS, if you are putting it optimally with bed preparation and wherever possible with imaging to optimize your results, you are still likely to get good results, and it may be safer to discontinue DAPT after 1 month with some caveats. So questions to be answered, as has been already been proposed earlier also with Dr. Hajra's talk and Dr. Gambhir's talk as well, that will coronary imaging have impact in further reducing stent failures in HBR patients while on single antiplatelet therapy? Because ultimately with innovation in products, you have reduced the that risk of adverse outcomes. It is your job to do your job optimally. And that short of imaging, I don't think we'll be able to do it in the right way. So under expansion, malapposition, age dissection, however good the stent is, probably if you end up with all this, you are going to end up with adverse outcomes. And in less than 1 month, your adversities mainly happen because of thrombosis. Beyond 1 month, your adversities are going to be with more of bleeding issues. So I think it is essential to navigate that first month right, and thereafter probably you are able to sail through relatively easy if you have done the initial job right. And lastly, what about drug-eluting balloon, whether that can have a potential alternative option in hybriding risk cases? I think with these two questions, I end the talk here. Thank you for your patience.
Thank you, Dr. Chirag. The next speaker is Dr. Mamas A. Mamas. We have virtual presentation.
Hi, Dr. Mamas. This is Dr. Kamal. Good to have you, my friend from UK. And I have very high regards for him. And we'll have him live from UK. Thank you for joining on a Sunday morning. I know he had social commitments, but he agreed that he'll join us live. Over to you, Dr. Mamas.
So thank you, Kamal Sharma. Always great to see you, my friend, and congratulations to the prior 4 speakers. I've thoroughly enjoyed this session. I think a lot of valuable insight around this case. So hopefully over the next 12 minutes, I'm going to persuade you that we have to go with data. And the only stent platform that has this data specifically for this case is the Ultimaster platform. So really there are, it's a complex case. A 50-year-old man, diabetes, end-STEMI, ongoing pain, complex anatomy, who has colon cancer with a prior history of bleeding, and he's awaiting surgery. So I think there's 4 really key questions when trying to think about this debate, okay? It's a patient with colon cancer, ACS, complex PCI. So really the 4 questions we have to ask ourselves are, number 1, what is the risk of ischemic versus bleeding complications in this patient. Number 2, should we even be doing a PCI? Number 3, what platform should we be using? And number 4, the duration of DAPT. This patient needs surgery, so we would obviously want to have the duration of DAPT as short as possible, but is there data in this case to enable us to do that? And I'm going to go through each of these 4 questions. So the first question is, what is the risk of ischemic versus bleeding complications in this patient? Well, to answer this question, really, the thickness of the struts, the polymer, the drug, the stent design will absolutely have no impact on bleeding risk. And it will have a very small impact in the shorter term on ischemic risk in this case. The key determinants of bleeding risk are colon cancer and prior bleeding, and for the ischemic risk are ACS, diabetes, the fact that he has complex lesion, but also the fact that he's HBR. These are the main factors that are going to determine your bleeding and ischemic risk. And as 2 of the prior speakers say, also how we undertake the procedure. So Dr. Hazra and Dr. Sheff both highlighted intravascular imaging. These are the factors that will determine ischemic risk. The rest of the factors around stent design are largely irrelevant. So, in terms of bleeding versus ischemic risk, this patient has cancer. This is data from the Mayo Clinic 5-year follow-up data, and you can see that these patients with cancer at increased risk of both ischemic events, so increased risk of MI, stent thrombosis, but also bleeding events that you can see. In this patient, the patient's HBR, because he's got active cancer, he's waiting surgery, and he's had prior melena. So he's got 3 HBR criteria, very high risk of bleeding. What do we know about outcomes of patients with colon cancer? This is work from my group published in the European Heart Journal a couple of years ago, looking at close to 600,000 patients with cancer. So for colon cancer, in hospital, no increase in the risk of ischemic events, unless they have metastases, which this patient does not have. But in terms of bleeding events, very high risk, a 3-fold increase in the absence of metastases, close to 5-fold increase in the presence of metastases. Going out to 90 days, ischemic versus bleeding events, you can see that colon cancer has 10% reinfarction rate at 90 days and around 4 to 5% readmission with major bleeding at 90 days. So, these are high-risk patients. So in this case, the 30-day risk of bleeding events and ischemic events is very high. The absolute risk of ischemic events is probably greater at 30 days, but the relative risk of bleeding events is largest. It's about 7-fold increase compared to non-cancer patients. So really, what we want to do is probably aim for shorter DAT. The next question is whether we should be intervening at all in this case or whether we should manage medically. He's got active cancer, and then what platform, what duration of that? Well, I'm only going to show 1 slide here, and really this is the slide, again, my group has published looking at outcomes in PCI, in STEMI, but same for NSTEMI. And in colon cancer, you can see in this figure that the event rates in medically managed patients is much, much higher than in PCI managed patients. So according to the latest cardio-oncology guidelines from the ESC, as long as the patient has a life expectancy over 6 months, which in this case he appears to do so, then we should be managing PCI. So absolutely manage with PCI with the sorts of techniques that Dr. Gambir very eloquently discussed in his case. So the remaining questions, what platform, what duration of that? Now this is a key point of this debate. There are no head-to-head trials in cancer patients with ACS comparing strut thickness, polymer, stent design on outcomes, okay? Those are largely irrelevant. The question should be whether there is data showing efficacy and safety of short DAT in HBR patients, cancer patients, in high ischemic risk situations, such as ACS and complex PCI, compared to longer DAT. I mean, everyone assumes that we should be doing short DAT in this case, but none of the previous 4 speakers have shown that it's safe to do so. They've not shown that you have better outcomes in this sort of case compared to long DAT, and that's the key question. And secondly, what platform? So we've seen some of these studies already. We've seen Biofreedom, we've seen Seniors, we've seen Onyx. And these studies do not help us in this case. They do not compare long versus short stat. All they show us is what outcomes of one stent versus another at 30 days. They don't tell us whether we should be using 30 days DAT or longer term DAT. So the stents may be as good as each other at 30 days, or they may be as bad as each other at 30 days. What we need is good data to show that in such a case, with very high ischemic event rate, close to 10% at 90 days, that it is in fact better to go short rather than long. And only one platform has this, and that's the Ultimaster platform and the Master DAT data. So this is a randomized controlled trial comparing short DAT, so 30 days, versus longer DAT in high bleeding risk patients, which included cancer patients. And this are the main findings, showing similar MACE between the short and the standard DAT, but lower major bleeding. So the next question is, in this high ischemic case with an ACS, is it safe to go with shorter DAT? And the answer is yes. This is a subgroup analysis, the ACS subgroup analysis from the Master DAT trial, showing that there is no interaction by ACS. So in ACS patients with high bleeding risk, there's no excess ischemic risk if you go short DAT, but you still maintain the benefit of major bleeding reduction. Okay? The next part is there evidence that we can go short in the complex PCI group subgroup? And again, this is the sub-analysis from the Master DAT trial. This is how they define complex PCI. Our case probably would fill this criteria because it's a long lesion, so you're probably going to need multiple stents, like in the case of Dr. Gambir. And again, this trial shows that in terms of ischemic complications, there's no difference between short and long in the complex or non-complex cases, but in terms of major bleeding, the benefit is the same, irrespective of whether it's complex or non-complex. So in summary, the main consideration, or one of the considerations, is whether we should do this case. Yes, absolutely. The second consideration is whether we can safely reduce DAPT, even though this is ACS and complex PCI and the patient needs surgery. The only platform that has this data is the Ultimaster platform. I've shown you this data. No other platform has that data. I think questions around strut thickness, stent design, polymer, absolutely irrelevant to this. The key thing that's going to impact on this patient's outcomes are whether we can reduce that short and whether the platform that we're using has data in complex PCI, in ACS, and HBR patients showing superiority of short-term versus long-term DAT. And the only platform that has that data is the Ultimaster platform. I think what we've learned from this debate is, number one, imaging is key. I mean, Dr. Hazra showed great discussion around that. Dr. Chet, again, great discussion around that. I also think technique is key. Dr. Gambir showed a great case. Technique's going to be important for the success of the procedure, and Dr. Gambir showed, how to do this in terms of using good guide support, preparing your lesion with rotablation and so forth. But you can do that with any platform. So I rest my case, and thank you for inviting me to contribute. I can't hear any voice. Can we put the volume up?
Hello?
Yes, I can hear now. Well, I can't hear the speakers.
Hello?
Yes, hello. I can't hear anything.
Hi, Dr. Mamas. So the the perspective from this session is pretty much clear. Like there has been people saying about each platform, and each platform they have shown that works well. So whether you take the three big or four big multinationals, so Resolute Onyx has good data, Synergy has good data, Alpine, and if they bring Sierra to India, Xience would have good data, Ultimaster has good data. And even 3 big companies of India, Albuminous or Vivas are from Translumina, or even I think Tetrilimus and Cruise has similar data of crossability and everything. So the platform, particularly if it is under 70, 80 microns, is going to be a great selection in this case, because it would be easy to cross through Shepherd Crook and Torches vessel, and the endothelization is going to be quicker. So DAPT discontinuation would be fine. That is where I think Indian companies need to come up with more and more data. Like if they want to really prove that their platforms are equivalent to Ultimaster or Resolute, then they have to come up with better data. But theoretically, considering that they are pretty much on similar platform, everything is going to work well. So as all the speakers had said, and very important thing here, the optimization of acute result is important. So imaging is a must, because under expanded stent, even if it is Ultimaster, it is going to clog down. So an imaging guided optimum result after debulking would be the best way forward. Mammoth, yesterday you had said in our talk, eyes would see what the mind knows. So here we all have been concentrating on the high bleeding risk. Melena happened because of carcinoma colon. The surgery is planned after 1 month. So our high bleeding risk is going to be maximum for the first 1.5 months. But carcinoma colon, as Mamas has rightly pointed out, is adenocarcinoma, which has higher thrombotic systemic risk. So that risk is going to last forever. And that is the reason our selection should not be completely based on the higher bleeding risk. It should be based on improved acute result of the stent, and that stent, it will be pretty much safe to stop DAPT for a short period of time, and then later on even would take care of the higher bleeding risk. So with that, I think it's a good thing. I'll give it to my other friends.
Hi, this is Dr. Gambhir. Well, as I said in the beginning also, that while performing a case like the one which was given to us, one of the very important things is the skills of the operator, which none of us have mentioned. I think we have to be skillful to handle a case like this. That's something which possibly was overlooked by all of us. So if you're not skillful in handling this case, then I think it's better not to do it. Number 2 is the selection of hardware, which I have emphasized to a great extent, and my friend from UK has also emphasized that hardware selections is very important. If you just pick up a Judkins guiding catheter, is not going to cross a Shepherd Crook. So you have to pick up a appropriate guiding catheter and a tortuous vessel where you have to pick up a hydrophilic guide wire. The third factor, which I have already said, is once you have achieved the acute success, you have to look up at 2 things. One is thrombogenicity, and the second is high bleeding risk. We are playing too much of emphasis on high bleeding risk and on stent. I do agree that Resolute Onyx, Ultimaster and Synergy all have reasonable data, and possibly the best data is with the Resolute Onyx. Now they have 2 years follow-up with the Resolute Onyx with 1 month of DAPT. But then now we have enough data from other small studies also, and if you had seen my last slide, which was a meta-analysis of 5 major trials and incorporating more than 4,000 patients, and complex PCI, the ones which had 3 stents and more than 3 vessels treated. And they have found that whether you give DAPT, once you give DAPT for 1 month and then followed up by a monotherapy or a DAPT, monotherapy is superior in terms of reducing the risk of bleeding without increasing the ischemic events. So even in high-risk patients, so our patient falls into the group of high-risk patients for thrombogenicity because of its thrombus, because of its CA colon. So despite his being in the high thrombotic risk, if you give him a antiplatelet therapy for DAPT for 3 months, followed up by monotherapy for the rest of the period, I think he should be falling into a zone of neither increased risk of bleeding nor increased risk of thrombogenicity. So I think that should be the message.
Yes, sir.
I think this session taught us many things, the choice of stent. So what is the future? Future we have now ticagrelor antidotes will be available. There is study in Germany, if you have a known devil, like your devil is known now, he has got a cancer, it's better than unknown devil, like you do not know what is the origin of the bleeding. It's much easier to tackle. We have a cangrelor, you can breathe these patients, stop oral, then you can go to cangrelor. Or if he bleeds profusely on the table, you can have absorber, like ticagrelor absorbers are available. So during surgery, suppose you have dissected the left main and you are sending them for surgery, one patient is already loaded on ticagrelor. And what do? You take this ticagrelor out of the system by an absorber, like a cytoabsorber. So these are the new things will be available for very difficult patient, that to a doctor, 50 years at the prime of his lifetime. I completely agree with Dr. Mamas that he needs something to be done. Because chance of death due to ACS is much higher than chance of having death due to bleeding from a bleeding colonic ulcer. Bleeding colonic ulcer can be taken by endoscopy, colonoscopy, by glue, by some powder, they can do laser, etc. So many things. And at the end of the day, the science is progressing, so the stent and the philosophy. So philosophy, you're going to live without philosophy, sir. So philosophy first, then your technology.
So any comments from moderators, chairman? So we will conclude these sessions. Thank you, Dr. Mamas, Dr. Gambhir, and Dr. Azhar for excellent discussion about this case. We will move on the next session, that is live from the Hall A. This is very interesting debate between Dr. Anil Jain and Dr. Kamal Sharma on triple vessel disease for either do multi-vessel PCI or CABG. So we will go to online. Can we have one photo, please? Small token of appreciation and small gift for all moderators and chairmen is in conference kit. So kindly collect the conference kit from the desk. Thank you.
Okay, thank you everybody. Nice to see you.
Thank you, sir. Can we go online? હટાવવાનું છે. એક સેશન નીચે કરવી છે ને ઓનલાઈન કરવાનું છે એક જ ક્વિઝ બાકી છે કઈ નહીં ઓનલાઈન કરી દો અત્યારે ક્વિઝ પછી ઓનલાઈન કરી દો સેશન ઇઝ ઓલરેડી સ્ટાર્ટ નીચે સ્ટાર્ટ થઈ ગયું છે હા હા મોસ્ટલી સ્ટાર્ટ બસ ઓકે હા હા ઓનલાઈન ચાલુ દો always short of time. Online આવી ગઈ? Okay. Lunch
for more than 10 years would have coronary calcium score more than 100.
I guess felicitation છે lunch lunch પછી એમનો complete થાય
Because you can have data on
એ પૂરો કરે એટલે એમનું felicitation
they've been here for much longer time than the cardiologists. Surgery has stood the pressure and the test of time. Angioplasty has evolved over the last couple of decades, and I think see, so Kamal Bhai and Dr. Anil are already friends, huh? So there is no conflict of interest between the two. I think you are at good, we are very good friends. Great. I think Bansi Bhai has left. Otherwise, I would say the conflict of interest has now started for all the cardiologists because of Bansi Bhai's comment.
Should call Bansi and ask him to come back.
Yeah, before he comes back, we should finish the debate.
Yeah.
So this is a case, I think, traditionally, multi-vessel disease always have gone towards the surgeon side, and surgeons have years of experience. As I said, the angioplasty, the stents have evolved in the last 1 or 2 decades. But still, I think with the better stents, the better medications, the reduced cost of the stents, I would say, now the almost the same. So I would.
Good afternoon to all. Thank Dr. Kamal Sharma and Dr. Pai. I think this topic is, as you know, actually I am surprised there is a debate about it. Because I think we have all settled the issue, the multi-vessel is part. But since we have come to this thing, so this case is 37-year-old male without diabetes and hypertension, with a strong family history of CAD, with unstable engine and triple vessel, mid LAD 90, proximal LCH 80, and mid RPA 90. Type A, B, C lesions respectively, with right dominant substitution, with normal LP function, with passing LDL of 155. Now, best strategy would be, I think I'll start with Dr. Ranil Jain, and I think we will settle the issue once and for all.
Just 1 minute. And similar to bypass graft surgery in reducing all-cause mortality on long-term follow-up, 10 years of follow-up is available, may be considered as a viable alternative to CABG. I am not saying that it should always be there, may be considered. If the patient is less than 70, normal LV functions, low or intermediate syntax score, EGFR of more than 30, high risk for CABG and CABG refused by surgeons. These are the group of patients who could go to the angioplasty. So last slide, it's for you to judge. CABG on your left hand side, an old technology, and PCI on your right hand side, a new technology. You can see after 2 days, patient is saying, thanks doctor, bye bye, I want to go home and enjoy my life. Thank you very much. Well, I think since there is no opponent, there may be some surgeons here who may like to ask something. Only cardiology. So that makes my job more difficult or less interesting. Okay. Thank you very much. I think
Now, this was a talk actually rather than debate, because we had Dr. Gambhir. Sir, we need to felicitate you for this oration. This is a guest lecture which was given only for you. All the panelists, please be on stage. We'll
Give a big round of applause for Dr. D.S. Gambhir for his valuable presentation and all the speakers and chairpersons. So thank you so much, and now it's time to move ahead for the next session. For this session, I would like to invite all the chairpersons to come on stage, and once again Dr. D.S. Gambhir sir from Noida, Dr. Bhupesh Shah from Ahmedabad, Dr. Kilol Kaneria from Vadodara, and Dr. Mithilesh Kulkarni from Ahmedabad. So all the chairpersons, you are requested to come on stage. Please be seated, sir. And also I would like to invite a moderator for this next session, Dr. Suresh Bishnoi, Dr. Dignesh Vasava, and Dr. Himanshu Megnathi from Anand. So I would like to request all the moderators also to come on stage. And I would like to request the chairperson to give a brief introduction of the speakers, and please invite them for proceed further for the next session. And introduction slides will be featured over here on slide. Over to you. You record mic. Yeah, I'm giving you.
A very warm good afternoon to all. We would like to start the bout 26, and the case is as follows. A 70-year-old male has end-STEMI with 99% calcified tortuous long LAD lesion with TME2 flow with resting STT depression and deep T-wave inversions on ECG changes in anterior leads with a EF of 45% with positive biomarkers and positive myocardial perfusion, nuclear scan for ischemia at low workout in the LAD territory. So the topic will be best strategy for the plaque modification would be, and we have the speakers with us, and we'll be starting the first talk. On the blue corner we have the topic is rota ablation. Gold is the gold standard, as it is old is gold, and I would like to invite Dr. Anand Rao sir for it. He is from Mumbai, and he'll be delivering his talk.
Thank you very much. First of all, I would like to thank Dr. Kamal Sharma for having me over here. And it's an honor to be speaking in front of our teacher, Dr. Gambhir, and everybody. So, I require the permission of the scorers and everybody else to begin the bout. So, my topic is rotablator is the gold standard. Dr. Kamal had given me this case, and now I'm going to talk about why rotablator remains the standard of care. So, it's a 30-year-old technology which has stood its time. More and more devices are coming into the market. However, rotablator still holds its ground. Today we have IVL, then we have laser, we have orbital atherectomy, which some cases have been done yesterday. But Rota, I think, is still a gold standard, and I will prove and I'll convince you why it's a gold standard, because we have data. We have large data, we have 30 years of experience, and we are still going on and on. So if we look at this, rotablator was invented by Dr. David Oth in 1980, but it came into practice only in 1996. We have one of our pioneers in the country, Dr. Gambhir, sitting here, might have done the highest number of rotablators in the country as of now, right from... Yeah. So, I've been listening to his lecture from our DM days from first year onwards, so it's still the gold standard, and he can vouch for it. So there is a strong clinical data supporting rotational atherectomy use. So let me take you to some data and registry why I say it's a gold standard. Then I'll come back to the case which Dr. Sharma has put up. So if you look at the old trial, Rotaxis trial, which was there with rotablator with the Taxus stent, this is first generation Taxus stent, and with the other arm was PTCA plus Taxus stent with the rotablators, and the second endpoints, as you can see, is MACE at 9 months. So if you look at this study, rotablator with rotablator and without rotablator, the success rate and slow flow, no flow dissection perforation was all equivalent in both the arms. And if you look at the late lumen loss was comparable, and the other things like death, MI, TVR, everything was number wise, it was slightly better in the rotablator arm. P value may not be significant, but this trial showed that rotational atherectomy is here to stay for a long time. Then came Prepare Cal's study, which had comparison between a modified balloon, that is scoring balloon, cutting balloon versus rotational atherectomy, and they had a 9-month and 1-year follow-up, and then the strategy success was superiority. So if you look in the both the arms, the procedural duration, fluoroscopy time, contrast volume was more or less the same. What was good was large dissection was much lesser in the rotational atherectomy arm, and even the side branch compromise was much lesser. So we all have seen that in our day-to-day practice. Second thing was the strategy success was higher in rotational atherectomy arm because there was a lot of stent failure in a balloon angioplasty. They were not able to put in stents, whereas in the arm of rotational atherectomy, the stent failure was very, very less. So preparing the lesion and understanding the lesion, reading the angio properly, and taking the rotablator upfront will definitely take you in a long way. So if you look at the 9 months primary endpoint in stent late luminal loss at 9 months was more or less both were same. So primary endpoint for non-inferiority was met with no statistical significant difference for clinical outcomes at 9 months. Then came Euro 4C registry, which had a large number of patients, and this was analyzed for 30-day and 1 year up. And the second endpoint, the primary endpoints were composite safety endpoint, and in the occurrence of the MACE, which has been mentioned over here. Here, real world cases were taken. For example, patients with diabetes, peripheral vascular disease, chronic renal failure, and CTOs, left ventricular dysfunction, unprotected left main, all the groups were included in this. So, if we look at the in-hospital complications, more or less was safe. So, it was stated that rotational atherectomy had very low complication rates despite including a highly complex patient group. So, it also demonstrated that low complication rates were there in highly complex patient, and these were the all-cause death and MACE, which was all comparable. So Europe 4C takeaway points were real world data demonstrate that rotational atherectomy is safe and effective with low procedural complication. After 1 year follow-up, MACE were acceptable. Using IVAS and DES can further improve the outcomes. Then came ROTATE registry, which has included a large number of patients, 1,000 patients. And then the primary endpoint was, these are all registries, and primary endpoint was MACE at the end of 1 year. So if you look at the MACE, the in-hospital MACE, 1 year follow-up, 2 year follow-up, stent thrombosis were all acceptable. So rotational atherectomy results in high procedural success rate with acceptable short and long-term MACE. This was what was concluded from this particular study. What is interesting was, we have seen many European operators telling that once you think rotational atherectomy is needed, just go for it and don't make it as provisional. There's something called as rota regret. You know, we've gone through it once in a year. We go through rota regret, and we always sit back and think and realize that we should have used the rotablator upfront. So what happens if you use a rotablator upfront? The pre-dilatation balloons are less, your procedure time is less, fluoroscopy time is less, and contrast volume is less. So the overall outcomes are better in terms of all these modalities when you use rotational atherectomy upfront. SCAR was a very interesting study which was published in 2020. So this was one long-term data started in 2005, and then they studied the patient up to 2016. So divided into 3 group of patients depending on the time duration, and then they looked at the MACE, 4-year MACE, and the second endpoints like major non-CABG in-hospital bleeding and major and minor in-hospital bleeding. So what they saw, there was an increase in the procedures with rotational atherectomy. So in 2005 it was only 0.5, and 2016 1.2. So there was a jump every year in the use of this device. Then adjunctive device were used, especially more of transradial, drug-eluting stents, and of course imaging, which was adapted. Then complexity, more and more tough cases were addressed with rotablators, advanced aged and comorbidities and high risk profile. And improving outcome rates were also there. So these were from 2005 to 2016, the complexity and everything went on increasing. So if we look at 3-year cumulative restenosis rate, right from 2005 it was 11.1%, which came down to 4.1% in 2015. Obviously we know the reasons, because the improvement in the stents, the imaging, adjunctive devices, and so on and so forth. Even the MACE from 34.2 in 2005 came down to 29.2 in 2015-16. Other complications were also quite comparable, and despite increase in patient complexity, major in-hospital complication remains low. Then there was a major debate about low speed and high speed rotablator. So low speed, now I think, of course, sir will tell us that I used to do a rotablator for all the patients at 180,000 revolutions. But now I realize 160 is better, because the slow flow and distal embolization is much better with the slow, the speed less than 160. So this was one arm where they used speed of 135,000 per minute, and with conventional balloon angioplasty, and they followed this patient. So the low speed showed good outcomes in terms of reducing probably slow flow and no reflow and distal embolization. And among the there seems to be a trend to increase in the survival in patients with when used with low speed ablation. Then there was an issue about operators who are doing large number of rotablators versus operators who are doing less number of rotablators. So what happens to this kind of outcomes? So this was in the UK National PCI Registry, where they divided into 4 quartile: high volume, moderate volume, low volume, and very low volume operators maybe doing this thing. But what they saw, even in this kind of subset, the complications rates were low, despite this significant less in-hospital MACE and major bleeding as as the operator volume increased. So what are the advantages of rotablator apart from the robust clinical data and 30 years of experience? Easy device trackability post rotablator, we have all seen that. Time tested therapy for intracoronary calcium is cost effective, US FDA approved. Of course, my colleagues also will argue that IVL is also US FDA approved, but we'll talk it at the rebuttal. Forward burrowing motion, optimal bed preparation calcified segment, differential cutting, long diffuse calcified lesion, as this case we'll discuss. Limitations are deep calcium, steep learning curve. I don't know whom to blame this, but I agree with this, because a lot of people have not been exposed to this in spite of being 10 years of practice. There's limited number of people kept it in their pocket and they were doing all these things. So this point is blame for ours. Pre-existing dissection in lesion segment. Well, not all dissections are contraindications to rotablator. Maybe non-flow limiting dissection, we have done it and we've been doing that. Wire uncrossable lesion, yes. SVG grafts, yeah, we have no experience and we don't do this. In-stent, we are doing that now. After the imaging has come, we have been doing in-stent. Maximum burst size available is 2.5. That too very rare. Even 2 millimeter bursts are not available sometime. So I don't have the same case, but I had this similar case which Dr. Kamal Sharma mentioned. 70-year-old patient, NSTEMI, and if you look at this long calcified stenosis, and he said NSTEMI, and as you see the TIMI flow in the LED is not very great. So it fits in all the criteria of Dr. Kamal Sharma's case. Now, from which angle does an IVL will actually go into this? So, if you are given an IVL and rotablator, obviously the first choice is rotablator. There's no question about it. So, one of my colleagues started pre-dilating it, and I was not there at this time. And he started pre-dilating. If you see all the things, and then after pre-dilatation, nothing could go in. Even there was a great difficulty for the microcatheter to go in. Probably there were nodules all over the place. So this was a situation. So what do? So I jammed the microcatheter halfway through, and then fortunately the rota could go in, the rota wire could go in, and this is a 1.5. I'm not showing all the details, but this patient had adequate dissection in spite of that, but we had no choice. The nothing was going in, NC balloons were not going in. So this is a 1.5 burr, went all the way beyond the mid segment, slow pecking and taking own time and make sure you don't get into complications. So as you can see, post rota, obviously there's a lot of things happening down there. The flow is reduced, but all those things can be taken care. So serial dilatation with 2, then 2.5, then probably we used 3, so you can see all those things. Then we used OP and NC balloon in the mid segment over here. I was not sure, but cutting balloon, but however OP and NC balloon went in, and after that plaque modification, TIMI3 flow came, patient was stable, and now we are all ready to go ahead and put stents. So this is a distal stent, long one, and this is a proximal stent, and then optimization, and this is how the result looks. Good TIMI3 flow and no compromise of the side branch, and no edge dissections. I'll come back to the slides in the rebuttal, but however, rotablation is a useful, indispensable device in intervention treatment of heavily calcified lesions and essential tool for complex PCI. Optimal technique and strategy are pivotal to avoid any potential complications. rotablation remains an important rescue device in uncrossable and undilatable intracoronary lesions. Rotational atherectomy is prone technology with huge global database. Rotablator is cost effective. Do I say anything more? I think the knockout is already there. Thank you.
Give a big round of applause for the speaker. Sir, there is one changes in the agenda. Only we are going to play 2 to 3 minutes of video over here as suggested by Dr. Kamal Sharma of Advanced MedTech Solution. So just for next couple of minutes or 3 minutes, we are going to see that video, and later on we'll proceed further for the next session. Sorry for amendment in this session.
The desire to make a difference in patients' lives led to the genesis of Advanced MedTech Solutions. We are dedicated to advancing patient care by manufacturing value-driven medical device technologies to serve the needs of more patients and healthcare professionals. We provide healthcare professionals with the right tools and enable them to do what they do best. The heart of the mission at AMS is to impact the global patient by optimizing patient outcomes through quality, affordability, and accessibility. AMS was founded by an elite team of respected industry leaders and visionaries who understand the challenges of the current healthcare environment. Our new state-of-the-art facility is equipped to manufacture a cutting-edge class of medical devices that meet the most stringent global standards. This eco-friendly manufacturing plant is singular in design and distinguished in efficiency. It serves as a technological and educational hub, focused on the medical science fields of surgery and interventional cardiology. Reaching out to healthcare professionals and providers around the world, AMS offers a compelling choice with a corporate and social responsibility founded on advancing the way we care for generations to come. The design
Hello. Okay, so we are done with the blue corner. Now we would be moving to the red corner, and the next speaker is Dr. Vipul Kapoor sir from Ahmedabad, and he will be speaking. IVL is a game changer with minimal risk.
So good afternoon, everybody. Thank you, Cardiocon, for having me as a speaker here in this August conference. Respected sirs, Dr. Gambhir sir, and seniors like Dr. Anand Rao, who just preceded me, and my dear colleagues and juniors who are gathered here. By the time they get my slides ready, I would just like to mention the blue part has already accepted, I believe, a knockout. The only change constant in this world is change. So 3 decades of a device or a therapy does not mean that there is no place for a new therapy. And we clearly know that new therapies are here to stay. And we know that for not only for calcium, but for all other modalities of treatment that we interventionalists are gathered here for. So my job is much easier because my preceding speaker already confessed to certain problems with the therapy that he was so confessing about, and which he very conveniently, hid certain parts of the talk, under the garb of, you can say, effectiveness and, ease of use. When I'll show you my slides, and also I will show you the same slides which he showed to a certain degree, because data is like a mini skirt, right? It hides more than it shows, isn't it? So, or the other way around. So, we can look at the data in both ways, and, we can still have a different picture. And by the time that we start, we as patients or as young interventional cardiologists who have just passed out, by show of hands, we can say that if given a choice, say possibly if you leave out a cost to a certain degree, and with the ease of use and the learning curve, if given a choice to use ROTA or an IVL, what would you actually use if given a choice? Please raise your hands as a patient or even as an interventional cardiologist. Raise of hands. Nobody will use IVL. All will use ROTA. Don't be afraid. Sir is our friend only. He will not physically harm you.
You can ask this question later on.
No, I can start with straight away.
Or,
Yes, sir.
Let it be left to
Yeah, sure. All right. Yes. Okay, so looking at this case, we didn't have the images, but we assume that the clinical details were something like these. A 70-year-old gentleman who presents with non-STMI, ST depression and deep T wave inversion in anterior leads on ECG. EF is 45%. Positive myocardial perfusion nuclear scan for ischemia at low workload in LED territory. And the angiogram presumably, so we are assuming certain things, is a 99% calcified long tortuous LED lesion with already having a slow flow, a TME2 flow. So there are certain things which you can clearly focus on. You know that there is a clinical presentation, patient has a chest pain, is a significant angina, already nuclear scan is positive, so there is definitely a problem there, needs to be tackled. And if you look at the angiogram, clearly mentions that it is a critical lesion, there is a long tortuous LED with pre-existing TME2 flow. Unfortunately, we do not have any imaging data, which as a preset with Dr. Gambhir also mentioned, with left main plasties, not all are same, but yes, imaging is here to stay and is an important part and parcel of all chip cases. So any calcified lesion which you treat today without imaging, you only are looking at part of it. You really do not know what is going on there. You do not know what amount of calcium it is, what type of calcium it is, what is the thickness of the calcium, and actually which segments are the ones which are most calcific and require the most amount of therapy. And again, financial situation we do not know. So these are issues with this particular case, which would guide us in selecting the type of therapy that we would look into it. So now, what are the implications of coronary calcification? Before we go on to the modalities of therapy and looking at this particular case and comparing the therapies, what are the implications of coronary calcification? Why is it important and what do we need to do about it? So if you look at coronary calcification, what it actually results, we all know here that it results in impaired stent delivery, there is a decreased stent expansion, there is increased malapposition and stent asymmetry. So ultimately you do not only have acute procedural complications, but there is also long-term problems in the form of stent thrombosis and restenosis. So when we look at this slide, you just concentrate here, you can see that with the arc of calcium going up, you can see that the stent expansion at a standard expansion rate of say about 16 atmospheres, you could see that the stent expansion percentage goes down, right? And same way as the arc of calcium increases, the stent expansion percentage goes down and the use of therapies like say rotablation, for example, the use of therapies go up. So it is very, very clear that you need to do something for a certain arc of calcium, but you can't assume this on angiography alone, because angiography is just an estimation of the amount of calcium. But whether it is adventitial, whether it is intimal, whether it is medial, whether it is a circumferential, whether it is a localized, whether it is a nodular, eccentric calcium, we simply cannot judge only from angiography alone. And that is why, when you compare coronary calcification vis-a-vis no calcification, you could see that the acute result or the target vessel failure is much higher in the presence of it rather than in the absence of it. And similarly, when you look at the particular trial, a large trial like an ADEPT-DEST trial, you look at the event rates, and if you look at 2-year events, they were so high when you actually put in an underexpanded or a malapposed stent. So it is very, very clear that you need to do something for these particular patients because they are simply very, very high risk patients. So what do you require for a preparation of a lesion? So you require a luminal expansion and you also require a plaque modification, right? Because it will facilitate your procedural success, and further it will also minimize the vessel trauma, and thereby you will achieve what is the goal is to achieve a higher MLD, right? Post calcium modification. So that is what is achieved by these therapies. So now when we look at these therapies, what are the treatment modalities which are available to us? So in the present scenario, you could see that, when you look at imaging and when you look at these stents, it is such a hard, calcium is such a hard substance. It's almost like a bone. When you put in and when you pull out material like this, you can actually have something like this. So it is simply very, very abrasive and something needs to be done for it. So what are the modalities? You could clearly see we have got NC balloons, good quality NC balloons now coming in. We have got cutting and scoring balloons, right? Like say angiosculps and Scoreflex and whatnot, right? We have got laser, as sir mentioned. We have rotational atherectomy, which has been there with us for the past 3 decades. And we have orbital atherectomy. Now we have got laser atherectomy, which has already started. We have already done orbital and laser cases, right? In the near past. And now we also have IVL, not to say the least, right? Which is intravascular lithotripsy. So when you look at the guidelines also, what do the calcified PCI guidelines mention? When you look at a cutting balloon angioplasty, right, there are limitations to it, right? Certain osteal lesions, fibrotic lesion, moderately calcific lesions, it may simply work, or as an adjunct to a rota or an IVL, right, cutting balloons may work. When you look at rotational atherectomy, it is clearly mentioned that it might technically be required in cases of tight calcified lesions to allow subsequent passage, but it should not be performed routinely for de novo lesions or even in in-stent restenosis. So obviously there is an acceptance to a C, that heavily calcified lesions wherein nothing else goes before your stent implantation, there is an acceptance that rotational atherectomy has its place, but so does IVL, right? And there is these techniques do not fight with each other. Basically they are meant to be used synergistically, complementing each other, right? And they are good technologies to be used in a justified manner in the case in which one justifies the other. So that is how we should proceed. If you look at the strategy for calcified lesions, right? If you look at PCI, you have taken a patient, you have done an angiogram, you find angiographic calcification. If you look at if it is a mild appearance of calcification, possibly a non-atherectomy strategy would work. If it is a moderate, that is where the problem lies, whether you take an upfront decision or whether you would possibly go with a non-atherectomy first. But here imaging would help you. Look at IVUS or look at OCT, which would be even better possibly. And then if you find it is mild, then possibly you can go for non-atherectomy. But if it is moderate or severe, you can straight away upfront go with an atherectomy strategy, right? And ultimately also when you, in Sir's case, as he had a strategic failure in his case, you could straight away go to an atherectomy strategy. So the strategy for calcified lesions, people who go out of this room should have a very clear idea what device to use when and what strategy to use. And that should be the purpose of this particular debate. Right? If you look at rota, as sir mentioned already, invented history, everything is there, but there are limitations. We have already seen the indications, but we, didn't concentrate much on the limitations, which I would be focusing on so that we know, and in this particular case, they are particularly very relevant. So there is slow flow. In our case, it is already present. There can be perforation, there can be CPKMB or troponin rise, so there can be evidence of MI. There can be spasm and dissection. There it is a technically challenging, which are already accepted that it's a steep learning curve. So this is something which we already know and we already accept. And there can be heat generation. When everything rotates at about 160, 180, there is going to be a heat generation, right? Contraindications, we have already seen that, sir already mentioned, eccentric lesions and tortuosity, which is already there in our case mentioned. So there is a tortuosity and therefore possibly to a certain degree a limitation, I would not say a contraindication. Important trials, already mentioned by sir, lot of trials he mentioned. I will just show you a few trials, and what he showed was that the choice of a burr is very important. So ultimately, how does that come from? That comes from the operator experience. Not anybody can use a rota straight away. First case I will do rota is not possible. You require a learning curve with it. While we have grown up with balloons, we know how easy it is to use balloons most of the times, but with rota you require some degree of experience. So choosing an optimal to artery burr is very important, because if you not do that, then you can have problems with the burr, you can have entrapment, you can have stalling, and you can have so many other problems, even perforation. So all those things are very important. So ideal optimal burr to artery ratio is very important. And if you look at the same Mount Sinai experience, you could see that over a period of time, if you compare 94 to 2007 and 9, as they got experienced and they used lower speeds, right, their results improved. Otherwise, they had high results of slow flow, they had major complications and also perforation. But over a period of time, those results improved. So clearly shows that operator experience is very, very important. And if you look at the rota and BMS and DES data, you could see that all of these trials have shown higher MI rates, post-procedural MI rates, everything, because the debris simply goes down into the system. So obviously the MI rates are going to be higher, stent thrombosis is possible, but to a certain very low degree. 30-day MACE events, and if you look at TVRs, right? With DES, obviously the rates were lower. If you look at the Rotexus study which sir mentioned, it was efficacious, but at the same time look at the complication rates. When you look at a PTC and a Rota, right, the excess site complications, the MACE events, if you look at death and MI comparable, but you look at the TV re-PCI, all of those things, Rota PCI, you can have a marginal incidence of perforation or a burr entrapment, and you may require an emergency bypass surgery. So albeit small, but there are incidences of grave complications which do happen, particularly with inexperienced operators, wherein Rota use may lead you to trouble. If you look at the complications, now Rota, when you use at complications, you have to be aware of. You may tackle them, but you need to be aware of. You just can't go blindly. So you can have bradycardia, AV blocks, you can have slow flow or no reflow, you can have vasospasm, you can have dissections, perforations, side branch occlusions, hypotension. Now these are the ones which are very, very common and which are related to the particular patient subset also, as well as due to inherent problems with the Rota system or the technique, the technology itself. And then there are also the possibilities of burr entrapment, burr detachment, burr stalling, and the guide wire fracture. In short, I will just cover all of these things. The problem is, these complications. If you look at bradycardia and AV block, we know that it is more common with RCA, and it can instantly occur after activating the burr, or it can follow a slowing trend of the burr. So there are problems, we need to tackle them, we need to be aware of. What are the mechanisms? Most of them are unclear, but there are various theories. It is said that microparticles can interfere with the vessels which are perfusing the AV node. There are possibility of vibrations at the heat of the burr itself which can cause a reflex bradycardia. So this is bradycardia, slow flow and no reflow, very common. We saw in Sir's case as well, and already this case has some slow flow. So it is observed in 5% of the patients who are undergoing treatment with rotablator. And how it is identified is by the diminution of flow by 1 to 2 timigrades, and no reflow is a complete cessation of flow into the distal vessel, and thereby you can have a patient can have chest pain on the table, there can be STT changes, there can be hypotension. All of these things are possible. What are the mechanisms? Plaque burden, long lesion. In this particular case we already have that. Non-STMI thrombosis can already be there. Long ablation time, vasospasm, platelet activation, microparticulate aggregation, and in the previously infarcted segment, if you treat it, you can definitely have more chances. Dissection, 10%, we already know, because of the guide wire bias, you can very easily have a dissection. You can see this tortuous vessel with the wire bias, it can hug the side wall, and it can actually burr the normal vessel as well. So dissections are possible, and you may have to deal with it. Perforation, dreaded complication, 0.7% from the multicentered registry, less than 1%, but definitely known and can definitely happen. And typically in severely angulated lesions, perforations are typically more common, and particularly if you oversize the burr as compared to the vessel size, then it can definitely lead to this. Side branch occlusion, yes, definitely possible, because the burr can actually go there, and you can have the problem with the side branch. Hypotension with vasospasm, bradycardia, slow flow, inadequately hydrated patients, or large doses of vasodilators, you can have hypotension as well. And further, as I mentioned, you can have system failures like entrapment, detachment, stalling, and also guide wire fracture. So I will not go into too much details of those, but yes, they are possible with rotablation. So just to list the potential disadvantages, the first thing that I would mention would be a steep learning curve, which quite a few people, and thereby there is an inertia to immediately initiate with rotablation. Operator experience and acquaintance with technique is essential for good acute and long-term result. Relatively cumbersome and a meticulous setup is required. It is not just that you get in, chalo rota karte hain, and then you get a rota done. It's not that way. You require lot of equipments there to be set up there. Long list of potential complications, but yes, the new Rota Pro, when we talk about cost, even that cost differential has now come down when you compare to vis-a-vis IVL. And psychologically, just that simple concept of, if you ask a patient or a person in particular, you can ask him whether you would like that idea of a drill going inside. There might be some inhibition as well. So all of those things are there. So what next? What option do we have now? So if you see, this is lithoplasty, lithotripsy, and a comparison, if you see, it is just a balloon which all of us are ingrained with, all of us are trained with. It is a simple balloon, where you have got those sound transmitters, and the basic mechanism is you are not breaking anything, you are just cracking something so that the next modality can just take over, right? So therefore it has its set of problems, but then it doesn't mean that it is to be shunned off just because that it is a little bit more expensive. But if you look at the advantages the convenience and the less steep learning curve that it provides, I believe this technology is here to stay, and it will knock out anything there which is there existing. So you could see the cracks of calcium that this produces, and with beautiful safety outcomes with the Disrupt CAT trial, you could see that the MACE events, perforation, and whatever complications with rotablation had were not seen with IVL. So therefore, the problem can be that eccentric calcium, and you could see that non-crossable lesions, IVL may have a problem, but vis-a-vis, if you look at rota, you can see thick focal circumferential calcium and the depth of calcium and deep calcium. This is the therapy which scores clearly over rotablation and will be the modality of choice when you look at deep calcified lesions. Summary and conclusions. I think I can also answer in rebuttal, but yes, extent of this is, I already have covered most of the things, right? It is a synergistic technique. We can combine both of them in certain particular cases, and then you can possibly do a rotatripsy. In this particular case, I am pretty sure that if the balloon can go in, IVL will definitely go in, and we would avoid, slow flow perforation dissection in this particular case, as mentioned above. Thank you.
Thank you, sir. Now I'd like to call upon the next speaker for the yellow corner. We have Balloon in Balloon is a much cheaper and effective tool, and the speaker is Dr. Prakashveer Parekh from Ahmedabad.
Good afternoon, Chairperson, moderators, and all the colleagues. Sid, you heard the previous two talks. We described in detail the technology which we use for the calcium, that is rotation atherectomy and IVL. I'm going to speak about very unique technology which is very simple and still very effective and not expensive. Okay. So, the implications of coronary calcium. If patient is moderately or severely calcified artery, then makes the procedure very difficult. It's very difficult to get a good acute outcome, as well as if you don't get a good immediate outcome, then chances of getting a long-term outcome are also very poor. So basically, how to tackle the calcium? Basically, broadly we have two technology. There is balloon-based techniques and ablatory techniques. The ablatory techniques, they reduce the calcium burden, is the basically calcium volume reduction. In addition, they also they are effective in creating cracks. So most commonly used technique in our country is rotation atherectomy. Other techniques are orbital atherectomy and excimer laser. While the balloon-based techniques include non-compliant balloon, super high pressure balloon, there is open NC balloon, different scoring balloon as scored flex, cutting balloon, angiosculpt, NC alpha, and the latest addition is intravascular lithotripsy. So balloon-based techniques, how they work in the calcium? They do not remove the calcium, but because of the high pressure which they generate, they create the cracks in the calcium. And if you create the cracks, then only you will be able to expand the lesion and the stent. All these balloon-based techniques have advantage because they are very simple to use. Everybody can use it, and they are user-friendly. Today I am going to talk about the open NC balloon, which is unique Swiss-made CE-marked plaque modification device, which is highly non-compliant to ultra-pressure double-layer balloon. So what is unique about this technology, open NC balloon? There are two layers which gives good power to the balloon. In addition, despite having two layers, it's a very low balloon profile. The crossing profile is very less, 0.228 inch only. Lesion entry profile is also very low, 0.016 inch. It got 2 folds in the small diameters and 3 folds in the large diameters. And got 2 markers, even in small size, it got 2 markers, so you can precisely place the balloon. So these are the 3 important features of this technology. It's a twin layer, linear compliance, and increased tensile strength. All these 3 things are very, very important when you are going to treat the calcium. Ultra pressure, the highest rated RB blood pressure of 35 atmosphere of pressure among all the balloons available in the market. And because of high pressure, RB high pressure which you generate in the balloon is able to crack the cracks in the calcium very easily. And each balloon is factory tested at around 45 atmosphere of pressure. And the cardios have used even the higher pressure, 50 pressure with the OP-enhanced balloon with a success. Second important feature of this technology is uniform expansion with virtually no dog boning. So it creates less dissection and perforation. The conventional non-compliant balloon, though they are considered non-compliant, but when they are infected in a calcified registered lesion, they do develop dog boning at the end of the balloon because of very resistance lesion in the center of the lesion. While the OP-enhanced balloon, there is virtually no dog boning. Even if you go to very high pressure like 35 atmosphere pressure, there is linear compliance and cause no dog boning, so it is very safe. So less chance of perforation as well as the dissection. And the third important feature of this balloon is ultra-low compliance. It is called linear compliance. It goes less than 10% even at pressure as high as 35 atmosphere pressure. It is the lowest diameter compliance rate over the largest pressure range of any PTSA balloon on the market. As you can see, the compliance cover OP-enhanced balloon with all size, even if you go from 10 atmosphere pressure to 35, it grows less than 10%. So that increases the safety of the procedure as well as the efficacy of the procedure. It has got the highest working range. If you compare to the other conventional non-compliant balloon, their working range is nominal pressure and rated burst pressure. RBM minus nominal pressure is the working range of any balloon. So the conventional enhanced balloon, the working range is about 8 to 10 atmosphere pressure, while the OP-enhanced balloon, the working range is very high, about 25 atmosphere pressure. So there are certain tips and tricks of using the OP-enhanced balloon in calcified lesions. Avoid polymer sleeve wires because when you go to high pressure, it compresses the inner lumen and sometimes it's difficult to remove the balloon from the wire. So if you are going to very high pressure, more than 30 atmosphere pressure with OP-enhanced balloon, it is always advisable to keep one extra wire along with the previous wire. So in case your balloon is stuck on the wire, you can easily remove it without any losing the access. Use extra support guide wires so you can easily access the lesions. Always start from a distal lesion and then come back proximally because once you inflate the balloon, the profile worsens. Always increase the pressure gradually. For first 20 atmosphere pressure, you can increase it very fast. But once you reach 20 atmosphere pressure, then increase pressure very gradually, every 5 atmosphere for about 10 to 20 seconds. And allow balloon to work and deploy before increasing pressure. Meaning that even if your inflation device shows the pressure of 30 atmosphere pressure, the same pressure may not be available in the balloon at that time. So better to wait for 5-10 seconds so the balloon is, the pressure in the balloon, inflation device gets transmitted to the balloon. And the sizing of the balloon is also very important. With the perforation with the open-enhanced balloon is not related to the pressure, but is related to the size of the balloon compared to the diameter of the vessel. So pre-dilation and treatment of ISR always use 0.5 meter lesser diameter than the reference vessel diameter. And for post-dilatation, you can use 1:1 balloon to vessel ratio. There are a lot of reports, someone registry data and anecdotal case reports with OP-enhanced balloon in resistance calcified lesion. There is only one small ISR randomized trial in which they compared the OP-enhanced balloon versus the scoring balloon to prepare the severely calcified coronary artery lesions. All these patients initially had a treatment with the non-compliant balloon, and on the failure of non-compliant balloon, the patients were randomized in the two groups. The OP-enhanced balloon group and the super high pressure balloon was used, and the other group they used the NSC alpha balloon, which has got 3 scoring nylon elements. And with the OP-enhanced balloon and NSC alpha scoring balloon, there was comparable stent expansion on intravascular imaging. However, angiographic performance was slightly better with the OP-enhanced balloon compared to the scoring balloon. This is a pooled analysis of 2 trials, which my previous speaker has described, the prepare care study and resolve care trials, in which total 274 patients were assessed, and out of which only 200 patients who had OCT image available after stenting, they were included in the pooled analysis, and it showed that the rotavator was, though it was more effective, statistically 100% compared to the OP-enhanced balloon or the modified balloon. However, the stent expansion was similar between the 3 groups, rotavator, modified balloon and super high pressure balloon,
while stand extending index was better, much better with the open inseable compared to rotameter as well as the modified balloon technology. So now with this brief introduction of the open inseable balloon, we are going to discuss a current case. That is 75-year-old male patient, non-STEMI, 99% calcified lesion, tortuous, longer lesion with TIMI2 flow, with slightly reduced ejection fraction and positive biomarkers. So which is the best device for this patient? So out of the three, rotation atherectomy, IVL, and open NC balloon, I will try to convince you that why open NC is superior in this particular patient. Of course, we need some more information to select the appropriate device for lesion preparation in this patient. Angiography film to assess the degree of tortuosity, lesion length, vessel diameter, and thrombus burden. An intracorneal imaging is extremely important to know the calcium burden, calcium location, and morphology. Basically, we are interested in to know the calcium thickness, calcium length, whether it is concentric or eccentric, is calcium nodule is there or not, vessel diameter, and guide wire bias. So this is the ideal case. If you want complication with rotation, this is the ideal case. Why? Because it's a very long lesion. What do you mean by long lesion? If your long lesion is long, if you do rotablaster, then there is more plaques. You are going to generate more debris and more distal emulsion. Secondly, with long lesion, you are likely to have a prolonged ablation time. In addition to long lesion, this patient has tortuous lesion. So tortuous lesions always needs more time to cross with the rotameter burr. This patient is already a slow flow, and if you use rotameter, it is likely that it can worsen. And why this patient is slow flow? It's likely that this patient might be having thrombus, though it is not visible on the angiogram, because the patient with non-STEMI is resting changes, is elevated troponins, and is TIMI2 flow. So because it's a long lesion, tortuosity, and probably thrombus containing lesion, chances of complication rate will be extremely high if you do rotameter in this patient. Secondly, there is high risk of perforation also, because this patient has a very tortuous artery. So rotameter wire bias is very difficult to predict on angiography. See, wire bias is strong toward the healthy side, it can easily lead to vessel injury. So the experienced operators will use smaller burrs to prevent perforation in such a tortuous segment. But if it is a small burr, then you are going to have inadequate plaque modification. That's why I believe the rotameter is not a correct choice for this patient. Now what about IVL? IVL challenge will be too difficult to deliver because the long tortuous calcium lesion. An IVS catheter is a bulky catheter. If you come with a crossing bubble IVL balloon's profile is 0.044 to 0.047 each, compared to open NC balloon, which profile is very small, like 0.028 inches, which is like conventional NC balloon. So the first problem with IVL is if it is difficult to deliver in this patient. And second problem, more than one balloon may be required in this patient. Why? There is a long lesion length. The lesion is in the LAD. So LAD usually tapers from proximal to distal segment. So if you have a very long lesion, you may need there be significant diameter difference in the proximal endocal lesion and distal endocal lesion. And when you use IVL, you to size IVL 1:1 to artery ratio, balloon to artery ratio. So if you have a very long lesion, you will end up using 2 balloons. So it becomes very expensive. Secondly, IVL balloon also sometimes ruptures. There is some registry data in a real world experience, and they show the rupture of IVL balloon was almost 4 to 5%. In case you rupture in such a long lesion, you will require probably 3 balloons. So it will be almost impossible, probably cost very expensive. That's why I believe that in this particular patient, open NC device will be my device of choice. Because of ease of use, is very effective to treat calcium, is very safe, low risk of perforation and distal emulsion, is a better crossing profile, so it is easy to advance the balloon in the calcified lesion, is a time-tested device, it is a clinical experience of more than 10 years, and is cost effective also. You can easily use 1 or 2 open NC balloon without any problem. So thank you for your attention.
Thank you, Dr. Parekh. Please, all the...
One or two patients.
We I will first address the issue which the last speakers has raised. He has raised certain points against both the IVL and the rotablation. And he thought that balloon in balloon or so-called OPN balloon is possibly the best modality of treatment in this case. Maybe he's right from his perspective. So I would first invite Dr. Vipul to tell us what Dr. Parekh has said. Do you agree with him, or do you have anything else to say or defend yourself? That you said IVL should be the treatment of choice in this case.
Thank you, sir. I do not agree with Dr. Parekh, sir.
Just give us very brief points
Yeah.
and 1, 2, 3, 4.
Yes, yes. So, like he said, the risk of perforation. So, if you see, those are very, very few reports, and those are, very, very meager percentages. And that is only when there is a very nodular or eccentric calcium that IVL balloons can rupture. Number one. Number two, when we talk about OPN-NC, it is indicated for fibrotic and mild, or you can say moderately calcific lesions. If we assume that this was a severely calcific lesion which was mentioned here, OPN-NC will not work. Number two. Number three, when we talk about an acute MI situation, going at that high pressure, when we already talk about thrombus, right? And also there are reports of IVL balloon, OPN-NC balloons also rupturing. So we'll end up with the same problems of slow flow, thrombus migration, and even further worsening of the patient's condition. So these 3 points I would like to.
Okay. So I think Dr. Kapoor is very rightly what he feels is these are the issues which according to him could be created by a OPN balloon, and therefore he is not advocating OPN balloon in this particular case. Now similarly, Dr. Kapoor has raised a lot of objections for rotablation in this patient. And I think he has concentrated his talk more on giving the negatives of rotablation rather than giving positives of IVL. If I was at your place, I would have told what are the advantages of IVL. So possibly you had tilted your talk more towards finding the fault of the other one rather than giving support of your case. So I would now request our first speaker, Dr. Rao, to tell us how would he negate the points raised by Dr. Kapoor that rotablation has so many lists of complications, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So, and that is so scary for the audience sitting over here. All these complications are so scary. So how would you counter him?
First of all,
give us short points. Yeah.
First of all, I don't know what the lecture was Dr. Kapoor taking. It was called as IVL the game changer, but he was apparently speaking about anti-rota over here. Not a single trial he mentioned. Disrupt 1, 2, 3, 4. Sir, if you don't know, learn from me. No, it was no, you are not mentioned. Second.
No, please no interrupt. You have to defend yourself.
Wait. Lecture was more on calcium than actually on IVL. Third, but this debate, so I'm debating with him.
Yeah.
Third, complications of rota he dealt in 4 minutes, and lecture on calcium was on 10 minutes. Sir, it clearly proves the blue corner is a winner over here, because I spoke that the rota is the gold standard and it will remain as gold standard. And I never spoke anything against IVL. IVL is a great technology, but there is no data.
No, but nobody prevented you to speak against IVL.
I know, but rebuttal. I thought I'll come on the rebuttal.
No, Kamal told you not to speak against IVL.
And one last this thing about IVL. He was mentioning about the fractures. If you look at all the 4 trials, especially Disrupt CAD4, the fractures were 17 to 15% only, not more than that, because that was OCT based study. So 17 to 50%. So there are another 50% where the fractures did not occur at all. So just because they cause fracture, you cannot take it as gold standard.
I think
that's the thing.
Let me now summarize and give you a few things which, with my long experience of using Rota and now post IVL. Few things which Dr. Kapoor has repeatedly said in steep learning experience with Rota. I think that should have been true with us, who've been doing rota for the last 22 years, but others can learn from us. That steep should now become a plateau, because we now know what should be the speed, we now know how to cross the lesion in the bend, we teach them, we can hold workshops, we do hold workshops, tell them how to do this, and this becomes not a then steep learning curve, it can be learned. Number two, the list of complications that you have enumerated are very rare nowadays, very rare. In hands which are doing more than about 50 cases per year, these complications are almost negligible. Slow flow possibly is the commonest complication, but if you know how to select your cases, slow flow again is not a very major complications. And few things more which I would like to add is that in my experience of more than 1700 cases of rota, I have seen slow flow which is of significant nature was only in 5 cases. I have never used any cocktail, never in last 1700 cases, not even one case. And I have never seen a slow flow which is of more than 5 cases, out of which one patient I lost, 4 I could manage. So it was very insignificant. Perforation only 3 cases, and stuck burr 2 or 3 cases, where one patient we had perforation and rest we were able to manage the stuck burr just by pulling it out. They were very mild so. Few other things which you have said, which of course would come with experience, contraindications of rota ablation. All those things which are mentioned in the literature and by even the company we have done. We have done rota ablation in 7 cases of graft. I have done rota ablation in 5 cases of acute myocardial infarction during the stage of acute myocardial infarction, not 5 days later or 2 days. While the patient is on table with acute MI, we could not cross with a balloon. We saw heavy calcification which was not giving way. We put a rota and ablated, and then we were successful. And all 5 patients did well. And there was severe triple vessel disease. But then those come with experience, I must say. Those will be with experience. They even say that you should never take a rota bar in a rotatory motion on a dynaglide mode while you are advancing it. I have always taken it in a dynaglide mode, and in my 1700 cases, nothing has happened. Whereas the company still writes that you should not. I don't know why they write like this. So these are some things which you can develop on your own. If ACC or AHA says that you should not do this and then, I say bullshit. I don't bother for it. I have my own experience of 1700 cases, and when I have never seen even a single case of any guiding catheter being ablated while advancing the burr in a rotatory motion, why should I follow the advice of the ACC or AHA? So these are a few things. Now coming back to IVL, the biggest problem in this case is IVL is 99% lesion. I am sure you will not be able to get a IVL balloon across this 99% lesion. So you will have to do a rota first and then put a IVL. So you will have to go to Dr. Rao, ask him to do a rota first, and then you take a IVL balloon. So I think, and even in all these trials that you mentioned about 1, 2, 3, that what is the name of the trial that you mentioned? So there was 23% or 25% incidence of adjunct devices like rota or balloon in this case for crossing into IVL. So that is the biggest limitation of IVL. Secondly, even if your target stenotic lesion is not 99%, if your proximal vessel is tortuous and calcified, I am sure you will not be able to get a IVL balloon down into the RCA at the distal site. You will not. Howsoever smart you may be, whatever backup you may use, it will be very difficult to take a IVL balloon down into the distal RCA if the proximal and mid RCA are also heavily calcified. I had a patient like this. I had to sweat it out to get a IVL balloon down into the distal RCA. And in fact, in another patient, I said, forget about rota. And after it was not dilating with a balloon, I stayed away, took a 2.25 millimeter burr and ablated the distal lesion in the RCA 2.25 and got a negative residual stenosis. Lastly, people say and advocate that deep calcification should be the treatment modality of choice where IVL should be used. I again say that if you know how to use rota and you can use a bigger size burr, and I will show sometimes a case, I have got 2 cases, failed IVL followed by a rota ablation successfully done, no residual stenosis. It was only by upsizing the burr to 2 and 2.25 you can ablate even the deep lesions and can get a good result. But those things will come with time, but till then Deep calcification, yes, IVL may still be a better choice than doing a rotablation. And large arteries, IVL may be still a good choice, because for large arteries, rota may not be a sufficient size to really birth the. So these are some of the points.
Yes, so that was well summarized, and this is the SKY statement, how to do plaque modification, which they go by the IVUS OCT. And there is a scoring system. If score is more than 3, you always do rota. If it's less, then you can do OPN. So of course, we didn't keep an imaging in this case, but if that is available, then you can do. And as sir said, you may have to use all 3 maybe. You do OPN, and Dr. Prakash Viparik is here. There have been cases he's done all 3 in one patient. So he does an OPN, then he does an IVL, then he follows it with rota, or maybe does first rota, then do an IVL, and then put a stent. So maybe it's not that you can't use one with the other, and sometimes
The biggest problem, Kamal, with the IVL is the cost.
Yes,
I think it's an easy learning curve, no denying this fact, but the cost is prohibitive. Cost is prohibitive, and reachability at the target site is also another problem. Long lesions, you may have to use two, three burrs.
LV dysfunction, sir. We had a patient who was 90-year-old, 25% EF, left main triple vessel. So that we did IVL only, no rota, because we were worried about of rota because of age of 90 and EF of 25. So do you think LVEF ejection fraction, severe LVD is an absolute contract? I know I've been at your center. You do it all.
Last case which I showed you, left main, and surgeons refused in my left main. I had an ejection fraction of 30%, little more than what you were saying. Severely diffuse the disease arteries, and I did rota, put 6 cents. At that time, even IVL was not even born. So you can still put an IABP and do it. Yeah, I think with those comments, we should conclude this session, and thanks to all the speakers. They have put forward their views very elegantly and comprehensively, and I must congratulate Kamal for putting such a wonderful case and bringing out such a exciting discussion on this point. Thanks to all of you, and congratulations.
So thank you so much, Dr. Anand Rao from Mumbai, Dr. Vipul Kapoor from Ahmedabad, and Dr. Prakashveer Parikh from Ahmedabad for their valuable contribution for the session. Also, I would like to thank Dr. Kamal Sharma and Dr. D.S. Gambhir and all the chairperson and moderators for their valuable contribution. Give a big round of applause for all of them. Thank you so much, all the gentlemen, and with this, we are moving ahead for the next session. And yes, through the application, you can click on the right answer, which is there. And there is a question on a screen. And I would like to request audience to take also a part in the quiz. You can
play. The question is, how many cycles of IVL shock can be delivered by one balloon? I think everybody knows this. Next. Of course, it is 10 bursts per inflation, 80 in total. Next slide. Next case. Yeah.
Yes. So thank you so much, and now it's time to move ahead for the next session. And for this session, I would like to invite chairpersons, Dr. Samir Rane from Ahmedabad, Dr. Neeraj Yadav from Ahmedabad, Dr. Chirayu Vyas from Ahmedabad, and Dr. Dinesh Joshi also from Ahmedabad. So please welcome all the chairpersons on stage, and moderator for this next session, Dr. Amit Gangwani from Ahmedabad, Dr. Shobhanand Jha from Ahmedabad, and Dr. Jaimin Dave from Gandhinagar. So I would like to request all the moderators and chairperson to come on stage, and I would like to request you to introduce speakers to proceed further for the next session. There are 2 speakers, Dr. Jignesh Patel and Dr. Raghav Bansal, followed by Dr. Jignesh Patel. So I would like to request the chairperson to just give a brief introduction of the speaker. Thank you. Over to you.
I think Dr. Jignesh is going to be the speaker, and regarding this case, he's going to support talking about ICD being the most suitable device especially for this patient, provided the patient profile. You will be providing the patient profile? Yeah.
So, good evening, everyone. So today we have a case that 75 a female patient having a class 2 dyspnea and a history of the cardiac syncope once in the last month. So other non-cardiac causes has been ruled out, and she had a history of the old anterior MI with normal coronaries, and the cardiac MR showing a apical scar with LV ejection fraction of 38%, and the ILR loop recorder shows the VPC burden of 4.5% of total QRS, and ECG is showing the bifascicular block with the prolonged PR with a QRS duration of 120 millisecond. So apart from the medical optimization, what should we offer to her? Whether we should go for a pacemaker considering the underlying bifascicular block and the prolonged AV, first degree AV block in the ECG, or whether we should offer a AICD considering the history of the old MI in the apical scar and the cardiac MR with the LV dysfunction. So I would say that if patient has only LV dysfunction and the cardiac MR showing apical scar with LV dysfunction, definitely we'll go for AICD straightforward. And if patient is only patient is a normal LV ejection fraction with the normal heart, structurally normal heart with the normal cardiac MR, and ECG showing just a bifascicular block with the prolonged AV block and history of the cardiac syncope, then definitely we'll proceed for a permanent pacemaker implantation in this patient. But we have both this condition here. So this particular gray zone, then we have to decide which is a more suitable for this patient. So in this particular patient, I would say that AICD is preferred in this patient because the tachyarrhythmia is the most likely cause of the syncope in this patient. So if we look at the cardiac causes of the syncope, the most common cause is a tachyarrhythmia followed by a AV block. It may be because of the low cardiac output hypotension, maybe because of the LVOT obstruction, or it may be a reflex mediated. But before going for any particular device therapy or offering a particular further intervention, we should take a proper history, and the further evaluation is always necessary, and that is almost important. If we look at the history of the syncope, it is really very important whether it was associated with the palpitation. If there is association of the palpitation with the syncope, that would nearly confirm the possibility that patient had a ventricular tachycardia. That was the reason for the syncope. If patient has a sweating, nausea, vomiting or breathlessness, and that may occur because of the hypertension, that may occur in patient with the ventricular tachycardia rather than any post-dilated syncope. So in such cases, if patient has a history of palpitation, nausea, vomiting or sweating at the time of the syncope, then definitely the VT is a more likely cause, and we should offer a AICD to such patients. Now coming to the another important evaluation is a evaluation of the ectopics. Here we have that 14 days loop recorder showed the VPC burden of the 4.5%. Though the percentage of the VPC is not that high, VPC burden is not that high, but we have to look the morphology of the ectopics. If there is a R1T VPCs, presence of couplets or triplets, or there is a presence of multifocal VPCs, then definitely the chances of having a ventricular tachyarrhythmia is a more likely etiology here, and we have to proceed for a AICD rather than a permanent pacemaker. And further evaluation like EP study, the EP study particularly if there is an induction of the ventricular tachycardia by EP, that would nearly confirm the VT as a etiology, and we have to go for AICD. And if we look at the HV interval, if there is a HV interval is more than 60 millisecond, there are more chances that patient may progress to the complete heart block in the future. So that we have to keep in mind as well. But the negative EP study does not rule out the etiology as a VT or AV block as a cause of the syncope. So the positive EP study has a more positive predictive value, but the negative EP will not rule out the VT or AV block as a reason of the syncope. That we have to keep in mind. And other important thing is a ECG characteristics. We are not given a detailed ECG findings here in this particular case, but if you look at the ECG parameters like any QT alternance, T-wave alternance, presence of early repolarizations, and other things like presence of long QT, short QT interval, presence of ECG signs that is suggestive of the Brugada syndrome or suggestive of the ARVD, then definitely such patient have a more chances of having a ventricular tachycardia as a likely cause of the syncope. And another important thing is ILR. The ILR will give a definitely more insight into the etiology of the syncope, but the only problem with the ILR is that it is really costly, and the cost of the ILR, if we put for 14 days or more than that, the cost will be more than even pacemaker implantation. So in this particular patient, in our patient, the possibility here is a ventricular tachycardia because she had a history of the old MI with apical scar and presence of the VPCs. Though the clarity on the type of the VPCs, whether it was NSVT, couplets or triplets, is not given here, the more likely chances that patient has a VT is more likely. And second cause may be a AV block because of the underlying bifascicular block with the prolonged PR interval, and it may be because of drug induced or maybe a hypotension. So this table shows there are various criterias, the presence of which says, indicates that patient is a very high cardiac risk in presence of the syncope. So which are these criteria? If you look here, presence of the severe structural or the coronary artery disease, for example, heart failure, previous MI, LVOT obstruction. In our case, there is a presence of the prior old anterior MI with apical scar. So our patient, in presence of the old MI and syncope, it becomes a very high cardiac risk in syncope, and the likelihood of the ventricular tachycardia is more likely. And other things like clinical findings and the ECG findings, like history, the syncope occurring during the exertion, or it is occurring during the supine position, or palpitation at time of the syncope. Is there any family history of the sudden cardiac death? Is there any presence of NSVT in ILR recording, or is there any presence of the bifascicular block with the prolonged QRS duration more than 120 milliseconds? In our patient, the QRS was 120 milliseconds. Or any presence of pre-excited QRS, prolonged QT, short QT, ECG suggestive of the Brugada pattern, or ECG suggestive of the ARVD. So these are the particular ECG sign and the clinical signs in presence of which if there is a syncope, then there are high chances that the patient may have a ventricular tachyarrhythmia as a likely etiology. So if you look at the review of literature based on the history, even a syncope from the arrhythmia is a most common reason, most commonly that occurs from the ventricular tachycardia, which accounts for around 11% of the total cases of the syncope. And on the other way, the bradyarrhythmias are cause of the syncope in just 3 to 10% of the cases. And the association of the ventricular tachycardia with low ejection fraction cannot be overemphasized, and it must be considered in any patient with a poor LV, whatever is the underlying etiology. So whenever there is a poor LV function and presence of the syncope, ventricular tachycardia by default should be considered. So those for this particular patient, as I already mentioned, that the all anterior MI, scar with VPCs and low ejection fraction, chances of VT is higher. As there is underlying RBBB, LASB and prolonged PR, it is not necessarily that AV block with the long pause is a reason for syncope in this particular patient. So not necessarily that just merely a presence of the bifascicular block and prolonged PR is a reason of the syncope. So the overall chances of having a VT is higher than the bradycardia in our patients. So definitely I would offer a AICD. And if you look at the comparison of the AICD and a pacemaker, the AICD can treat both the tachycardia as well as a bradycardia, and it can prevent the sudden cardiac death if the patient has a VT in future. But the permanent pacemaker, it will only treat the bradycardia and cannot prevent the sudden cardiac death if syncope was due to the ventricular tachycardia. Though the AICD is costlier than pacemaker, but we have to be more safer in this patient. So as I already said that in absence of the investigation like EP studies or data on a VPCs and ILR, it is better to be safer to put a AICD rather than a pacemaker, and that will treat a tachycardia and bradycardia both, and pacemaker will only treat a bradycardia. And the next, we never know that if patient has a next episode of the VT, then patient may not survive and patient may have sudden cardiac death, and that will not be prevented by putting a pacemaker. So that can be prevented by offering her AICD. Now if you look at the guidelines for the ICD implantation, it also says that it is a class 1A recommendation to put a AICD as a primary prevention if patient has a LV dysfunction with EF less than 35% with the class 2 symptoms. If EF is less than 30%, even with the class 1 symptoms, AICD is a class 1A indication for as a primary prevention. And in case of ejection fraction is less than 40% with a positive EP finding, if there is an induction of the VT during the EP study or any presence of the NSVT, then is also a class 1 indication when the LV ejection fraction is less than 40%. So definitely in this particular patient, the history and the thorough evaluation in form of the ILR, if possible, EP study is helpful before deciding the device therapy. As I already mentioned that EP findings are not that specific. Positive EP has a more positive predictive value. So the induction of the VT, definitely VT is a etiology, but negative EP will not rule out the VT or the AV block as a reason of the syncope. So to summarize, if there is a structurally abnormal heart, VT is a more likely, then definitely we should offer a AICD. If there is a presence of structurally normal heart, normal LV function, normal cardiac MR, and presence of the AV block in a ECG, then definitely we'll go for a permanent pacemaker. So in our case, because of the all interval MI, presence of LV dysfunction with a apical scar in the cardiac MR, putting a AICD will be a more sensible and a safer option. Thank you.
Next speaker, I think, would be Dr. Raghav Bansal, and he would be talking in favor of a pacemaker. A dual chamber pacemaker alone shall suffice in this case.
May I? Good evening, everybody. So I'm Dr. Raghav from UN Mehta. So coming straight to my talk. So just a few important. My slides are not there. Yeah. So yes. So coming straight to my talk. Regarding the case under discussion, there is a few points which needs to be remembered about this case. This patient is 75-year-old. This is not a usual case, and this patient has a bifascicular block with a very prolonged PR of 240 milliseconds. There is a 14-day ELR which has been done, which reveals a VPC burden of 4.5%, and there is a cardiac syncope, which I suppose that it is cardiac now, so no point going into the reflex syncope pathway. And there is only a small apical scar, and the ejection fraction is 38%. Now going ahead, I am here to speak about DDDR alone shall suffice as of now in this case. So what are the possible causes of the cardiac syncope in this case? So it can be intermittent complete heart block, which seems to be more likely because there is a bifascicular block plus prolonged PR interval denoting the conduction system disease. There are certain VTVF can also be there, but it is less likely because there has been an old anterior wall MI, and with no residual ischemia, coronaries are normal, ejection fraction is more than 35%, is 38%. There is only a small apical scar. There are no high-risk features on the Holter, including NSVT runs or a VTVF. But the problem is that VTVF cannot be conclusively ruled out to say that we will not put an ICD. So a pragmatic solution can be EP study, as pointed out before in the previous talk. So we can do a programmed electrical stimulation for a VTVF. If it is inducible, then we can go for an AICD. If there is no inducible VT, we can do a bradycardia study and see the HV interval or inducibility of any high-grade AV block. If it is there, we can go ahead with a dual chamber pacemaker implantation. If the HV is normal and there is nothing, no tachy is induced and there is no high-risk feature for the bradycardia, we can go ahead with an ILR. But the problem again, as rightly pointed out the previous speaker, is that the negative predictive value of an EP study for both VTVF and for bradycardia is both questionable. So that brings us to the quandary what needs to be done. So to find the answer, let's have a close look at the evidence. What is there in the evidence? Let's review the evidence. So what is the evidence for DDDR in this case? First, we'll discuss about the evidence for the dual chamber pacemaker. So this was, here it is all started. So this was the first study from NEJM in 1982, where patients of bundle branch block was studied, and it was found that patient who had syncope, there was a 17% incidence of heart block against 2% patients who didn't have any syncope, and the risk of heart block and of death from a bradyarrhythmia is usually low. Coming down in the same year in 1982, this is American Journal of Cardiology. It's a landmark paper from Scheinman, which today forms the most of the guidelines. So this paper included 303 patients with chronic bundle branch block and did an EP study for all these patients, divided into three groups: HV of less than 55, HV of 55 to 69, and HV of more than 70 milliseconds. Interestingly, what they found was that the progression to high-grade AV block was rare, only 2% in less than 55 millisecond group, and 4% in group 2 and 12% in group 3. And HV of more than 100 millisecond was particularly high risk with a progression rate of 24%. And in this study, 62 patients had underwent a pacemaker implant. There was no difference in mortality in patients having pacemaker implant or no pacemaker implant, but pacemaker definitely decreased the symptoms. So this is the landmark paper based on which most of the guidelines today exist, and this is the ESC guideline for management of syncope from 2018, which clearly says if there is an ejection fraction of less than 35%, we go ahead with an ICD or CRT. But the problem is if the ejection fraction is more than 35%, we can go for an empiric pacemaker, which is a class 2B indication, or consider an EPS as a class 2A indication. And if nothing is found, we can implant an ILR. But so we have contrary data also available, which makes us confused. So this is a trial which was done published in 2013, the issue trial, where ILR was done in 52 patients with biofascicular block and unexplained syncope and negative EP study. So what surprisingly was found, even after a negative EP study, 42% patients had a syncope recurrence and 17 patients were secondary to high-grade AV block, and additional 3 patients progressed to asymptomatic complete heart block. So negative EP study cannot rule out. And then there was a press study which was published in Circ A&E in 2013. In this study, all these patients, biofascicular block with unexplained syncope, underwent a pacemaker implant empirically, and these patients were randomized to DDD 60 mode versus a DDI 30 mode. And what they found was that DDI 30 mode had a significant increase of symptoms as compared to DDD 60 mode. So this means that pacemaker implantation in this subgroup conclusively decreases the symptoms of syncope and pre-syncope as compared to no pacemaker implantation, no intervention. So pacemaker implantation was suggested. However, there is no mortality benefit. So as per this study, the last press study, 2017 AHA recommendations are to, it is reasonable to implant a pacemaker in such a patient with chronic biofascicular block and syncope. However, they have failed to give any level of recommendation or level of evidence for this indication. But 2018 guidelines for from the European Society of Cardiology are pretty clear about it, that if you want to implant an ICD, you have to do a EPS before and say that there is inducible VT. And if you want to implant a pacemaker, you have to do an EPS to show that HV is more than 70. If HV is more than 70, it's a class 1 indication. But the problem is this uptake of this guideline, application of this guideline, even in the United States, it's very poor. So this is the data from Medical College Albany in United States of America, which showed that only 10% of the patients with biofascicular block and syncope actually underwent EPS. So what is the reason behind this change of why these guidelines are not being followed? So basically there has been a resistance to do an EPS because the negative predictive value of EPS is poor. That's why there has been a recent rise in interest in these patients, and recently in 2022 two studies were published. One was the Sprightly trial, which was published in JACC-EP. It was a randomized trial where such patients biofascicular block with undiagnosed syncope were randomized to implantable cardiac monitor or a pacemaker, and it was clearly shown that pacemaker group did better in terms of reduction of symptoms, and many of the patients from the implantable cardiac monitor group actually required to be upgraded to a pacemaker on later follow-up. However, there was no difference in mortality in between the two arms. And the other trial, which was published in October 22, was in the heart rhythm. This was a prospective multi-center observational study, and it was a propensity match study in which 89 propensity match pairs were analyzed, and it showed that 39.3% patients who had in the ILR group actually developed significant bradyarrhythmias and recurrent syncope on follow-up. So thus it was suggested empiric PPI reduced syncope recurrence in this set of patients and can be considered. So summary for the evidence for pacemaker implant is that dual chamber pacing for syncope in biofascicular block may be reasonable without EPS even, especially in the elderly where falls can be traumatic. So this statement is specifically written in the European Society of Cardiology that in elderly patients where falls can be traumatic, DDDR implantation in a syncope in biofascicular block can be considered even without an EPS. However, EPS can still be considered indicated and can be done when available. Now coming to the second part of my talk, which is the evidence against the AICD in this case. So what is the evidence of implanting an AICD in such a case? So AICD evidence started from secondary prevention trial. So this was the meta-analysis of the 3 secondary prevention trials which showed effectiveness of AICD implantation, AVID, SIDS and CASH. This was from European Heart Journal in 2000. Even in this meta-analysis, if we look at closely, so what was found in the patients who had ejection fraction of more than 35%, ICD in the secondary prevention, this is secondary prevention data, this is not primary prevention data, mind you. In the secondary prevention data also, ICD was not much effective as compared to amiodarone in the secondary prevention arm in ejection fraction more than 35%. And the lines only diverged after 5 years of follow-up. And the only evidence for implanting ICD in patients of ejection fraction more than 35% comes from a single trial, which is MUST trial. In this trial, patients less than 40% were included only when they had unsustained BT or an unexplained syncope. There was no unsustained BT in this case. Syncope can be explained by the biofascicular block in this case. And importantly, all patients underwent an EPS in this study, and only patients who had EPS positive for inducible monomorphic VT underwent an ICD implantation or antiarrhythmic therapy. and it showed that ICD implantation improved mortality rates in this subgroup who had an inducible VT. So based on this MUST trial, we have the current guidelines from the AHA 2017, which shows that such patients have to undergo an EP study for inducible VT before implanting an ICD. So ICD cannot be directly justified. And similarly, even the European Society of Cardiology guidelines from 2022, which are the latest rendition, it also shows that programmed electrical stimulation is class 1 indication in such subgroup before implanting an ICD. But there is further problem with the benefit of ICD when we look further into the data. So this was a paper in 2005 which shows that in the primary prevention trials where ICD showed a mortality benefit in patients less than 30 or 35%, it was shown that mortality benefit was majorly driven by patients who were included with ejection fraction less than 20%. As the ejection fraction is more than 20%, the mortality, and as the ejection fraction rises, it is not a linear scale, it is actually a logarithmic scale, and the mortality actually falls logarithmically as compared to a linear scale, what can be expected. So a difference from 30 to 38 is not same as 22 to 30. The other major point is all these trials were done in 1990s and 2000s when our guideline directed medical therapy was not that sophisticated. In today's date, our uptake of GDMT is much better as compared to before, and we have ARNIs and SGLT2 inhibitors making our mortality data much improved as compared to before. With the reduction of mortality in heart failure patients and such patients, the sudden cardiac deaths are also expected to get reduced, thus diminishing benefits of an ICD. So ICD, is it free of troubles? No, it is not. And if we see the cost-effective analysis, even in the United States of America from the MADIT2 and the SCUD-HEF trial, the cost per life year saved becomes acceptable only after 5 and 8 years of follow-up, not before that. So a patient should have a significant lifespan available before ICD should be implanted. And ICD has a 10 to 15% definite risk of inappropriate shocks, which can cause severe anxiety and deteriorate the quality of the life of the patient. And ICD is a bigger device, especially in a frail patient with a 75-year-old, it can cause a lot of complication with a bigger device and stouter leads. And the last point in this patient, which is very important, that this patient is already 75-year-old, as per the Indian life expectancy, has already outlived the average life expectancy in India. And what we see that this is the data from which was published in Circulation 2013 from United States of America, Ontario ICD registry, which followed more than 5,400 or more than 5,000 patients. So what was seen that this blue line and this purple line, which are more than 80 years and 70 to 79 years, have a very high mortality on follow-up after ICD implant. And if we see the appropriate shock rate, they are comparatively lower as compared to the younger age group. So the question if the benefit of ICD in such group is very, very questionable. And in fact, there was a review paper in 2015 Europace, which clearly said that result of ICD trials cannot be extrapolated to this elderly population, and mortality is already high in elderly people because of the too many comorbidities they have and because of the aging, and evidence for survival benefit is very weak in this population, and ICDs are not cost effective in elderly as a group, and they can be considered only when estimated life expectancy is more than 7 years of age. So this is pretty strong evidence against implanting ICD in this case. And syncope not unexplained in this case because it may be likely due to intermittent AV block. There is no evidence of NSVT on 14-day Holter. VTVF thus is unlikely. For primary prevention, minimal benefit of ICD at ejection fraction of 38%, and with guideline directed medical therapy in today's date, there is diminishing benefit of ICD for primary prevention, and at age of 75 years, ICD has completely controversial benefit. Thus, costs and risks of ICD implantation in this case versus a dual chamber implantation cannot be justified in this given case scenario. Thus, DDDR alone shall suffice as of now, and I rest my case here. Thank you.
Now we come for the rebuttal. Discussion? Okay. That was a major question I wanted to ask Dr. Jignesh. Yeah, absolutely. Just one question for Jignesh specifically regarding this case. If by just suspecting this VT as an apparent cause of syncope, and that is why we are mandating to put an ICD, just imagine if at all an ICD has been placed, but despite that, the VT keeps on recurring. And it is not responsive to anti-tachycardia pacing and neither responsive even to the shocks. then how will the ICD prevent the occurrence of VT, if at all it's a scar-induced VT that you projected as an indication of ICD? How will ICD prevent the occurrence of VT?
VT on EP study, then definitely we can go for ablation of the VT if there is a
No,
monotopic
that is what you needed to point out, that actually even before prior targeting to put an ICD just as to prevent patient getting recurrent syncope, prior EP ablation and EP ablation of the scar induced VT, if at all it's inducible, that is more important just to prevent the occurrences of VT.
Yes.
Yeah. Point maybe Dr. Raghav, if I just like to point you out, before going for an invasive study, or even if we do an invasive EP study, just imagine a borderline HV interval. You find a borderline HV interval of around maybe 65 milliseconds. Then in that case, will you mandate pacing for a bifascicular with a prolonged PR interval?
So, in my experience, sir, I usually take the social scenario and the holistic approach. So, what is important here to understand is the first episode of syncope, and even if it is a bradyarrhythmia induced syncope, so in those cases also it has been known, the data supports that there is very less risk of mortality on follow-up even if bradyarrhythmia and syncope recurs. So what we can do is we have two options. So if the patient is very frail and is at high risk of traumatic falls, then we can just go ahead and implant a pacemaker. If the patient is okay, only homebound and is okay and at lower risk of traumatic falls, and the patient is financially weak, so in that case, I might consider a follow-up, medical follow-up at this point of time with an HV normal.
If I interrupt you in between, sorry, but actually before just talking about invasive evaluation of an HV interval, I think a very, very good point which probably you might have pointed out is looking at the 12-lead ECG in detail. Because that is where probability of maybe picking up some abnormalities like a masquerading bundle branch block, presence of a bifascicular RBBB plus LAHB if it is associated with a LBBB morphology, especially in lead 1 and AVL. This is what in absence of presence of S waves, that is a classical standard masquerading bundle branch block, which is an advanced form of AV block, which is what will mandate the pacing just by looking at the ECG only without going for an invasive EP study. That is what was an important point which probably you should have talked of. But why not because of prolonged AH interval? That is what I just pointed out, that HV interval is borderline just 65 and hugely prolonged AH interval, nodal. Exactly. So case details were even more important to discuss at, right? As said, depends on the center and the volume and the experience of the operator. Like if at all for a 3D mapping system, scar related VT with a single scar and a single inducible VT should be in the range of around probable 70% with which it can relieve the VT component recurrence. That is what. Then the other options are maybe optimizing the medical therapy, and this is what is the last option before going for maybe cryotherapy of the cervical sympathetic denervation and kind of modalities. CRTD definitely in the presence of a classical left bundle branch block, because RBBB and IVCD, they are being considered as being options which should be included in the guidelines, and they should be projected as a non-LBBB category. That is classically called as non-LBBB category. Non-LBBB category, which is what if at all you are providing resynchronization, that is how it will improve the LV function. So this category is right now yet to come into guidelines. The non-LBBB. Not as much as of a responder as a classical LBBB would be. Yeah. Yeah, Raghav.
Give a couple of comments on this. So regarding the need for CRT, first of all, in this particular case, the QRS was given to be 120 milliseconds. So
it was less than 150, yeah.
Yeah. So the other thing is that there was a recent paper in circulation A&E which showed clearly that RBBB CRT is not helpful. It was a very big data and RBBB CRT is not helpful. The other thing is that we can still consider a CRT in ejection fraction of less than 40% when a pacing burden of more than 40% is expected in this patient. If the patient progresses to a complete heart block and requires a pacing burden of more than 40%, in that case, we might actually justify CRT. But at the moment, the pacing burden, since the patient had only one episode of syncope, it cannot be justified at the moment. And patient should be explained if on follow-up, that patient becomes pacing dependent, he might require an upgradation to device or CRT. The other consideration in such a case scenario that would be that you can do a dual chamber pacemaker with a conduction system pacing lead, which would be very good for this patient, considering the ejection fraction of in the mid range.
But then comes the problem of if at all the VT becomes inducible during the EP study.
Regarding this, there was one data recently published in circulation mail, which clearly said that for patients of more than ejection fraction of more than 35%, ICD can be completely avoided and just ablation can be done.
Ablation, that is what. Ablation of scar VT was a very, very important component.
These patients with an ejection fraction of more than 35% get a scar VT, they are likely to have a sudden cardiac death because of scar VT. They are more likely to present with a stable monomorphic VT in this subset. So that is another thing. And if you are doing an EPS and you get an inducible VT in such a case scenario, if it's only one single monomorphic VT morphology which is getting again and again induced, we should consider ablation and putting it in a DVDR.
Ablation was more important, and most importantly, we should be talking of the ECG morphology, especially in one AVL. This is what was a very, very simple pointer as to the presence of how much advanced bundle branch block, the masquerading bundle branch block, which is what would suffice a need for a pacemaker in that sense, without going for an invasive EP study, which is what can also confuse you if at all the HV intervals are borderline. And the prolonged PR interval is mainly because of the prolonged AH interval.
And the last thing, one more point I wanted to emphasize here is that patients who are frail, so elderly patients, especially in India, are likely to be frail. So 75-year-old who's very frail is very, very unlikely to benefit with an AICD implantation, and there is a lot of data regarding benefits of ICD in frail patients.
Study, and if you find that there is no any induction of the VT and as well as the HV interval is less than 60 milliseconds. Yeah. So still could it be a chance that this syncope could be because of the ventricular tachyarrhythmia?
Baseline always remains prolonged rhythm monitoring. That is what will remain the baseline discussion for this case. That keep on looking at the rhythm for a long time. That is what will give all the answers, which is what is the main point.
ILR for a long term.
So ILR is actually for more than 1 year, about at least 1 year, rather than.
Implantation versus ILR implantation in such a case scenario where EPS is negative. In those scenarios, pacemaker implantation may reduce the recurrence of syncope on follow-up. However, there is no change in mortality.
Okay. But particularly when you are putting a ILR for a longer duration, like
long rhythm monitoring, long-term rhythm monitoring is the basic.
If patient has a ventricular tachyarrhythmia by that time, then there are always a chances that she or he might have a sudden cardiac arrest.
See, that will always remain. So. Not necessary, especially in a 75-year-old with bifascicular block. And as we are talking, for example, if we are shown the 12-lead ECG with a broad QRS LBBB morphology in 1 and AVL, especially with such a prolonged PR, that is classically called as masquerading bundle branch block, which is what is a very advanced form of AV block, which is a classical Pro-1 documented cause of syncope, which is where the pacing would suffice.
It will take care of both tachycardia or bradycardia as well. Then why not to be a safer? Yeah.
But how it will prevent the recurrence of VT?
Yeah, that will not prevent the recurrence, but
Ejection fraction is not low, it is mid-range in this case. So when you have an ejection fraction nearing 40%, then VT might not be the most common cause of causing it. It might not be there, but in some patients
it may be
less than 30% probably ICD, but at a 40% ejection fraction.
Nearly 40, yeah.
One group photograph. So thank you so much, both the speakers, Dr. Jignesh Patel and Dr. Raghav Bansal, and all the chairperson and dignitaries, all the moderators. So please give a huge round of applause for this entire team for making this session very interactive. And let's proceed further for this one group photograph. Thank you so much, everybody. And we are also having one quiz and a question which is there on your screen. You can give the answer through by application of Cardiocon 2023. If you have downloaded, just access and give the answer among these 4 options. And there is a point we are going to calculate in the end of the meeting, and the winner will be also announced later on based on the right answers whichever given by the audience. So this is what the quiz, and you can see the question on your on this screen. So thank you. I guess the answer is also shared on the screen. Thank you. And now it's time to move ahead for the next session. Next session, I would like to invite chairpersons Dr. Kamlesh Thakkar from Mehsana, Dr. Jayal Shah from Ahmedabad, Dr. Riyaz Chanaria from Ahmedabad, Dr. Kaushal Pujara from Anand. So I would like to request all the chairpersons to just come on stage. And for the moderator for this next session, Dr. Alap Patel from Mehsana, Dr. Chirag Patel from Ahmedabad, and Dr. Kandarp Nimawat from Ahmedabad. So please welcome all the chairperson and moderator on a stage. Thank you. And I would like to request the chairperson to give a brief introduction for this next session's speakers. Which introduction is already on a screen. Dr. Prashant Vazirani is our first speaker. So I would like to request chairperson to give just a brief introduction of Dr. Prashant Vazirani and proceed further for the session. Thank you.
So good evening. So we'll start this topic with Dr. Prashant Vazirani. He's MD, MBBS, MD and DNB cardio gold medalist and working at Pradat Nagar, Ahmedabad in cardiology and child care clinic. So we'll start off with his talk on small vessel disease.
Thank you. So coming to the dissections of the details given, we have a 35-year young male ACS setting, and he has some risk factors like he is diabetic, hypertensive, and the infarct vessel is a diagonal, it's a branch vessel disease, and it is of 2.5 millimeter caliber, and it is an osteal disease. So what more we would like to know? So apart from that whether he has a markard or not, I would like to know that what is the angle the diagonal is making with the LED, whether a two-stent strategy will be possible in this patient or not. Because if it is, the angle is bad, and if I end up, messing up the LED, then it is not good. And apart from that, I would also like to know his bleeding risk score. Whatever scoring system you use, we would like to know his HB, if he has any renal issues, upper GI bleeds, and thrombocytopenia, any planned surgeries, etc. Because he is acute MI patient, and AMI, as we all know, is an independent predictor of bleeding at 1 year. So we are studying small vessel disease. So how do you define small vessel disease? Any vessel diameter less than 2.8 millimeters is a small vessel disease. And approximately 40 to 50% of all coronary lesions are occurring in small vessels. And around 50% of our coronary interventions are performed for small vessel disease. So much so that we proceduralists have pushed the stent industry to even manufacture 2 millimeter stents now. So why this treatment of small vessel disease is included? Because they are challenging regions. They have higher risk of wrist stenosis and target lesion revascularization. They have higher MACE rates. DES may have longer term issues. We want to avoid DES in small vessels, and so therefore this question of DCB or DEB, whether it can be good as DES. So we have these 4 treatment options, whether we can do a POBA or a BMS or a DES. Now we have even better DES like a biodegradable polymer, no polymer, first generation BVS, second generation BVS. And you can also do a DEB, which I am going to discuss. Apart from this, I'll be very happy if somebody in Cardiocon 2024 will be speaking on medical management for this patient, that you coronary plumbers, you just want to fiddle with, put something in it, a stent or a balloon. Why not just medical manage for this osteal branch vessel disease? So because this patient has some restenosis predictors, like he is diabetic, it is a small vessel, it is a osteal lesion, and being an osteal lesion, there can also be a geographic miss. Then you may have to implant another stent, and if the angle is not good, your stent will land into LAD. Then you will have to do a bifurcation, and you can mess up everything. So now with our considerable decades of knowledge, we know that in-stent restenosis is more common in diabetic, and more so if it is in a stent is placed in a small vessel in a diabetic. As you can see, if your vessel size goes on decreasing, your chances of ISR, they go on increasing in a diabetic patient. Why does this happen in diabetics? Because the coronary lesions are more complex in diabetic patients. They have more necrotic core volume and delayed healing secondary to slow endothelization and increased inflammatory response. And this issue was discussed in the morning lectures also. The OCT pictures were shown of uncovered struts. So apart from all the stent issues which are discussed, this uncovered strut issue, many times it is not discussed. So what are the advantages? I have jotted down them together. Because you have a homogeneous drug delivery to the vessel wall, you have immediate drug release without the polymer. This is a DEB is a easily repeatability of the procedure is there, and since there is no foreign object left behind, there is no risk of stent thrombosis, stent embolization, or other stent issues. And it is a shorter depth, so a high bleeding risk patient can be effectively treated. Just last week we had a young alcoholic who came with an anterior wall MI, but he was bleeding on endoscopy done in the midnight. He had varices, and that had to be clipped, and in the morning still the gastroenterologist did not clear us for intervention because he was still bleeding. He wanted to do another colonoscopy and endoscopy, and unfortunately the patient was kept only on medical management. So such high bleeding risk patient, you will need a shorter DAPT, and then a DCB will be a better option. So lower event rates and better long-term safety outcomes and reduced vascular inflammatory response will be there with a DEB because in absence of any polymer, and potential for allowing the vessel to function normally. Now this last point, it has been even been studied. If you see in the top portion a DCB and a lower slide the DEB DES has been tested for vasomotion by acetylcholine and nitroglycerin, and the portion distal to the stent was behaving had abnormal vasomotion response to the acetylcholine, while was not such the case for with the DEB. So coming to the concept of late luminal gain and late luminal loss and luminal gain. So whenever you implant a stent, you have a late luminal loss which occurs. While in the case of DEB, when you implant a DEB, because of the drug, it proliferates into the intima and the media. There is a favorable positive remodeling which happens, and ultimately you get a favorable luminal gain and not a loss. So this has been explained by Dr. Kleber that in a DES there is no vessel enlargement, there is no luminal gain, and there is only luminal loss which occurs because of the neointimal proliferation. While in DEB, you can have vessel enlargement and plaque regression, or vessel enlargement only, no plaque regression, and no vessel enlargement and only plaque regression. So these three factors are contributing for a luminal gain in DEB. So this has been studied also that after the treatment with a DEB, you still continue to have a luminal gain in the patients with DEB. So coming to the trial evidence, these are 4 important trials which were done in de novo in small vessel disease, but these were all non-inferiority trial. Now we also have a superiority trial. So Picoletto, Bello, Restore, SVD, and Basket Small 2, we'll go through them quickly. So in Basket Small 2 trial, some 380 patients were randomized into a DEB and a DES. So at 1 year, it was a non-inferiority trial for MACE, and not only for MACE, even for target vessel revascularization, MI, cardiac death, and MACE, everything was non-inferior, and it continued for even at 3 years, it was non-inferior. So this is Antonio Colombio's slide that if you just take out the diabetic arm in this trial, and if you study them, the 3-year results, you see the target vessel revascularization, it is 9% in DCB and it was 15% in DES. So a gross difference in this. So not only in small vessels, a DCB study should be even there in large vessel also diabetics. Coming to the Bello study, same 100 patient, 100 for a DEB and 100 for paclitaxel balloon. So this was a true small vessel study where only 1% of the patient were more than 2.8 millimeter vessel size. So same, it had a non-inferiority for all the outcome, whereas for late luminal loss, it was seen with the paclitaxel stent and not with the balloons. So this is the peculiar slide that shows that on long term it had a superiority outcome, because after 200 days of implantation of the stent, the MACE events, they started to diverge, and the stent related issues, they started after 200 days. So the Restore SVD China trial, they had the two arms, a small vessel and a very small vessel arm. And in the small vessel arm, they had both the arms like a balloon arm and the stent arm. And same that at 1 year, it was a non-inferiority trial. And now, since the presentation of the Restore SVD trial back in 2018, then we had 2 years data in 2020. Now in TCT 2022, they had presented the 5-year outcome showing the same, that it had non-inferior data between both DCB and a DES. So what are these trial taught us? That DEB have same event rates, maintained efficacy and safety as the modern DES in treatment of de novo coronary small vessel disease at 1, 3 and 5 years. And absence of foreign body has a long-term benefit in terms of luminal gain. And rate of both major bleeding and stent thrombosis tend to be lower in DCB than in DES. So coming to the superiority trial, Picoleto 2, in which 100 patients were randomized to a Zion stent and a drug-coated balloon. You can see, as I explained previously also, there is late luminal loss was seen only with the stent. And a superiority outcome was there for MACE and vessel thrombosis. So is it too much to expect better clinical outcome by DCBs versus DEs on the long term, because we have seen a significant amount of trials which I showed? What about our subset of patient, an NSTEMI patient who is coming? Can we treat them with a DCB? So this was presented in a PEPCAT NSTEMI trial in which it had the both arms, a drug-coated balloon arm and a DES arm. This trial also showed a non-inferiority data at 9 months. And this trial concluded that treatment of coronary de novo lesions with the balloon, a drug-coated balloon, was non-inferior to the stent treatment. So what for our patients who has a very high bleeding risk score at the presentation? So what for these patients? So a trial was also done, which is the debut trial. So they had two arms, for paclitaxel balloon and a bare metal stent. A bare metal stent because you cannot put a drug-eluting stent for a patient who has a very high bleeding risk score. So this trial also had a very positive outcome when it was compared against the stent. And everybody should go through this paper of drug-coated balloons, where they have dealt with all these trials which I have told, like applicability of DCB in small vessel disease, for high bleeding risk, even for a STEMI patient and STEMI patient. So DCBs are now getting applicable in all such patients. Coming to the guideline recommendation, this is the main problem why this debate was kept, because DCBs, there is no indication as on today in an ESC or an ACC for use of DEB in de novo coronary vessel, small coronary vessel, but they are a class 1 indication only for ISR. So till now it is not in the guidelines. That is why this talk has been included. But you just have some position papers by Italian and German and other societies where they have just given some their consensus and recommendations. So what is my experience of using DEB? My experience is at present only with Concept Medical's Magic Tuck sirolimus balloons. So why sirolimus? It is cytostatic and not cytotoxic. We'll see why. It has 10,004 mole safety. It is anti-inflammatory. It has a slower tissue absorption and a short tissue retention. So why is it cytostatic? Because paclitaxel is acting at the mitotic phase of the cell cycle, and it is irreversibly inhibiting the cell division. While sirolimus, it is binding reversibly to the rapamycin receptors. So this is how the coating is done. The balloon is initially inflated and the spray coating is done. Then it is folded 3 times and then packed so that when we inflate, we have a homogeneous drug delivery. So this is the chart showing on the left side the concentration of the drug-coated balloon, the drug in the de novo coronary region, and this is in an ISR. So as you can see, there is a steep decline, and at between 30 to 60 days, the drug absolutely disappears. So this is why 1 month DAPT still you will require if you treat your patient with a DEB. So coming to this, the key for a successful DEB implantation is whether you have prepared your bed optimally or not. Because a DEB is designed to deliver an anti-proliferative drug and not to relieve a stenosis like your NC balloons. So this is how your balloon should be applied after a pre-dilatation, 1:1 pre-dilatation. You should assess your angiographic results. If you have no flow limiting dissection like your type A or B dissections, or residual stenosis is less than 30% and an FFR is more than 0.8, then you can still go ahead with a DCB. But for all the other cases, like if you have type C and more dissections, if you have a more residual stenosis, FFR is low, then you should proceed with a DES. So now what if you have used a DCB in your patient and you have a dissection? So what will you do? So this is a study which showed that what happened to the patients who were left with the dissections. At 6 months angiography, 45 of those dissections were healed and only 3 of them were chronic, and they included all the type A, B and C dissections. So we should not be afraid of the dissection. There are many ongoing trials and unavailable data where sirolimus balloons and are being compared with paclitaxel balloons and even with giant stents and whatnot. So there are another types of drug-coated balloons which are coming up, like they are having stent-like profile where they are going to cover the drugs up to 90 days to cover the smooth muscle cell proliferation and migration. So what is the take home? A stent-free treatment of CAD with a DEB is a safe, effective alternative of treating side branch ostia, long diffuse lesions, bifurcations in diabetics, and even mid to distal LADs where in future your surgeon might not get upset of putting a graft. So DEB results in significant luminal growth at 6 months, and the key is optimal lesion preparation, and we should not be afraid of dissections. We should not be cosmetologists. We should remain as cardiologists, because if you are I showed you that if you have a type A or B dissection, we should not be afraid and just go ahead and put a stent. And you should have confidence in the DEB, because how will the confidence come? I also had initial hesitancy of using the DEB, because just with practice, start with simple cases and then with the complex cases, and then seeing is believing. So we have come a long way of coronary progress in revascularization, from initially only bypass surgeries to POBA to then BMS, then DES, first generation, second generation, and now we have come to our metal-free PCIs with DCB first generation, biovascular scaffolds, and now second generation DCBs with sirolimus and solution SLR, as I was mentioning. So I suggest here is not to choose any one therapy, but a hybrid interventional approach, DCB, and if you have a good result, your non-flow limiting dissections, your FFR is good, your residual stenosis is not much, then you can leave it. If you have those, then you should go ahead and put a DES, because the future is going to be a DCB with a biovascular scaffold or a resorption repair device. So maybe in CardioCon 2024, we'll hear more about resorption repair devices. Thank you. The best strategy for preventing stent-related issues is still not to have a stent.
Thank you very much. So I'll invite the next speaker, Dr. Bhavesh Roy. He's one of the best interventional cardiologists, and he's practicing at Zydus Hospital, and is a fellow of European Society of Cardiology and FSCI and also FACC. So he'll be talking on stents implantation in small vessel disease.
Thank you all. Although it is a debate format, and our opponent is not the Prashant or another, but it is the small vessel disease. So in general, we will be knowing our enemy or opponent, what it is and how it differs from the other larger vessel disease subset. A brief about our patients, hypertensive and diabetic patients. So already a high risk at the low age. Presentation as a known ST elevation MI and lateral wall MI. Treated with the ticagrelor, and LV function is not mentioned, but I think it should be a mild or normal LV function. Ongoing symptoms, whether a patient is having ongoing chest pain or not, it is not mentioned. And we assume that MI, already deep T wave inversions were mentioned. So we expect that MI part is almost over 3-4 hours, and now he is stable. And vitals 100/60, I will consider that not as a hypotension, but maybe he may be normotensive with the medications. And angiography showed a critical ostial stenosis, 15 millimeter, tight in D1. What not mentioned is probably a length of the D1 and length of the LAD, type 3, type 4, type 2 LAD. And the diagonal, which is an ostial disease, runs parallelly as a major diagonal dual LAD, that is not mentioned. So coming to our small vessel disease education or the learning, that how we approach to a small vessel disease. Small vessel disease is present in 30 to 67% of the patient undergoing angioplasty, especially in female patients, in patients with diabetes, and in patients with the chronic renal failure. These are the three subsets in which we found a small vessel disease. The definition of the small vessel disease, when we are discussing about the small vessel, what it is the exact definition? Initially, it started with the 2.8 millimeter and 3 millimeter. And then as the newer devices started coming for the treatment of 2.5 and 2.25, the newer definition came as a 2.25 to 2.5 and ultra small vessel disease also, which is a 2 millimeter and 2.25 millimeter vessel also. All the trials which have been mentioned by the for the drug coating balloon and for the drug eluting stent is having a different criteria cutoff for the 2.25, 2.5 and 3 millimeter. So one trial or second trial cannot be compared in between because the subset is different. All these patients and lesion characteristics, which are the small vessel, diabetic patients, chronic renal failures, and female patient. This is the risk for the device failure, whatever we do. So we have to understand that if we are doing angioplasty with a 3 millimeter, 3.5 millimeter versus 2.25, 2.5, already our patient is at a high risk for the repeat need for the revascularization. Patient with the vessel diameter of more than 2.5, less than 3. And those with the vessel 3 are having a TLF rate 9 versus 5. Significant rate is already there. This we have not reached up to the treatment part. It is in general. So vessel size and long-term outcome. This is what we discussed, right? This is the trial background. Now, some of the facts about the small vessel disease. Remember that whenever there is a small vessel disease, more likely to have a proximal disease. And if the proximal vessels are having small vessel disease, then the distal are also very likely to have. It is usually combination. It is very, very unlikely to have an isolated small vessel disease in the PDA PLE. It will be usually a subset of diffuse disease. The amount of myocardium tributary depends not on the diameter only, but the length of the blood vessel also. Third thing is that true diameter of the vessel we don't know. Sometimes it is the 2.5 millimeter vessel looking like a Sometimes it looks like a 2.5 millimeter vessel, but if you do the coronary imaging, it may turn out to be 2.75 vessel also. And after vasodilatation, when the patient is in MI and you are giving some fluids and nitrates, there could be a vessel not fulfilling the 2.5 mm criteria or small vessel criteria. Accurate assessment of the vessel size depends on the coronary imaging, state of adequate vasodilatation, and relaxation of the patient. None of the study so far discussed by the drug-coated balloon favoring or which I will be discussing, drug-eluting stent, is not having any coronary imaging done in the background. So this is the background of the small vessel disease, that how the trials are analyzed. Now coming to the study data, the contemporary second generation DASH showed an outstanding performance in the patient with the small vessel CAT. When we say small vessel, it is around 2.75, 2.5 and 2.25 and 2 millimeter. Great number of dedicated studies, subgroup analysis of the large randomized studies. New generation DASH reduced both late lumen loss and the clinical restenosis. This was seen even in the small vessels that tolerate late lumen loss less well than the larger vessels. In addition, the rate of death, MI, stent thrombosis were low, which underline the safety of these devices. I will show the data. So this is the trial 3 millimeter, the same trial basket trial, which was having an arm of the drug-coated balloon also, basket small trial. Then this is for the 3 millimeter vessel. Now 2.75 bioflow, leaders and the Olivera. So we are coming to the another trial, 2.25 data, less than 2.25 data. So we are having a 70, 835 and 101 patients for the less than 2.25 patients. And we can see the TLR in the range of 4, 6 and 2. TLR is quite low. If I will go back to previous slide, see the data of 2.75, 1300, 800, 1300 patient sample size with the vessel size of 2.75. Now coming to the 2.5 millimeter size data. This is the size which our patient is having. And see the number of sample size, 1500, 1600, 1900 patients, and see the TLR rate ranges from 3% to the 4% to 5% only. And these are the follow-up of 2 to 3 months. All the patients are having DAPT follow-up for 6 months. So this number of trials shows that we are having a single digit, less than 5% TLR and TLF with a 6 to 12 months of DAPT with the available stents. These are the dedicated small stent registries, trials, not registries, sorry. So result is due to what? Why this result came? The result is because of the strut thickness. Orsiro versus Zane's bioscience studies and bioflow studies and bioresult. These are the polymer-free stents with the 60 micron strut thickness And the cell design, like Resolute, is also developed in such a way that it is single wire coiled or laser fused devices, which will reduce the need for the polymer, and chances of restenosis, late lumen loss, and strand thrombosis will be significantly less. A number of studies suggest that the patient with the diabetes and small vessel disease could benefit the most from the use of drug-coated balloon instead of drug-eluting stent. Yes, I'm telling about the drug-coated balloon. Which trials? Basket, Small 2, and Bellow, which our Prashant described. But what they have written, just I will write down. The use of drug-coated balloon in de novo lesions, which are not appealing for the implantation. For the stent, represents a growing indication. Number one, the use of DCB in anatomic setting adverse for treatment with the DES was only shown to be similarly efficacious. So this is the statement given by them. Now coming to the trials of the drug-coated balloon. These are the trials for the less than 3 millimeter, less than 2.75 millimeter, and less than 2.5. See the number of slides available, number of trials available. Only 4 to 8. Number one. See the sample size. Sample size is 700, 100, 57, 230, and 101. These are the data for the vessel size included for 3 and 2.75. For 2.5, we are having only one trial. So Bellow, Basket, and Piccoletto doesn't apply here because it is for 3 and 2.75, not for 2.5, which is there. Estimation, TLR rate and TVR rate. See the rate 6, 5, 32, 5, 5, 4. TVR rate 32, 10, and 5.3. Significantly high as compared to what we have seen even for the 2.25 and 2.5 in the stent studies. So what are the limitations of the data, including DCB or DEV? What are the limitations? Number one, what we described initially, diameter was assessed in a different ways. Some trial had a QCA, some trial had a visual estimate. Number one, range from the visual assessment to QCA. None of the study used any imaging or the coronary, and very limited head-to-head comparison data. None of the trial had a head-to-head comparison data. So last comparison trial, we are having only, I could find only one comparison trial, which was a head-to-head trial. Percutaneous treatment and outcome of small coronary visit, SCAR report. This is basically see the number of patients. The aim of the study was to investigate the outcome of patients with de novo lesions in the small coronary vessels undergoing PCI with the DCB or the new generation DES. Methods. 2009 to 2017 patients, number one. Vessel size is less than or equal to 2.5 millimeter. What are the number of patients analyzed? 14,788. It's almost 15,000 patients data. With the drug-coated balloon, 1,154. Very high number of DCB. 13,000 patients with the 2.5 millimeter size stent. 13,000 patients. Okay. The propensity score, see the data, you can read. What is the conclusion? Conclusion is that because of the significant higher risk for the restenosis, I am reading the restenosis up to 3 years. This research suggests that a DCB are not an equally effective alternative to newer generation DES for PCI of the small coronary vessels. This is the flow chart of the patients, how they were included. All patients with the small vessel CAD who underwent PCI were enrolled, and then restenotic lesions, BMS, all generation DES, they were excluded, and then a head-to-head analysis was done. This was the curve, Kaplan-Meier, and we can see that immediately within first year, both the curve started separating for the DCB versus the drug-eluting stent. Procedural characteristics. Now this is very important. See, it is not a diagonal vessel. See, it is for the LAD, LCX, and left main. It was not for the small vessel disease of the OM or the PDA or PLV. These are the main blood vessels, number one. Number two, see the bifurcation, 228 versus the 1600, less the p-value less than 0.01. See the number of devices 2. See the type B2 and type C lesions. P-value was significant. So I'm telling, even in bifurcation, even in complex lesions, even in the main coronary artery, not in the branch vessels, we are having a better result with the drug-eluting stent, which is of newer generation, when the vessel size is of 2.5. This is the favoring DES versus favoring DCB in the different subsets, in the age, in the diabetes, whether bifurcation, whether presenting with the ACS, or whether having a complex lesion. So with this enough information, our management strategy is clear that it should be a drug-eluting stent. It should be a newer generation drug-eluting stent dedicated for these small vessels. And How to approach? This is not related to this our patient, but in general, how we will. Number one, we will give the nitrate. We will go for the coronary imaging if possible. We will assess the length of the blood vessel, expected myocardium under threat. We will remember that small LED is different than the small vessel OM or distal PDA-PLV. Long lesion in the small vessel versus short lesion in the small vessel. Both are different. If we are having a small vessel, but this lesion is very long, where I am putting a 2.25, 2.5 stent, which is of 38 or 48 millimeter, I will differ. I will go for the drug-coated balloon. But if I am having a 2.5 millimeter diameter with a lesion of only 15 millimeter, I may go for the stent. Expect higher chances of restenosis. Start with the gentle POBA, see the response, flow-mediated vasodilation, and then decide. See for the dissection also. Choose dedicated stents and drug-eluting balloon reserved for small, long lesions in the branches, that is 2.25 or 2 millimeter, where we think that, okay, medical management or doing something is equal. This is the main pitfall of the trials, small vessel disease. What is it? Do the POBA. If there is any dissection or restenosis, yes, then go for the registry, not the trial. And what trials were shown, this Piccoletto, Bello, Basket Small, is the 2010 trials. It was with the paclitaxel, not with the sirolimus, which is available right now. And the number of patients were less. And we can see, they have not highlighted, 20% of the patients in the trial had a stenting done. They were posted for the drug-coated balloon arm. They went for the drug-coated balloon, and 20% of the patients went for the stenting. So these were deviating the results. So this is again the same. We can see that 10, 19, and 19% went for the DES BMS. PepCAD, I'm not, or ISAR China, I'm not going into the drill because it was a restenotic trials. And our patient is not having a restenosis, it is a de novo lesions. So restore SVD also I'm not going in the detail because the dropout rate or the bailout stand rate is not mentioned in that. So this is the case. I think that should be sufficient for us to have any questions and comment, please.
I think the very good debate, Dr. Prashant and One is Resolute Integrity and Orsiro. Orsiro is having a 2.5 size available, and specifically for the 2.5, we are having a 60 micron straight thickness, and even in the main blood vessels, we are putting 2.5 millimeter. If we ask the data of interventionists who are using all the stents, they will be putting probably 20 to 30% of the stents as a 2.5 category. So, Orsiro, my preference will be Orsiro. Availability of Resolute, we have to ask for the 2.25 millimeter stents in our store. It is not routinely available, all the sizes. So if you are having any 2.25, then Resolute is having another 2.25 dedicated stent available. 2 millimeter size stent is also available with the Medtronic Resolute. So that patient we have to take off the table, ask for the stent, and then go for the procedure in the next sitting.
I think the main issue was here, it's a good discussion between both of you, but main issue is here a young patient, right? Young patient with the drop positive ACS. So now there are multiple question comes in mind, whether recurrent chest pain, one episode of chest pain, how high was the troponin, what was the osteal diameter, what was the length of myocardial supply?
Yes.
The main issue is not diameter, but whether how much of myocardium is supplying by that vessels. And on top of that, whether ischemic dynamic changes or not, or just only drop mild positive. So there are so many questions we have to decide before we just conclude on this simple scenario. And I think especially despite of we are interventionists, like, you know, if I'm in this place, would I at the age of 35 years, I would prefer to have stent.
No one would like to have a stent.
Exactly.
Or
Especially
like to have a MI or any treatment.
Progressively important vessels not that's more important other than deciding and the there are a lot of trial between DAB and DES, but do you have any trial with aggressive medical management in specific patient compared to DEB, compared to DES, and then see if the aggressive medical management wins over long term, especially in the patient who has not diffuse disease, only single discrete disease, and that's why it's important. In all these trials they are showing a lot of data, but each patient are different. I think we have to decide about the patient presentation, myocardial supply, and a lot of patient recurrent symptoms. Yes. So then only we can decide rather than just building the trial itself. Okay, oh, we follow this trial, we follow this trial. I think is a common sense by the cardiologist is very important in small vessel disease, especially in deciding, especially young patient. In old patient we understand, but in young patient it's so difficult for us
especially like a lot of, it's a good controversial topic. You know, some colleges advise, oh, go for DB, some colleges go for DES, and some say micromanagement. So I think each patient is different outcome. At this, I think I can conclude on this session, I think.
Thank you.
Questions? Anyone has any questions? Any discussion about the small vessel disease? Especially when you are diagnosed osteolis disease side branch, and what about the main vessels? I think you are trying to compromise main vessels, or it's not easy, like, you know, trying to put the stent, and then you compromise main vessel, you'll end up with the stent there as well in a young patient. And I think it's a always have to decide is a joint discussion between the patient, individual specification of angiography, patient choice, and then about your colleague and whatever discussion happens. But it is any questions anyone has for small vessel disease? It's good debate, good discussion, both of you. It's a congratulations. Thank you. To conclude the session, thank you.
I would like to request to give you a group photograph. I would like to invite Dr. Prashant Wazirani and Dr. Bhavesh Roy also to just come on stage. And it was really a lucid way of presentation by both the speakers. So give a big round of applause for the speakers, chairperson and moderator for this session. Thank you. Thank you so much, all the speakers, chairperson and moderators. And now it's, yes, there is a quiz. So would like to request somebody can remove that on the screen. Madam, just remove that brochure. Yes. So online we had created one application, Cardiocon 2023. You may give your right answer. Completion of this conference, there will be the calculation of a point. So whomsoever has given a right answer as many times, so there is some surprise gift for the audience as well. So would like to request audience to just access application and give the right answer of this question. And there are four answers are there, and select the right answer among these four. So thank you, and now it's time to move ahead for the next session. Next session, I would like to invite Chairperson Dr. S.S. Kothari from Delhi, Dr. Swati Garekar from Mumbai, Dr. Amit Mishra from Ahmedabad, and Dr. Bhavesh Thakkar from Ahmedabad. I would like to request chairpersons to come on stage, and moderator for this next session, Dr. Tarun Parmar, Dr. Anil K. Jain, Dr. Ketav Lakhia from Ahmedabad, Dr. Nilesh Oswal from UK, and Dr. Abhay Pota from Ahmedabad. So I would like to request all the dignitaries to just come on stage. Also, I would like to request a chairperson to give a brief introduction of this first speaker of this next session. Over to you, chairpersons.
I'll just send it over to Swati for comment and starting the session.
Good evening to all of you. Like Dr. Kothari said, an interesting problem and a common enough one. An infant who is not gaining weight like they're supposed to after birth and has been diagnosed to have a PDA. The PDA is large, going by the size of 4.5 mm mentioned. And you have a QPQS2 probably calculated on echo, or maybe it's a guess based on the degree of left heart enlargement. So certainly a significant PDA, they are saying. There is pulmonary hypertension, and that's flow related. There is nothing else apparently. The biventricular function is normal. The left heart is enlarged as expected. So can one of the moderators then take over and introduce the speakers?
Just a brief comment from Nilesh also before we hand it over to those who are physically present. For smooth operation, we will hand it over to you after a brief comment from Nilesh also.
Yeah, good evening, everybody. I think we are a little bit behind India time.
It's as mentioned by you and Dr. Swati that PDA is long-standing issue, but we have made a lot of progress. So this debate may be very useful to know whether it is a surgical or intervention procedure is useful in such cases. So now I think without delay we should start this topic, and maybe moderator introduce our speaker at this time from Ahmedabad. Thank you.
Good evening, everyone. Today's topic is large PDA in infancy, and we'll start with a talk with Dr. Bhavik Chapanari. He is MD and DM from Amrita Institute of Cardiology, and he is right now Associate Professor in UNM ICRC.
Hello. Yeah. Good evening, everyone. It's my pleasure to be here on this platform, and I'm thankful to the organizer and Dr. Kamal Sharma sir for giving me this opportunity. I'm very happy to see our colleagues sitting here also. So first, the debate is about a large PDA in a young infant. What is a good strategy, device versus surgery? So first, I'll start with the accepting the facts. So first of all, pediatric cardiology as whole, it's not an independent field. You cannot survive and you cannot work like an independent pediatric cardiologist. So it's a totally interdependent field. The pediatric cardiologist, pediatric cardiac surgeon, intensivists, anesthetists are all equally responsible for taking care of children, and they are all interdependent. And any complex intervention, when a pediatric cardiologist is planning, it always requires the presence of a pediatric cardiac surgeon who is there to bail you out when you end up with some sort of complication. And we are very fortunate that we have a good team of pediatric cardiac surgeons at our institute who are backing us, and because of them we have reached to the state where we are able to do many of complex interventions which is possible and which is being done everywhere. So overview of my talk is about case details, my decision, why device closure, evidence about device closure in young infants, case examples, and take home message. So first of all, about case detail, it's a 2-month-old female, weight is 3.5 kilo. The child she's having failure to thrive. There is a murmur. Echo is showing large, long, tortuous PDA with a size of 4.5 mm and severe pH is there. QPQS is calculated to be 3.1:1. So what would be the best strategy? So first of all, looking at these case details, there is no doubt that this patient or this child requires some sort of intervention because child is symptomatic. So we have to close this PDA by any means. What would be my strategy? My strategy, being a pediatric cardiologist, obviously I am favoring a device closure. But why I am favoring, I'll give you evidence for that. So PDA device closure is my strategy, but as I have told, it's not a straightforward case of PDA device closure. So I'll always keep my surgeon informed that I'm doing such case. And in case of emergency or in case of complication, he should back me up. Device selected for this patient would be Amplatzer vascular plug because it's mentioned as a long tubular PDA, and size as my planning would be to use 8 mm or 10 mm vascular plug. So before going ahead in the discussion, I would show the advantages of my transcatheter intervention because I don't have to show anything against surgical solution for this because PDA ligation is very well proven to be very safe and effective. It's one of the very proven pediatric cardiac surgical procedure, and there are not much of disadvantages associated with procedure. So I'm not against surgery. I'm just favoring device or transcatheter intervention in this patient. So first, what is the advantage? It's less invasive. There is no scar. So obviously, and there are proven data showing there is a psychological impact of sternotomy or thoracotomy scars in children when they are reaching to adolescents and adults. So that no scar is very important. Minimum ICU stay. Almost all patients with PD device closure may remain in ICU just for observation for 3-4 hours, and they'll just be they'll just go to ward, and that's why ICU related morbidity is very less. Less hospital stay. They may stay for nearly 2 to 3 days max, and they will get discharged maybe on the same day of procedure. There is no chance of pneumothorax, recurrent laryngeal nerve injury, It's again less with surgery, but it is possible. Theoretically, it is possible. So that is not there in case of transcatheter intervention, and there is no need for general anesthesia because majority of cases we are doing under local anesthesia and transvenous sedation. So the complications which are associated with general anesthesia can be avoided. So coming to classification of PDA, it's a Krichenko classification, and there are 5 types of PDA depending on this classification. This is the most common type of PDA, that's type A and conical PDA. This is a PDA where there is no ampulla. It's a short flush PDA like a AP window. This is a type C PDA, which is called a tubular PDA, which it's a classical PDA of a preterm child, and these are more complex sort of PDA. So the case details which has been provided, when we are talking about isolated PDA cannot be actually tortuous. It can be long, it can be tubular, but usually it's not tortuous. So I'm assuming that the case provided to us, it's a tubular and long PDA, and that's why my focus of discussion will be on long and tubular PDA. So what do you mean by tubular and long PDA? So this is a classic example of a long tubular PDA. This is a ductal angiogram showing a long and tubular PDA. And this is an echocardiographic image of ductal view, which is again showing a long and tubular PDA. So what is advantage in long tubular PDA? You have a good landing zone. So you have a good length of PDA available where you can put your device, and because it's a long tubular PDA, you have many choices of devices to select, and there is less chance of aorta and PA compromise because it's possible you can deploy the device totally inside the PDA and you can avoid jailing either LP or aorta. So that is advantage in this patient, and that is that's why I would encourage, or I would prefer device closure in this patient, because this was a long tubular PDA. I'm encouraging for PDA device closure. So what is ideal age and timing for PDA closure? It's this has been taken from an Indian guideline published by Dr. Anita Saxena madam from AIIMS Delhi. So large moderate PDA with congestive heart failure, earliest closure by 3 months of age. Moderate PDA with no heart failure, we can close it by 6 months to 1 year of age. And if there is failure to thrive, we can close it earlier as well. Small PDA, we can close it by 1.5 years of age, and silent PDA, usually it's better to leave them alone. So method of PDA closure. So again, I've told you this was published in Annals of Pediatric Cardiology in 2019, and here they say weight more than 6 kilo, class 1 indication is, again, it's individualized and device is more preferred over coil or ligation. But when weight is less than 6 kilo, surgical ligation is preferred, is class 1 indication. And there is the off-label use of devices has been increasing because nowadays it's feasible because of availability of various devices which can go through which are low profile and go through a low caliber seats as well. So what is evidence on PDA closure, device closure in less than 6 kilo of child? So this is a paper published in Circulation. This is the largest series of infants with less than 6 kilo of weight. The number is 747 infants who have undergone PDA device closure, and this paper shows us how effective and how safely we can close PDA devices in these patients who are weighing less than 6 kilo. The study duration was around 3 years. Total patients included, all patients with less than 6 kilo of weight were included in this study. They were further divided into weight subgroups. Less than 2 kilo was called extremely low weight, 2 to 4 was very low weight, 4 to 6 was low weight. So total 747 patients were enrolled. Median age was 4.3 months. Median weight was 4.6 kilo. And procedure success, you can see, was 705 patients out of 747 patients were successfully closed with the PDA was successfully closed. That comes to a success rate of around 95%. So, and when the procedural failures were looked, the weight was not a criteria. Among all weight groups, the procedure failure was more or less same. It was statistically insignificant. And the composite failure multivariate analysis was done for composite failure, and only variable which was found to be significant was age at intervention. If the age of the child is less than 30 days, it may be that may give rise to some sort of it was associated with composite failure, that's procedural failure and major adverse events. These were the major adverse events documented, and most common adverse event was arterial access injury. That was just a pulse loss which was requiring a heparin infusion. That was seen in 3.5% of patients. Device embolization was there in 2.4, that was 18 patients out of 705 patients. Arrhythmia was documented in 1.7%. Major bleeding which required blood transfusion was observed in 11 patients, and there was no death documented which was attributed to the procedure or was related to procedure. So this data shows that we can close it, the PDA devices in less than 6 kg of infant with relative safety and efficacy, provided you keep meticulous planning of the procedure which will prevent further adverse events, and that's why the concept has come that more and more the weight is low, you can avoid taking arterial line, which will take out nearly 3.5 or 4% of complications, but just by avoiding taking artery and thus doing device closures by taking a venous access alone. So as time has grown, now more and more preterm babies are also being subjected to transcatheter PDA device closure because of availability of various low profile devices. And this is a paper, it's a meta-analysis of infants less than 1.5 kilo who is undergoing transcatheter closure. It was published in Journal of Pediatrics in 2020. Total 97 studies were reviewed, and total number of infants weighing less than 1.5 kilo was around 600. Success rate was documented to be 96%. Major adverse events documented was around 8%. 5 deaths was observed, that's around 1% of mortality, and 4 out of this were the infants less than 800 grams of weight. So this again shows that even in preterm babies or even in low weight babies who are less than 1.5 kilo, because of availability of specially designed devices, the transcatheter closure is feasible. Obviously it requires a lot of knowledge of hardwares and the paramedical and non-cardiologists like intensivist, anesthetist support as well. So these are the various devices available for PDA devices. These are the more common devices which are being used. This is ADO, Eblets Duct Occluder 1. Piccolo device is a specially designed device for preterm infants which can go from a 4-friend sheath. Employs the vascular plug 2 is also a low profile device which is often useful in patients which is provided to us like a long tubular PDA. These are devices in preterm babies, and this is a recently available device that's a Medtronic microvascular plug which can go from a 3-friend delivery system and has been effectively being used in patients who are very preterm and less than 1.5 kilo. So when we are planning any PDA device closure in any patient who are low for weight, so echocardiography evaluation becomes the major important thing for planning the procedure. And what we are looking in echocardiography is the type of PDA, if it's conical or tubular, what is the size and length of PDA, what is adequacy of branch PS, how is the arch, how arch adequate the arch is. And out of this, I feel adequacy of arch is the most important finding, which encourages you for device closure and which will avoid you from doing devices. So this is an example. This is a 3-month-old male, 3 kg, PDA is 3.7 mm, and this is how we assess the arch. This is the PDA size is around 3.7 mm for a 3 kilo child, but the arch, as you can see, measurement which is around 7.7 mm. So it's usually if the arch measures around 7.5, there are many operators, they say that you can put a device which is around 8 into 6 mm, but not more than 10/8 device, not more than 8/6. That's a 10/8 device. So this patient was subjected for PDA device closure, and PDA was closed with 8/6 ADO1 device. This is another example. It's a 8-month-old female, 3.5 kilo, 3.9 mm PDA, as you can see. But on evaluation, it's found that the arch is narrow at the isthmus, and it measures only around 3.2. There is no coarctation as of now, but this narrowness of arch here you can see the isthmus is narrow. So this narrowness of arch may hamper or may prevent you from doing device, and this and if you do device for this patient, you may end up in complication of aortic compromise. So that's how you see the adequacy of arch. I'll go through few case scenarios. This is very similar case provided to us. It's a 4-month-old female, 3.7 kg weight, recurrent LRTI, large tubular PDA, severe PH, PDA diameter is 5 and length is 14 mm. This is an echo image large dilated LALV. There is significant mitral regurgitation because of dilated mitral annulus secondary to LV dilatation. This is a subcostal image showing a large tubular PDA with left to right shunt. This is a ductal view showing a large tubular PDA which is left to right, and this is a measurement. As you can see here, it was measuring around 4.5 mm and length was around 20 mm. So this is how PDA is being assessed by echocardiography, and that's how we decide on the planning what device should be selected. So based on this, the device selected was around 8 or 10 mm vascular plug. This is an angiogram showing a long tubular PDA which measures the size of 5 mm and length is 14 mm. And as planned previously, patient underwent PDA device closure with 10 mm Amplatz vascular plug 2. Post deployment of the device, LPA has been checked whether it's flowing well and unobstructed, and arch angio is showing a good device position and no obstruction in aortic arch. So this is a post procedure echo image showing good device position. This is case 2, 10-month-old child. Again, large tubular PDA, but what is there? It's a narrow isthmus, and patient was taken for PDA device. As you can see here, the arch looks slightly small inside. So here we had a worry that we may end up in a scenario where there is a possibility of some sort of aortic compromise. PDA device was done with 10 mm AVP2. The angio showed unobstructed LPA, but echocardiogram showed device protruding into aorta, causing some sort of obstruction, and that's why balloon was taken to reposition and push the device further inside the duct, and that was helpful, and eventually we were able to do successfully the device closure. So that's how the pre-operative echo guided us that we may end up in such complication, and we were mentally prepared. This is third case. It's a 1.6 kilo failure to thrive. Birth weight was 1.5 kilo, large PDA. Patient was taken. This is echo, dilated LALV and large PDA.
I think time is over.
I think I'll just take 2 minutes. So here, as I've told, that arterial access injury is the major complication. So to avoid that, usually in smaller babies, we don't take artery. It's a venous sheath passed across PDA. This is an angiogram, and the same PDA being closed with the Piccolo device 5-6. I'll run through this case. Sometimes we end up with complication where you are not able to put a device which is more particular size. Suppose this was a case where ideal candidate for 10-8, but 8-6 we were not able to put 10-8 device because of small arch. So sometimes we have to wait on table, and we wait for the residual flow, how it's coming down. If it is coming down and PA pressure is coming down, we sometimes make a decision that if since PDA is getting smaller and smaller, the residual flow is getting smaller and smaller, and PA pressure is coming down, we sometimes release the device, and at the end of the release of the device migrates, and eventually we have to take the device out, snare out the device, and patient underwent PDA ligation next day. This is a post-op patient who underwent PDA ligation. It's a 2-month-old child, weight was 2.2 kilo, currently he is 1.8 kilo. Because patient was hemodynamically unstable, sternotomy surgery was done for PDA ligation. There was a residual flow from PDA, and there was a small VSD, and because of that we were not able to extubate this patient. Both PDA and VSD had to be closed with Piccolo device, and eventually on 4th-5th day patient was extubated and sent home. And this is the youngest child who has underwent VSD device closure, and this was reported in 2017. So take home message: PDA device closure in young infant is feasible because of specially designed devices, although it is associated with significant adverse events, but which can be prevented with meticulous planning. In-depth knowledge of hardwares and device is required. Meticulous echocardiographic evaluation is very much needed. Surgical backup is often needed in such procedures. Thank you.
Okay, I'll invite Dr. Tushar Gajjar for his views on surgical closure of PDA. Dr. Tushar is a senior pediatric cardiac surgeon at UN Mehta Institute of Cardiology and Research.
Good evening, all chairpersons and respected moderators and chairperson and audience. My talk is on minimally invasive surgical closure. Now, it's not moving. Going to the basics, I think I don't have to go in. Can I do this from here? Okay. Going into the basics, I think Bhavik has already explained. These are the guidelines given in 2022 by Indian Academy of Pediatrics. Similar thing, what Bhavik has said. We have the moderate size PDA with us, and guideline says that more than 4 kg only can be device closed, but I think it's an institutional policy and the experience of the interventional cardiologist. But the guideline says surgical ligation is there for patient less than 4 to 6 kg. PDA is of unusual shape. There is progressively enlarging or aneurysmal PDA, or there is endocarditis or endarteritis. This guy who has done revolutionary surgery in 1938-1939 with PDA ligation, and has opened up the avenue for a lot more surgery. Basically, as a surgeon, we do PDA ligation through thoracotomy, which is whatever incision we put, that is going to be minimally invasive only in a pediatric. It's like through lateral thoracotomy, or we do through anterior thoracotomy, or through VATS. Probably the number 2 incision is we may do with the conventional 2 retractor, and that is the minimally invasive approach for PDA ligation. We ligate PDA with either clipping if it is a small or moderate size PDA. If it is little, all size PDAs can be ligated, or additional safety we can do transfixation. If PDA is large and short stumped, then we might have to divide it and suture it. And something like window-like ductus, we have to go on pump and close it. These are not amenable to device closure. Now, for surgeon's point of view, PDAs are not like various designs. We have like either acute angle, the first image, or the obtuse angle, which is important for us as a surgeon while looping it. Or PDA may be either small, moderate, large, or window type. This is only for surgeon's point of view. We can see surgical complications. Hardly there are less than 1% complications, whatever has been mentioned by my friend. First transcatheter closure was done by Portsman in 1967, and I think after that, a lot of evolution has come in transcatheter closure of PDA. This is what he has already explained about the various types of angiographic views and PDA description. In today's case scenario, if you see this 2-month-old, my question is about access. I think it is not going to be an issue with the experienced cardiologist. 3.5 kg weight also is not going to be an issue with them, but it's a 4.5 meter long tortuous PDA. Tortuous PDA, what is it? It's a abnormal type of PDA, and with a moderate size, and it's a shunt of 3:1. These are some papers which has done comparison of surgery versus transcatheter closure, and this was in NEJM. Probably might be too old to comment on, but still they have said that the more effective and less costly surgical procedure was superior to transcatheter placement of occluder. So they are not supporting the transcatheter only surgery, they are supporting the more recent one, 2014 article. This was a meta-analysis of 7 published report of transcatheter versus surgical repair. And I think they concluded that despite various limitations in their study, they have found out that there is no significant advantage of catheter-based versus surgery, except they have reduced hospital stay, but they have more complication of residual shunt by transcatheter closure. This is one more paper which is a little bit more recent and of 2021, which says that transcatheter closure is far better than the surgical closure, but they have put a limitation which is highlighted in the box, that prospective clinical trials are necessary to evaluate the clinically relevant differences of low cardiac output syndrome following transcatheter closure versus surgical ligation. So this was one of the thing, and then there are papers on complications of device closure. I think there are, this paper has mentioned about major complication, which is 3.4%, like significant hemolysis, infective endocarditis, or device embolization. Minor complications like device projecting in LPA or in the aorta or like nickel toxicity, it's like 5.1%, and there is a residual shunting which is significant, 0 to 42% in initial phase. Probably less hospital stay, but shunting is there and they require frequent follow-up of the patient to see that there is a residual shunting. There are some late complications. You can see in this figure that the device is embolized late into the RPA and it required surgical removal later on. There is devices caused in first picture. You can see there is a LPN narrowing, and here it is caused DTA narrowing. Especially if you can look at the acute angle PDAs, what surgeon looks at it. This might be the cause probably for DTA narrowing. And this is the device retrieval from LPA where I think surgeon bails out the cardiologist. And these are somewhat some more examples of device embolized in LPA. And this is what the second image is, little dreaded complications where device is embolized lately into the descending thoracic aorta and caused the spinal cord ischemia, and patient had a paraplegia. So though it has been retrieved and it recovered over a few years, but that is one of the dangerous complications for the patient. So sometimes devices cause coarctation, and we have to even remove that segment and device retrieval and do the end-to-end anastomosis. Though cardiologists can take out the device, and while retrieving, they injure the peripheral vessel, and we have done this interposition grafting for the peripheral vessel. And sometimes the device has caused damage to the valvular chordae and the papillary muscle, and that also needs to be tackled by surgeon. So ultimately what comes down in the era of Ayushman or in the era of the school health in Gujarat, it doesn't matter whether device or it is a surgery, but in private sector or corporate sector, it matters device versus surgical closure. It is almost like it's a costly affair. So my take home message is, if a standard time tested, less time consuming and pocket friendly surgical PDA closure is there, it's a preferable strategy for this patient. Thank you.
Paper is open for the discussion.
So, can I start, Amit?
Please. Any comments from the audience?
Couple of points that PDA closure is one of the most satisfying intervention, because it's completely curative, safe, and really effective, and thousands have been done. So today, device closure of PDA has come to stay. But this case is little different. Here is a specific case of a very small baby with a large duct. And there the arguments of decision making both have highlighted what are the variables to be thought. I just like to add a couple of points that when you, in terms of the procedure, that when you take a larger device, you have to be mindful of the fact that it will lengthen. So the length of PDA is important. Secondly, when you put a big stiff things in a small baby, one of the complications is that the heart gets stented. Then you suddenly find there is hypotension and you don't understand what is happening. And what is happening is that all the valves are getting stented because of the stiff device. So whenever you do a device in a small baby, be mindful of stent. Third thing is just by the way that PDA is a very bad lesion. A large PDA is a terribly bad lesion for Eisenmenger. And it really get into Eisenmenger as by 1 year of age. So it needs to be treated, no doubt. And some of the PDAs do close. So as Dr. Tushar highlighted, some of the preterm PDAs may even close by 3 to 4 months. So putting all these things in mind, you can take a decision. And when you are taking out the device, it must be made sure that it doesn't get stuck in the tricuspid valve, because that can become a very big disaster. So these are small points in terms of procedure. And I think both the speakers have done a fantastic job in highlighting, giving us the tips of how to make this decision. My bias, I would not like to say right now. Let others also comment, and then maybe we can conclude with our strategy. Over to Swati and Nilesh, please, before we can give it to Dr. Mishra.
So thank you for revising the technical aspects, and I agree, excellent presentations by both the speakers. I'll make 2 quick comments. One is, I take exception to the first speaker saying, because I'm a pediatric cardiologist, I prefer cath device closure. I think not. I think because you are a pediatric cardiologist, you will do what is right for the patient. And he didn't say he wouldn't, but needs correction in my mind. Second thing, a little bit unrelated, but a PDA is a congenital heart defect and needs lifelong follow-up. There is no space for, oh, the device is done or the PDA ligation is done and you can come maybe for the first month follow-up and you're all set. No. In my small personal experience, I've had seen kids with rubella syndrome, not the full-blown cataract and everything, but just mild developmental delay, present 10 years later after an infantile closure of PDA by device with severe pulmonary hypertension. So do encourage parents to pop into your clinic once in a while. I'll give the mic over to Dr. Nilesh now. Thank you.
Thank you, Dr. Swati and Dr. Kothari. Thank you, first of all, to Dr. Bhavik and Dr. Tushar. After a long time, I'm seeing them on video. And both have given their perspective and regarding the strategy. Probably I want to just highlight one thing, which I understand applies to all intervention and all procedure. It is the right patient, right place, and right person. If your indication is correct, you may not be still confident in doing the procedure, hand over to the surgeon. You may have a good hands-on, but if you don't have enough facility in your hospital to back up with surgeon, anesthetic, or anyone else, then please don't proceed, because we are dealing with the small child as we are pushing the boundary. People are doing the closure even at 600 gram. It doesn't mean that what we can do needs to be, we can do it. Like, I can do it, so I do it. No, but there are certain things we have to place our boundary, that beyond this we should not go. I think this patient is particularly very high risk, and if it is done device closure, very well done. But if you can't do, there is nothing ashamed to be of this, because we cannot just neglect patients' future. We can damage the vessels. There may be limb length discrepancy and not the scar. So I think it is a difficult decision in such cases, but I understand that if you are confident, you have done it plenty, and you have a good setup, you can go for device. But if you have a little bit doubt, there is no harm in asking surgeon for favor to do the closure. Thank you.
Hi, Dr. Kamal here. Thank you, Kothari sir, Swati, Nilesh. Sir is mentor to my teacher. So sir is sir of my sir. And Swati is my school senior. Nilesh is my batchmate. So that's the other other way of looking at things. But I just wanted two important inputs from all of you, including chair persons who are present here physically. One is the APA guidelines for the same. There is a guideline from the Pediatric Association of India, and also pediatric PCSI guidelines, which talk about an age cutoff for a pediatric device closure as class 1 versus surgical closure as class 1. And second, I believe this must be the message, but I just want it to be reinforced by the panel, that for doing a pediatric intervention, you just don't need a pediatric surgical backup, you also need a good pediatric intensivist backup as well. Just quick comments from the chair and panelists on this.
Well, Kamal, thank you. These are important points, and but guidelines are just guidelines. I can't say it enough. I keep on saying this, that guidelines are meant to be just as guidelines. Neither they are legally binding nor they are really compulsory. So when you case by case is the only way to go. Especially you created a case scenario which is so difficult. Had this been a PD of 2 millimeter, has this been a child which is slightly bigger, no issue. We can follow the guideline. So I think no matter what the guidelines say, individual case decisions are to be taken by a team. And if you see into the process of guidelines are meant for giving an overview. But as you say, yes, device closure has become class 1 in guideline in general. But I have a bit of I'm always iconoclastic against the guidelines. I think guidelines are being taught too much and talked too much, and they really do not help as much in an individual case. In this particular case, I will go out and talk to my surgeon, discuss the case. It all varies with the anatomy of the PDA actually. And then I'll take the decision as already been told. I think that is my thinking. I didn't know that you collected all your colleagues. That's a great idea. And I'll ask Dr. Mishra and Swati and Nilesh to further comment on those.
I personally feel that.
Dr. Mishra, a little louder.
Yes,
yeah.
Sir, one slide. Hello. 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 I personally feel that PDA is a very simple operation, a very small thoracotomy, just 2.5 centimeter. It can be ligated very easily. But having said that, if it can be closed with the intervention without any scar and without any risk, cardiologist is comfortable, there's no harm. We are always there in the backup. The only problem is in my past 15, 20 years of experience, I've come out with the occasion where there's a coarctation or there's a coarctation which is diagnosed after 3 or 4 months of surgery. In that situation, it has become very difficult. Or say same baby 2.5, 3 kg and the device is migrated into the right pulmonary artery. Sometimes you have to go into the total circulatory arrest. It becomes such a major operation when you have to go on circulatory arrest and retrieve the device. So one should take a calculated risk in these patients. Otherwise, we are happy if they can close the device, there's nothing like that. But one should calculate the risk and then approach such patient, which is very obviously 4.5 millimeter, this device, long tortured ductus. It's not looking very deviceable to me.
Yeah, Nilesh, Swati, any additions?
Well, the device, what it looks like, it is a deviceable, but you know, as mentioned by everybody, there are the risk involved here. And if you don't have enough backup, you go for the surgery. I stick to the same place that if patient is needed and if you are confident and the place is enough to support your procedure, you can attempt. Because the advantage, particularly in India, I think for PDA device closure is the turnover. There are so many. Means I can say that you can do 10 PDA device closure, but you can't do 10 PDA ligation in a day. That is in India, particularly in that scenario. But still, we keep in the mind that we should not be playing with the life of child or any complication for child.
See, there are fewer surgeons in India than interventional cardiologists. But you see, 4.5 PDA in 3 kilo is nobody's business. That the aortic arch is going to be less than 4. So you are talking of a PDA which is as big as an arch, and then it's acute angle versus. So if you are sure that you are not going to impinge upon aorta or LPA, the anatomy allows you that, then you can consider that. And that Bhavesh has, with Bhavek's experience, he can decide that surely on echo. So it's case by case basis one can do that. Otherwise, device of PDA is a wonderful, operation. It is here to stay. I think surgeons will occasionally get a PDA to close now, and soon they will forget how to close a PDA. Yeah, we can't hear you. We are not hearing. Is it?
Yeah, I don't hear anything either.
I'll share my experience. As sir, you told, when I was resident, I used to do 6 PDAs in a day, and now we are doing hardly in 6 months 1 case. So
like that.
It's a scenario. Thanks to interventional cardiologists, they have taken over, and I think they have reduced burden of hours by not wasting time for PDA, and we can give our better time for the more complex and more important surgeries.
Right.
Thank you.
So I like to point out again that PDA gets into ICL migration very early. So remember, PDA gets ICL migration before 1 year. So large PDA needs to be closed. Now I'll just share one case where PDA was embolized. There is an 18-year-old lady who wants to be a model, and she never wants any scar. So she is insisting that I want a device. So device was done, and as luck would have it, it embolized. So we had to take it out, and it embolized to RPA. So they went and opened the right chest. By that time, the device had gone to LPA. So they had to open the left chest. And when the surgeon was trying to do that, somehow or the other, the device reached to carotid. So she ended up getting carotid endarterectomy also. So she had 3 scars instead of 1. So cases of all sorts are there, So one has to be, as a doctor, we always meet with humility and try and do best for each individual patient with consideration of everything. Yeah, that's all from my side. I can't thank Kamal enough for setting the stage and having a wonderful discussion on this.
Thank you.
Thank you, Kamal. Thank you very much.
That's all from our side.
Thank you, everyone. Thank you, Dr. Kothari, Dr. Nilesh, Dr. Swati, and our panelists who are present here physically as well. Please stay back for a group photo. Can we have the Zoom link showing the 3
Dr.
and...
Kamal, who won the debate, but?
Sir?
Who won the debate?
The patient.
Okay.
So, thank you very much. Thank you. Dr. Anil, Dr. Tarun, both our speakers, Dr. Mit Mishra, Dr. Bepota. Thank you very much. Can we have the quiz based on this discussion so that there's a learning for the online audience? We have 1,500 plus people logged in on 3 platforms that we were streaming live, which is on RX TV, Medflix, and the delegate link. So this is as per the guidelines. Again, that's the question that I asked. What does the guideline tell? And as we said, this is not as Dr. Kothari was mentioning, patients don't come, they don't know the guidelines. Guidelines only doctor knows, patient doesn't know the guidelines, so he has to be chosen according to what his status is. And this is based on PCSI guidelines, this question. Can we have the next slide? Yep, it's 2 years though. That's what, when I was doing the literature search, this is what it turned out to be. Next, can we have the reference for it? So this is the American Heart Association, and also then it was further endorsed by the PCCI, but it's an older one. This was for preterm infants, however, including the feasibility and complication. So yes, as Dr. Korari was mentioning, every child needs to be analyzed as to, but remember, this is not with PAH or edema. This is only for prevention of PAH and infective endocarditis prophylaxis. That's what the guideline talks about. Thank you very much, everyone. We move to the next session now. Thank you. Bye-bye. Bye-bye, everyone. Thank you. Our next session, yes, over to our compeer, please.
Thank you so much, Dr. Kamal Sharma, sir, for your valuable input. And now it's time to move ahead for the next session. And for this session, I would like to invite chairpersons, Dr. Bhupesh D. Shah from Ahmedabad, Dr. Abhishek Rajpopat from Ahmedabad, Dr. Atul Maslekar, also from Ahmedabad, Dr. Ramesh Patel from Ahmedabad, and Dr. Karthik Natarajan from Ahmedabad only.
Dr. Ramesh.
So, please, all the chairpersons to come on stage. And also, there are moderators for the session, Dr. Rajesh Thosani and Dr. Bhavik Darwani, Dr. Devender Sharma from Palanpur, and Dr. Kunal Tamakuwala from Ahmedabad. So all the dignitaries, please come on the stage, and I would like to request the chairpersons to give a brief introduction for the next speaker for the session. Over to you, chairpersons. Thank you.
Good evening to all. So we'll be discussing a very important topic. I'd like to invite Dr. Manik Chopra. He'll be speaking on transcatheter aortic valve implantation in this patient.
Good evening, friends and colleagues. So basically, this is valvular heart disease section, and I am here to. Can I control? Yeah. I'm here to talk in favor of TAVR, which is a better strategy for a clinical scenario which is given. So this is what all has been given to us is a 65-year-old female. She has effort angina NYHA class 3. She has a history of syncope twice. Transthoracic echo shows gradients of. Can my slides run, please? All right, so the clinical scenario is 65-year-old female, NYHA class 3, history of syncope twice, transthoracic gradients of 112 by 66 millimeters of mercury. There's normal coronary anatomy, STS score of around 3, and CT scan shows suitable lower limb and valve CT findings. Ascending aorta, abdominal aorta arc are all fine, and LCA height is around 13 millimeters. So if you see this, then this is a typical case of symptomatic severe low risk aortic stenosis, meaning by if the patient is for surgery also, this would be a low risk surgery. Now the advantages of TAVR over surgical aortic valve replacement, for which the patients as well as physicians are attracted towards this, is that you don't need to open the chest, can be done from groin in most of the cases. You do not need cardiopulmonary bypass, can be done under local anesthesia, early mobilization, early discharge, and resumption to routine activities. Now, first, since it is low risk, we need to understand the evidence for TAVR versus SAVR. So this all started with high-risk patients and inoperable patients. So it was partner cohort B and then cohort A, which was for inoperable as well as high-risk patients for aortic stenosis for a balloon expandable technology, and it proved that it works well and it is superior to surgical aortic valve implantation. And then the similar thing was done for self-expanding technology with core valve prohibitive risk and core valve high risk, in which they documented similar findings. So the stage was set in for TAVR for high risk and inoperable patients. And then it went to intermediate risk with partner 2 trial and core valve intermediate risk trial, again proving the superiority of TAVR versus SAVR at 1 year all-cause mortality. And then came the low-risk trial, the trials which are the foundation of evidence for this patients, which we are going to discuss, partner 3 trial and core valve low-risk trial. And in both these trials, the partner 3 is a trial for a balloon expandable valve, which says that in severe aortic stenosis with low surgical risk, the rate of composite of death, stroke, and rehospitalization at 1 year was significantly lower with TAVR than surgery. And for core valve low risk trial, it again, the patients with low surgical risk, TAVR with self-expanding supraannular bioprocesses was non-inferior to surgery with respect to composite endpoint of death and disabling stroke at 24 months. Now, where do the guidelines stand? This is the chart for the patients who need to be treated with severe AS, but in general, I would like to focus on one thing. This is for high risk and prohibitive risk. It is completely in favor of TAVR. For low risk and intermediate risk, the cutoff point would be, I won't go into detail of this whole chart, but in general, the cutoff would be 65 years, less than 65 years surgery, 65 to 80 years SAVR and TAVR class 1, and more than 80 years TF TAVI is class 1, while surgery is class 2A. What is the evidence for ESC guidelines? I think cutoff becomes less than 75. So 65 and 75 for American and European guidelines. Now, so this patient was a low risk patient, and this patient also, since we have evidence with both the trials, partner 3 trial as well as the core valve low risk trial, this patient would probably qualify for TAVR. And the guidelines would also support that, at least the American guidelines would support that. But when we are dealing with these low risk patients, there are few things which we need to understand. There are 2 things. One is the procedural success. So when you see a CT scan, you need to assess by CT scan what are the chances of annulus injury, what are the chances of PVL, what are the chances of complete heart block, what are the chances of mortality, and what are the chances of coronary occlusion and or need of chimney or Salker stand during the procedure. Meaning that if there is anything which predisposes the patient to complication, which makes the TAVR high risk, in that scenario, probably we need to hold ourselves, and then probably it would be more for surgery. So the aim is to give results equivalent to SAVR. So this is one thing. And second thing is late issues. The late issues are, what are the late issues? Late issues are the durability of the transcatheter heart valve. So once you do a transcatheter heart valve in young patients, we know that it should last as long as possible. So the durability of transcatheter heart valve becomes very important, and it has to be compared with the surgical bioprosthetic valves. Second is, if this patient gets a myocardial infarction, whether you would be able to hook the coronaries or no. That deals with coronary access after TAVR. Of course, when you do a surgical implantation, you cut the native valve and implant the surgical valve exactly in a similar fashion. So commissures are aligned to the coronaries. I mean, the hooking is never a problem. While TAVR valves in general are not so. So initially they were deployed in a manner in which they would be commissurally non-aligned. So in those cases, and can you be a bit more silent? Thank you. So in those cases, we would have techniques for commissural alignment, which is possible for that would be, so the techniques for commissural alignment should be practiced during TAVR. And what happens when this patient gets TAVR in future? So in those cases, again, you need to understand the risk of coronary occlusion during the procedure and possibility of accessing the coronaries after the procedure, which would be determined by the risk of plane, depth of the THV implantation, and commissural alignment. So if you look for the durability of the TAVR valves, this is the comparison, which is a 8-year follow-up. Routinely, the mean time from the deployment of a surgical valve to a redo surgery is 8 years, as per early surgical data. And so notion trial at 8 years, you would find that the surgical valves, the TAVR, I would read the conclusion in this. There are no significant differences in the risk for all-cause mortality, stroke, or myocardial infarction, as well as the risk of bioprosthetic heart valve failure. However, if you see this slide, the middle one, the mean gradients are still better with transcatheter heart valves, and the effective orifice area is also better with the transcatheter heart valves. So they do as well as surgical aortic valves. So that point is also justified. And I would now go to the idea of the risk plane. So you could see these are different valves, balloon expandable valves, lotus valve, and other valves. And the point to which the leaflets raise are the risk plane, because once you put another valve inside this, the leaflets are going to rise up to the top of the commissure. So a balloon expandable valve has slightly smaller risk plane. So if your coronary ostia is above the level of the valve frame, it is type 1, and you could easily access the coronaries even after TAVR procedure. While if it is 2A, meaning that the risk plane is higher and the coronaries are lower, then you would need some space in between the valve frame and the aortic wall to hook the coronaries, which would be called as VTA if you are going to hook it outside the valve frame, or you can go inside the frame and try to hook it. So the type 2B is where there is very little space in between the frame and the aortic valve. So these are the three types, and if you think type 1, if you put another valve in this where the coronaries are higher up, then it should not be a problem. Type 2A, there is some space, it is still feasible. Type 2B, since you are going to deploy a valve and VTA is very low, there would be a ceiling at this level. So the blood is not going to flow from the ascending aorta into the sinuses. The process is called as sinus sequestration, and there is a chance of coronary occlusion. So this type 2B patients sort of valves, and they are being simulated. So how do you go about it? So this is how you measure the VTC distance. This is the frame, and this would be VTC if it is at lower level, and VT-STJ if at the top of the frame. So in general, if the patient is less than 55, the consensus is it goes for SAVR with mechanical bioprosthesis. 55 to 65 is a gray area. 65 to 80, you simulate CT scan, calculate VTC and VT-STJ. If it is more than 4 and 2, you are good for first TAVR. And if the risk plane is below the level of STJ or the VT-STJ is more than 2, you are fit for TAVR and TAVR for the future also. So then you go for TAVR with balloon expandable or self-expanding valve. But remember, balloon expanding valve has an advantage that it has a smaller frame, so it would be maybe better. And self-expanding valve, you would also need commissural alignment. Now, if CT simulation shows that VTC distance is less than 4 and your VT-STJ is less than 2, you might have challenge in the first TAVR also. At the same time, you might have a difficult time during second TAVR. So then it's best to do SAVR during the first bioprocesses. The idea is when you get a CT scan for the first time, you should have a clear impression that you would be able to do TAVR and TAVR in this procedure in patient, at least on your analysis for the next time. So, and if the patient gets transcatheter heart valve degeneration, then what are the ways? This is, for TAV and TAV. you have to calculate BT STJ, and if it is more than 2, you are fine with it. If it is less, either you surgically expand or you are looking for basilica or some sort of leaflet modification, or chimney would be only possible if you are above the level of risk plane. So I would say, since it was being told that the anatomy of the valve is suitable, I believe that whatever I have discussed fits into this, and this patient is for that. But if it doesn't fit, which might be possible in 15 to 20% of patients, then probably this would be better treated with surgery. I rest my argument here. Thank you.
Thank you, Dr. Manik. Now I'd like to invite Dr. Priyank Bhatt. He'll be presenting minimal invasive surgical closure is the preferable strategy in this patient.
Yep. Yeah. So thank you very much, Kamal Bhai and his team, for having me here. Thank you, Manik Bhai, for agreeing to be fellow debater. Though there is no debate, we have agreed on most of the things, and we are going to agree. I'm going to kind of extrapolate or kind of reinforce the same things that you have said. We can look at this topic from two perspectives. One, what we should do, and second, as you were mentioning about coronaries and stuff, how we go about it. So the second point is moot. Some expert operator like you is not going to face any challenge in this case, which is an old 65-year-old lady, good coronaries, good anatomy. It's a moot point, technically speaking, if we can do TAVI or not. Data wise and logistics wise, whether we should do TAVI or SAVR, probably we can debate, and that's what I intend to do. TAVI is quite realistic. It's promising. It's here to stay. It's like how PAMI came into being, primary reinterventions, a few years ago, and it has really it's a big boon today. So many hearts, so many ventricles are being saved by PAMI. The same way, it's going to be a life changer, I mean game changer. But I believe it's still not ready for the young and the low risk patients. Why? Because there are some unresolved issues with TAVI as yet. Leaks, we'll go one by one. So one more thing we have to keep it in mind is that all the trials that we talk about are Western data where the average population is older. So if we were to extrapolate into Indian population, we would say if they are saying 85 octogenarians, we are going to say 75 or 70, but it's not going to cut it below, kind of. It's not going to, their 80 is not going to become our 50, right? This is just a symbolic slide where it's a review of 11 meta-analysis of 11 articles, different studies, and some are clear-cut indications for TAVI, some are clear-cut indications for SAVR, and then there are some gray areas. One important factor about TAVI is paravalvular leak. If you go in SIR-TAVI, the leaks are very high. I mean, the leak rate is very high compared to SAVR. And it keeps on it remains. Many surgical leaks, because of the partial removal of calcium or be it as may, they tend to kind of regress much more from what you see early on. Tower leaks usually remain, and why this is important is because the mortality is directly related to this paravalvular leaks, and the mortality keeps on increasing. At the end of 2 years, the difference between the mild leaks and severe leaks is staggering. It also affects the LV remodeling, which is the purpose of operating, which is the indicator of how good the surgery is or how good the gradients have come down. And if you see, the LV mass regression is quite high when you put a surgical valve compared to a TAVI valve, especially when they have the leak. Second is, of course, the implantation of permanent pacemaker, conduction defects. It is assumed that serious AV block happens in 1 in 6 TAVI patients. Surgically speaking, because we are going to be operating directly under vision, it is very rare. We in these days we hardly see the heart blocks. If I kind of rush it through, as per this 2020 article, the PPI permanent pacemaker implantation was 14% in TAVR versus 5.6% in surgical valves. Delayed high-grade AV block is an underappreciated complication of TAVI. This is another 2019 article. So there are a lot of patients who get heart blocks or which are unrecognized, or they are recognized later. And again, as we said, the heart function and the remodeling both will be affected by this. Again, this is a Sweden Heart General Registry 2021 finding that risk of PPI should be an important consideration in the modern age, especially in transcatheter operations, especially in younger patients, and especially who are lower surgical risk, which is probably our patient. Again, CVA is also very underreported as far as TAVI is concerned. There are a lot of articles where the cognitive dysfunction post TAVI was quite high in what you call rate of cognitive dysfunction was quite high after TAVI, which is and silent infarcts as well, which are kind of taken into the stride that they'll recover, and they do. But some of them do end up having long-term sequel, and embolization of calcium is certainly a risk factor in TAVI. I think many of the operators, I'm sure Dr. Manik Bhai as well, would have started putting Sentinel now more and more for this, but then it is going to add to the cost. And without Sentinel, you are always going to be worried what will happen now to the patient. This is a slide. This is a case we had done, in Bangalore once, and this is the debris removed, debris which were captured by the Sentinel device. Now, these debris are not going to go into the circulation in a sour patient because we are going to wash them off. Aorta is anyway clamped. So it is very unlikely that this bad kind of shower is going to happen in a surgically operated patient. There are some neo complications that are happening with TAVI. Any new procedure is going to come up with new problems like annular rupture, device embolization, tamponade. But probably with time, it's going to get better. Durability, as Manik Bhai mentioned, is a big issue. These valves are crimped. These are handled very, they are crushed in a way, and they are put in a patient who is already having calcified native leaflets in situ. So they are also going to impinge on the neo leaflets. So they are, sorry for this slide, this is just a photograph. I could not get the original one. But if you see on the left side is an intact neo leaflet, and on the right side is the crimped one. If you just look at it, you will realize that this is quite a trauma for the bioprosthetic valve. There are, of course, early TAVR failures with valve thrombosis, cusp ruptures, degenerations. These are accelerated because, as we discussed, the valves are crimped, the leaflets are crimped. So the TAVI valves tend to degenerate faster, and now we have better valves surgically, which are having 25 years durability in vivo, and these have been introduced in Indian market about 2 years ago. This is called Inspiris valve, which has a better diameter, and it's going to last longer. Valve in valve remains the holy grail. We say that we'll be able to do it more often, but there will be problems with device malposition, obstructions, high gradients, PPMs. So universal applicability is also a problem with TAVI. Expert operators like you are not going to have, but TAVI is not something, it's got a steep learning curve. Not everybody is going to do it, and younger or inexperienced people doing it are going to have more problems. They are going to need 2 devices, they are going to need more coronary interventions, and then it's going to add to the cost, and of course it's going to be harmful to the patient. And last problem, of course, is the cost. I am going to do 4 showers in a cost of 1 TAVI. So with the best valve available today. So it's also going to be, very, very important factor. As far as surgical, surgeries are concerned, I'm going to do minimal invasive surgery. We may even do a sutureless aortic valve, which I will just show you in a minute. So this is the my approach to the surgery. I can do conventional, but in this case, I can easily do the right anterior thoracotomy. This will be the scar for this lady, about 4 to 5 centimeters. She is not going to, the violation to the pericardial cavity or the chest, as we call, is not going to happen. If she needs another surgery, her sternum is virgin, her pericardium and her left ventricle is going to remain virgin. There are going to be no additions there. There is, it's just going to be like doing a virgin surgery again. Say we have to go in again after 5 years, 10 years, 15 years down the line for any reason. If you really compare apple to apples, we can even do a sutureless surgical valve, maybe not in this case, but a little interim or high risk case where we are going to implant something called this is what we had done about, say, month and a half ago at SAL. This is a Percival valve, which is a sutureless valve. We just need a rapid deployment. We just need 3 sutures for this. Just like a TAVI, we put the patient on bypass. We open the aorta, we implant this, and this will be a 1 or 2 size bigger valve because it is sutureless, a stentless valve, and we just come out without a problem. There are a few trials which again say the same thing. PPI implantation rates are higher. This is again a very old trial, but 5-year outcomes of the same trial were quite similar. PPI implantation was staggeringly high, and of course paravalvular leaks. Partner 3 again had what we surgeons call convenient route, that they said that a few things were non-inferior. So when you say, it's like telling a patient that हम तो ये बोल रहे हैं but फिर आप देख लो. So it's something like that. Again, partner had some limitations. The endpoints were not blinded. It excluded some patients where SAVR performs certainly better, like bicuspid or poor access. A lot of patients were lost or withdrew from the trial in partner 3, and a lot of patients were lost to follow up. So we still don't know why. And there is something called asymptomatic valve thrombosis, which we feel that it can be secondary to crimping, was not examined in this. So I would say that currently robust data for the durability of TAVI are only for 5 years. SAVR, of course, we have very, very long-term data. It is a prudent course based on the published evidence to recommend SAVR for anybody who is 65 or older and lower risk, which is our patient. So I would still say that I would do a minimal invasive right thoracotomy surgical valve replacement for this lady with the best valve available at 1/4 of the cost, and all I think less similar risk as far as the mortality and stroke and atrial fibrillation and other things are concerned, and much lower risk of pacemaker implantation, paravalvular leaks, and other neo complications. Thank you. Yes, please.
I think the durability issue is almost settled. And regarding the crimping and non-crimping part, the trials were all done with crimp valve. So if they prove that they are going well for 8 years, probably we have got to accept it. Regarding the subclinical liquid thrombosis, it also happens in the bioprosthetic tissue valve as well as surgical valves. And then regarding the issue of pacemaker, I think most initial time you've shown as correct, but now it is different. It has come down. The PVL part was from Sataric plan, that's again expanding plan, initial plan, that also has come down. And maybe and this, 65 years probably, as I understand, 75 to 80% of the patients on CT analysis would probably be okay for a TAV and TAV procedure also without any issues, in which you would be able to go with TAV and TAV. And your data says that probably TAV and TAV is almost better than TAV and SAV. Of course, these TAV and TAV patients didn't include the patients who the TAV and TAV is not feasible. So these are some new things, and probably Abhishek, you can add some more.
Yeah, indeed, it was a good discussion, I must say. Priyank bhai, I got to know about certain things, and I am a TAVI guy, so I would not just be biased. But our surgical colleagues, most of the time, the surgical aortic valve used more than 90% time is 19 or 21, and that's the bench ID. So the true ID is somewhere around 16.5 to 18.5. So most of the time, our what we feel as a TAVI operator once we see the different CT scans, that as a surgeon, you should also integrate a CT into your understanding. Because you might end up putting a bigger valve, you might change your threshold to go for annular root dilatation procedure, and eventually not discharging a patient with a moderate aortic stenosis. So that's the thing what we want to say. Dr. Manik has already mentioned about the TAVI and everything. There's a second generation device. The learning curve was different. So I don't think so. It's a good idea to extrapolate those data into the current era in the 7-8 years, because with the partner 3 trial, there were pacemaker rates and everything matching well. And as far as the Sentinel device and cerebral protection device is concerned, the stroke is equally known complication post-surgical AVR. And subclinical infarcts are even known after coronary angiogram. Even if you put something inside the ascending aorta, you end up having something in the silent infarcts in the brain. But indeed, yeah, with the TAVI, we have option of cerebral protection, which you might not have post-surgery. But if we work together as a surgeon and a cardiologist, as a heart team, we can offer best to our patient, what is good for the patient. And learning CT, I recommend every cardiologist, the way you are learning to do an angiogram analysis. If you are looking to treat a valvular heart disease patient, CT analysis learning should be a part of your training, your curriculum, because I got to know that some surgeons are hesitant to put a bigger valve because even the coronary obstruction is a non-complication after surgery as well. So some surgeons are hesitant for that. But indeed, because you are seeing the valve after the area after going on a pump, so it's all flaccid, you don't know what's going to happen. But if you do the CT up front, you know that, okay, once I will just start the blood once again, this valve is not going to have any obstruction to the coronaries. So I think, evaluating the patient as together and integrating a CT analysis as a part of the decision as a surgery versus TAVI should be more important, I guess.
Certainly, I'll just tell you 2-3 things. One, totally agreed. But the newer devices, as the technology improves, a TAVI valve, it's certainly going to improve a surgical valve as well, isn't it? So what the first generation valves, what we used to put, say I have put a 19 Hancock. Today, if I put a 19 Inspiris, it's going to be, at least maybe 33% bigger internal orifice. Then so that is one. Second, when you have as a TAVI guy, you have the option or the facility of Sentinel. But for me, when I debride or when I decalcify annulus, the aorta is cross-clamped. So at that time, nothing can go into any circulation. It can only come out. So if of course, there is a chance of stroke. As you said, if I am cannulating the aorta from there only, it can have a stroke. But from these debris or from these small calcified leaflets where we know they are bad, we know they are prone to it, it is it is much less likely or much less possible for them to go into.
But I would say, I have come across the surgeon who had to close the chest after opening because they didn't see what is happening in the ascending aorta. They could not see that on the echo. So I'm not going individualistic on that.
100% agree.
Rather, if you learn analyzing the CT, you can decide your clamping site also. This is the atheroma free zone.
Certainly.
Right? Integrating the CT is most important for decision in aortic valve.
For the minimal invasive surgery, we used to have something called endoclamps, where it will go inflate itself in the ascending aorta, and we don't have to put external clamp on it. But counterproductively, it had more stroke rates because it was being inflated inside. So the point is, we are not going to, run away, or we are not going to be able to hide from the stroke.
Yeah.
But probably because of the technicalities of the surgical valves, the rates may be lower.
And I guess
maybe.
yeah.
But yes, of course, with the devices and all.
Yeah,
I think. But then it's going to add to the scheme patient costs.
Yeah, indeed. So, working together helps us. And
Sure,
just one
that
last
is a
comment.
given.
Even the Percy valve has a higher conduction disturbances problem as compared to your routine surgical valves because you are putting it
Because again,
much
we are
bigger.
putting it, no, we
Just
are
like a
putting
TAVI.
bigger valve in the calcified. We are not decalcifying that annulus.
Yeah,
anyway.
so I think
Yeah, so-
cumulative decision helps.
So there's one thing I'd like to ask Dr. Manik and Dr. Abhishek, like, what is, if you compare a surgical, say, bioprosthetic valve and a mechanic transcatheter valve, what is the average durability of the two valves if you compare both?
See, these all durability data what you get from the company, they are basically the bench testing in vitro.
Okay.
Inspiris, like Dr. Priyank said, 25 years. The valve is launched like 4 years back, right? So indeed, you can never know. Second thing that a factor is also the age. You put a bioprosthetic valve in a younger age, that's going to degenerate faster because this patient put a more robust immune response to that. That's also one factor. So, but as far as the data we have limited, that is only from partner 2A and all those things, because earlier the valve used to overlive the patient. The patient used to die before the valve because they were a very old patient. So now with the data we are getting is from the Notion and the lower risk trials. So, but as long as these things are concerned, we do have enough data to say that the durability of TAVI valve and aortic, the surgical valves are still matching as of now.
Okay.
Of course, the end result was similar for surgery as well as for TAVR, but in subgroup analysis, you can see that the effective orifice area and the gradients were much less in transcatheter aortic valves. So, in fact, they are doing better than surgical aortic valves. The only catch is that Notion had all self-expanding valves in their group. The partner trial has balloon expandable valves, and probably I'm not sure about the data, but I think it should be doing almost similar things. So the durability part is similar, and the data which comes from US says that the mean time from deployment of a bioprosthetic valve to a redo surgery or to point where it reaches a redo is 8 years. So it is from the surgical side. So 8 years is the mean number. Come what may say, companies, all the companies, including surgical valves as well as transcatheter, would make tall claims. But finally, it is 8 to 10 years. It might be earlier in patients with CKD and others. And with patient processes mismatch, it might be, sometimes it might be 15 or 16 years. But on an average, I would say if you do at 60, expect at 70. If you do in still younger patients, expect still earlier. Because it would degenerate still. And surgeons have implanted bioprosthetic in younger patients and they have seen the same thing, I think.
Theoretically, a third time is also possible. Say it degenerates after 10 years, you do once a valve and valve.
So if your coronary heights are above the level of valve frame, and if your diameter is good, first you put, maybe if it is 26, then it is ready to take another 26 and then 24.5. And then probably even fourth time you can put a evoluta, so that you can decide on CT scan. But for sure, one TAVR, and mostly TAVR and TAVR, 80% of times TAVR and TAVR is at least CT scan by it's feasible, 20% not feasible due to the coronaries below the level of wrist pain and VT-STJ less than 2. And these planes, I mean, you may have leaflet cutting technologies, modified basilica and other stuff to support it in coming days, or maybe a chimney stent above the level of our wrist plane going like this and helping out. So there are ways, but those would be difficult subsets. Of course, shorter frame would be better. Taller would be longer because then the wrist plane increases. And you can deploy it slightly deeper if you think that you can get away with the coronaries.
So the story comes back to the CT analysis. If your first cut is deepest, you take a right decision on a first valve, because believe me, taking out those TAVI valve for a surgeon can be a nightmare, especially if it is a self-expanding.
I was about to say that.
Yeah.
That your comment that heart team comes into picture.
Yeah. So
here,
your first cut should be
if
deepest.
you have selected the patient first time correctly, then probably he will outlive at least the second procedure.
Yeah. And TAVI is more of a cerebral procedure than a cerebellar procedure. In angioplasty, you are working in millimeters, you are working in centimeters. Obviously, the hemodynamic differences are going to make a difference of your temperament when you are doing it. But believe me, it's not a very cerebellar procedure. You need to learn CT and plan it accordingly. There are ज़्यादा hands on का कोई ज़्यादा role नहीं है. You just need to plan it and have some temperament what's gonna happen. Anticipation, anticipation, anticipation. That's how it goes. So the first CT analysis is the ideal thing for your patient. What should be offered to this?
No, almost. I mean, I would agree with him with that part, and I would also agree with that part that probably CT scan should be part of analysis for patients for AVR, because then if you have a very small annulus, for example, on echo, you might find it different because you are measuring it under the short axis. It might be slightly larger on CT scan. So that way you are ready for, and maybe you are also mentally prepared for root enlargement.
Even the families, because as if I have to do a root widening, they are going to have, I mean, it's a
root
complicated
enlargement,
procedure.
venters,
They are
and
going
all
to
those
have higher
things,
chances of
you
PPI. They are going to
know.
have higher chances of bleeding. So all these are also there. And just to finish, I think we are also now very much concerned about the durability of valves as surgeons, I would say, and then we are really reconsidering, especially in mitral position, the bioprosthesis. This is little out of context, but right now we are not strongly but quite vehemently not recommending it, especially with fibrillations, atrial fibrillations.
Your point is well taken, and there is a joke why surgeons support a cardiologist for TAVI, because when they promote TAVI, you actually end up getting a tissue valve at least. So for that. So that's on the lighter note. But because when you explain 20 lakhs, they are easily able to do it in 5 lakhs. So that's one. Other thing I just wanted to ask the panel and discuss the whole thing as to what would make you think of a sentinel device, an arch protection device in a patient. Would a previous stroke be good enough if you could doubt that it's because of an AFib? One, or second, is the arch atherosclerosis documented by, say, carotid intima media thickness or RCT angiogram, or a presence of pre-existing carotid artery disease would be enough to make you choose a sentinel or cerebral protection for the TAVI?
Carotid stenosis, rather my filter will be below the bulb and all most of the times, and not necessarily, at least not on the my first one it's in brachiocephalic. So carotid stenosis is not going to give any protection. Arch atherosclerosis and everything, it's a debatable factor because you are anyways manipulating your sentinel inside the ascending aorta. When you are doing it, you technically carry a risk of dislodging it. Instead, the ostial carotid disease is a relative contraindication where you don't want to touch it. So my patients who has who get a sentinel one is Wallin valve, where they have a very bad degenerated leaflets. Indeed, a cryptogenic stroke in the early period of which could not be explained. So in the notion data, 2/3 of the stroke happen after the procedure in the 6 hours to 48 hours window. So keeping the patient heparinized in a post-procedure period is equally important. So of late, I have stopped using protamine unless there is some obvious bleeding coming out of the groin. So Wallin valve, previous stroke, and super calcified aortic leaflets. These three subset I promote. I prefer to use sentinel in such patients.
So I would also, one thing I would like to add, and you should try encouraging patients to use for Inspiris Resilia if possible, because one, theoretically they say that tissue is better, and second thing is that there is a possibility that you can expand the valve frame without fracturing because it is expandable. So 19 can go up to 21 or 22. So in general, your patient processes mismatch is going to decrease in future with TAVR valves because you can stretch them. And regarding the sentinel, there's no clear consensus. In general, I would say that you do a coronary angiogram, you find a 80% lesion. As a cardiologist, you would probably intend to stent the vessel despite the patient not having chest pain. Similarly, with the TAVR, if you 99% times you catch something in filter, and when you see it, you tend to advise sentinel, saying that this debris won't go in, but we don't know how much helpful it is. But valve-in-valve patients, calcified bicuspid valves and other supercalcified valves, I would probably be more useful. And also, the calcium debris is mainly due to valve predilatation and manipulation of the valve rather than the atheroma part in the arc, because that would be there with any of the procedures. And you, when you're putting a filter, you have to balance the time spent in putting the filter, because that would be more prothrombotic manipulation that would displace the plaques and versus the protection that the filter is giving.
The biggest advantage with Resilia is if the patient forgets the surgical record, you can get to know what size valve it is.
No, that's why I was about to say that, and I'll probably end with this, that yes, sir, we must put more and more Resilia as surgeons. So your patients who can't afford TAVI, we are ready to put Resilia in them, please. Yeah, including myojna, doesn't matter. Yeah, if they are going to them, they are not myojna.
No, whatever is good for the
Yeah,
patient
yeah,
should be
I
done.
know,
Yeah, thanks.
Just, yeah.
Apart, while doing we have less experience in TAVI. We have done at least 12 to 15 TAVI in our institute. But we are operating aortic valve replacement since long. Apart from routine hemodynamic monitoring, while handling this heavily calcified valve surgically or doing TAVI, we prefer one more monitoring, that is NIRS. So while handling, we cannot prevent neurological events, but we can monitor it. So we are in preference to monitor it, NIRS.
I think aortic valve, mostly aortic stenosis and that kind of pathology, very difficult as far as induction is concerned, because there are high chances that patient get crash and it's a fixed cardiac output situation. So you cannot take the patient lightly. Everything is ready then and then. And one thing I want to tell that cardiologists should always have a backup for the surgery. Surgeon don't have the backup. So they are the...
Oh, we thought we had backup of anesthetists.
Yes, that's right. Because we are always...
Yeah, exactly. Yeah.
I mean, and that is true. I mean, you cannot have a TAVR program without
Yeah.
surgical backup in the institute, at least for the time being. And I think that would be the right way to go, because once in a while you might need it theoretically if the patient crashes due to any reason. Yeah, and maybe, I mean, it helps also sometimes if there is LV perforation due to wire and other stuff, they might be of help. Annulus rupture, I'm not sure how much they would be able to help.
Mostly it's a team approach, and you have to share the stress and fun, both the things.
And I think they should join us in procedures so that they start learning it, and probably if they learn it, then probably I think it would be also good for them, and since they can understand both the things better, so they would be more broader in selecting the patients who could be taken for TAVR.
I think mostly the anesthetist is more comfortable after transesophageal echocardiography, because so many things we can work out with that. If patient is getting difficulty in off bypass induction, something new findings we are getting. So T is very, very important. It's a one kind of our junior assistant.
But it would require some sedation or some sort of anesthesia, because else it would be discomfort.
No, he's
Okay.
surgical.
So sorry.
Okay.
Thank you.
Thank you,
all the speakers. Very nice presentation. And
Thank you so much, Dr. Manik Chopra, Dr. Priyank Bhatt, and Dr. Kamal Sharma for your valuable input. Give a huge round of applause, each one of us, for making this session very, very interactive. And now, yes, sir, mic is there. Yeah. It's working. So.
Downstairs we have gala dinner after one debate of mine which is remaining. So please join us downstairs, and then we have singing and karaoke night and gala dinner. All of you please join us downstairs, please.
All A. Yeah.
We had 800 plus logins for this live session. So just giving you a 800
Round of
plus.
applause,
Yeah.
yeah.